Hello, hello, hello. Okay, okay. Hey, hey. Okay. Hello, hello. Okay, okay, okay.
trial, trial,
Hello,
trial, 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 trial,
नहीं यहीं से बंद है हेलो हेलो
hello,
हेलो ये सर आ रहा है आपके पास अच्छा ठीक है हेलो
hello, hello. Yeah,
गुड मॉर्निंग डॉक्टर डूडो गुड इवनिंग
hello, hello. How are you?
या we'll take another few minutes before we start please it's little late for you in Boston but still please thank you
Oh, hello.
Good morning, everyone, and a very good evening to Dr. Duda in Boston, USA, and other delegates who may have joined in different parts of the world online. Appropriate greeting to them. Welcome to the fourth edition of the Jaipur Surgical Festival, which is an academic activity that we started here at the Mahatma Gandhi Medical College and Hospital, which is a unit of the Mahatma Gandhi University of Medical Sciences and Technology in Jaipur in the state of Rajasthan in India. Just a brief overview of our institution. We are the first private medical university in the state of Rajasthan. Uh, we have 8 constituent colleges, including medical college, dental, nursing, occupational therapy, physiotherapy, hospital administration, health informatics, and various other allied health sciences. And in the next few years, which includes our Silver Jubilee year next year, we plan to introduce a Faculty of Management Sciences also. The medical college offers courses uh, at various levels, including graduate, postgraduate, and super specialty courses, which are equivalent to the fellowship programs in the US. In almost all specialties, subspecialties, and super specialties, which are identified in the list of the National Medical Commission, which was erstwhile called the Medical Council of India. The fourth edition of the Jaipur Surgical Festival theme is complications in surgery. We thought that it is our duty and responsibility to cover this topic because unfortunately, this topic is not covered or not paid so much attention in the usual meetings and conferences because people are reluctant to talk about their complications. But we know that whenever we do a procedure or an operation, complications are going to occur, they do occur, and they will continue to occur. So it's very important for our young colleagues, the students and the young practicing surgeons to know about them and to know as to how to manage them. The previous 3 Jaipur surgical festivals, the themes were safe cholecystectomy, hepatopancreatobiliary oncology, and we also did a close group meeting, international study group on gallbladder cancer, emphasizing the problem of incidental gallbladder cancer. And I'm happy to inform that 3 or 4 of the subgroups of the last year's meeting, they have completed their manuscripts of the reviews on the topics allotted to them. And these manuscripts are under the process of submission to various journals for publication. In addition, we also did a IASCO postgraduate course on jaundice, and I am happy to inform that all these academic activities have been held under the auspices of and have been endorsed by the International Association of Surgeons, Gastroenterologists, and Oncologists, IASCO. And as you can see, Dr. Duda, who is the honorary secretary of IASCO, has joined us from Boston online. Dr. Duda is a, excuse me, radiation oncologist who is also involved in a lot of translational research. And as I mentioned, he holds the position of the secretary of the IASCO. And once I finish the introduction, we would have him say a few words about our collaboration. In addition to Jaipur Surgical Festival, actually Jaipur Surgical Festival is an offshoot of Jaipur Surgical Tutorial, which is an online education portal that we started more than 3.5 years ago, and which is being managed by my colleague, Dr. Anand Nagar, who's with me as professor of HPV surgery and liver transplant. And under the auspices of the Jaipur Surgical Tutorial, we conduct an online teaching class every Saturday, 9 to 10 a.m. India time. And I'm happy to inform that we now have almost 1,000 members, students and faculty, including about 200 from outside India, uh, who attend and then watch these activities online. As an extension of the Jaipur Surgical Tutorial, we also organize a monthly, once in a month masterclass on a single theme topic. 16 such master classes have been held in the last almost 1.5 years. This is done every Wednesday and Thursday of the month, 7 to 9 p.m. India time, 2 hours on Wednesday and 2 hours on Thursday. The next master class at the end of this month is on corrosive esophageal injury. We are going to announce it soon. In addition, Anand also helps me in conducting what we call a Jaipur cholecystectomy coaching, where we contact a surgeon from whom we have recently received a referral for post-cholecystectomy bile duct injury. And we request them to participate in a one-to-one session with us, me and Anand, where we discuss that particular case and their past experience with lap chole and try to kind of educate the surgeon as to why this injury occurred, how he or she can avoid it in future. And as a gesture of their participation in this interview, which of course is a pure academic exercise, the data is entirely anonymized and confidential. We send a copy, complimentary copy of my book, Safe Cholecystectomy A to Z, to the surgeon. Uh, we also do offer in a service called Jaipur Paper Clinic, where I encourage young students and young surgeons that if they are writing any abstract or a manuscript, they can send it to us. I try my best to polish it as much as I can before they submit it to a journal for publication. As a educational activity for the lay public, we conduct what we call a Jaipur Swasthya Charcha. It means the Jaipur health discussion, where we go to any school, college, university, organization, or department, and we discuss a topic which they want us to discuss. I take a panel of experts related to that topic, and in about an hour session, uh, we discuss the public health related aspects of that topic. We've already conducted more than 50 such sessions in the last 1.5 years. We also propose to start an activity called Jaipur Surgical Gurukul. This has been in my mind for quite some time, but for various reasons I have not been able to start it, but hopefully next year. We would invite students, especially those who are going to appear in the final exam, and more so those who have failed in one or more attempts, and give them intensive coaching to prepare them for their exit exam, when they stay with us, say for a few days or a couple of days. And I am happy to see my colleague, Dr. Raj Govind Sharma, who is the Chief of Surgical Oncology, in the audience. They have been doing this activity for last almost 2 years, which is very popular. Uh, a large number of students from the state and adjacent states come and attend this activity. I have to add that although the Jaipur Surgical Festival is organized by the Center for Digestive Sciences at my institution, this center includes all four departments: medical gastroenterology, surgical gastroenterology, hepatology, and HPB surgery, and a liver transplant unit. In fact, we are a unique institution in India where in the same institution, all four departments exist as independent units, and we offer fellowship training program in all these four specialties. So while the academic activity is conducted by the Center for Digestive Sciences, the technical support is provided by Gastro University, which is an online portal run by my former fellow from Lucknow and now a consultant GI surgeon in the city of Ahmedabad. And his technical team, Dr. Avinash Tak, his technical team offers all the technical assistance. Just a word that the faculty of the JSF may feel that the audience in terms of delegates is limited, but I have seen that that is the usual trend these days in most meetings and conferences. In fact, even in JST or the master class, we find that the students who are joining live, the number is small, 15, 20, 30. But next morning, when I look at the YouTube channel of Gastro University and our university, I find that hundreds of students have viewed the video overnight. So probably that is the trend. The students these days don't want to be bound down by us as far as time and venue is concerned. They want to watch and learn at their own convenience, at their own pace, at their own time. So I'm quite happy about it. I request all my faculty colleagues not to get disheartened by the small attendance. Your efforts, your time is valuable, and I can tell you that it is being valued by students even now. Almost 10, 15 minutes ago, I received a lot of messages from JST students that they have logged in and they are waiting for the proceedings to start. So whether they are in front of us or whether they are remote from us, I assure you that your efforts, your time is not going waste. And in fact, I just looked at the Gastro University YouTube channel. The first JSF, the maximum number of views that we have had so far is almost 3,000. And all the master classes, the number of views range from a few hundred to even more than 1,000. So with that in mind, I'm going to announce that the fifth Jaipur Surgical Festival probably would be a pure online mode, but we request the faculty to come to Jaipur so that you can interact with each other, with us, see the city. So we will be here, we will interact with each other, we will generate the discussion, but I think the delegates, the students would be online, whether they want to watch it at that time or later. So we will probably change depending on how the world of teaching and education is changing. So with that, I would like to thank everyone. We have faculty colleagues from Nepal, we have a colleague from Japan, we have a colleague from Bangladesh, we have delegates from Tanzania, Cambodia, and uh, one or two foreign faculty and delegates just last night, they informed me that they are not able to come. We will have a few delegates from India also. But as I said, that the total number of delegates, including online delegates, would be much more than this. So with that, I would now invite Dr. Duda, who, as I mentioned, is a radiation oncologist, but also a translational scientist. And he's with us today for us in the morning and for him in the late evening because he's based at Boston, the Harvard Medical School and Mass General Hospital, and he holds the position of the Honorary Secretary of the International Association of Surgeons, Gastroenterologists, and Oncologists. Welcome, Dr. Duda, please.
Yes, good morning. Good morning. Good morning, everybody. On behalf of the International Association of Surgeons, Gastroenterologists, and Oncologists, IASGO, on behalf of President Mohammed Abdel Wahab, of my co-secretary general, Professor Kyoichi Takaori, we're really delighted to welcome you to the fourth Jaipur Surgical Festival, which is being organized, as you heard, by the Mahatma Gandhi Medical College and Hospital this next 3 days. I greatly enjoyed myself participating in past meetings, and I really regret not being there with you, but I'm sure this year's meeting will be equally exciting and successful. A few words about IASGO. IASGO was founded in Amsterdam and the Netherlands in 1988, and is really a unique multidisciplinary society with the aim of globalization of the best medical knowledge and practices. IASGO encourages surgeons, gastroenterologists, and oncologists to join forces to realize the mission of IASGO worldwide. Millions of people worldwide die from treatable conditions due to lack of routine surgeries and care. Moreover, the major breakthroughs that have transformed medicine over the last decades do not reach sometimes the patients at a global scale, in part because of lack of knowledge. So IASGO's vision is that up-to-date medical knowledge and expertise could and should benefit all communities globally. It has to be available beyond any discrimination based on individual, institutional, and national level to every patient who strives for survival because of challenging and life-threatening diseases. The mission of IASGO is to provide excellence in patient care by administering the highest quality of service in a safe and compassionate environment. IASGO leadership strives to implement this vision through a well-structured educational program with a global reach. We're teaching and promoting multidisciplinary collaborative approaches for treating this very difficult to treat diseases. This year, we actually celebrated our 35th annual World Congress in Cairo, Egypt, and we also held over a dozen CME symposia with large participation worldwide, and we're, of course, very happy to be back in India. In addition to communicating the latest clinical and scientific developments, friendship and collaboration are also vital in carrying out the mission of IASGO, which is globalization of medical knowledge. This fourth annual JSF meeting is another excellent opportunity to meet old friends and make new friends. We commend the remarkable efforts of Professor Kapoor, who has spearheaded the efforts to implement the YASGO programs in India, as you've just heard. Along with a dedicated organizing committee and strong institutional support, he created one of the highest level programs, including international experts from Asia and all over the world, and also promising young fellows. This will lead to networking and cross-fertilization among experts at various stages of their career and the diverse interests to promote further collaborative projects at an international level. Professor Kapoor has actively involved in YASGO for more than a decade, including participating at YASGO World Congresses in Bucharest, Vienna, Fuzhou, Seoul, Moscow, Taipei, Istanbul, and Verona, as well as multiple symposia such as those in Beijing, Belgrade, Cairo, and Chiang Mai. Before that, he was the guest editor of the special topic on gallbladder cancer in the YASGO official journal in 1999, which included experts from all over the world. He also organized an YASGO course, as you just heard, on jaundice in March of last year, which was attended by our past president, Professor Ender Dulundu. Finally, Mahatma Gandhi Medical College and Hospital Jaipur launched, as you heard, the International Study Group of Gallbladder Cancer, ISC-JBC, on the lines of the International Study Group of Liver Surgery, International Study Group of Pancreatic Surgery, and International Group of Rectal Cancer. The aim of this effort was to produce a series of consensus statements on various aspects related to gallbladder cancer. And of course, given its relevance and implications, YASGO has fully endorsed this effort of the ISG-GBC. And I'm really delighted to hear that 3 of the manuscripts are already prepared for submission, and want to congratulate all the people who have been involved in this wonderful effort. This year's JSF theme is the complication in surgery. Most sessions are related to surgery, gastroenterology, and oncology, and feature key local and international experts. We are delighted to endorse this symposium, which is becoming a wonderful tradition for Indian experts and the ISGO. I would like to end by welcoming you again on behalf of the ISGO to this meeting in Jaipur, a celebration of the latest medical and scientific advancements in gastroenterology, oncology, and new treatments. Thank you very much for your attention. I wish you all a productive and enjoyable meeting and look forward to seeing you next year.
Thank you, Dr. Duda. That was Dr. Duda, the Honorary Secretary of the International Association of Surgeons, Gastroenterologists, and Oncologists, joining us from Boston in US, although it's a very late evening for him. Thank you, Dr. Duda. I'm also happy to see Dr. V. Sitaram, one of the senior most GI and HPB surgeons of the country. Actually, we wanted to invite and honor him at this meeting, but because of some personal and family reasons, he was not able to travel, but he said that he will join online. I am happy to see Dr. Sitaram. Thank you very much for joining. In fact, Dr. S.K. Mathur, another very senior surgeon, he also said that he will be joining online, and probably Dr. Shastri also will join. I request all these senior members to please contribute to the discussion, because most of the sessions are in the form of panel discussion rather than didactic presentations. So I request Dr. Sitaram and other senior colleagues who would be joining online to please chip in and offer your valuable experience and wisdom to the young participants of this meeting. So with that, we would start with the scientific program. Rajiv, you are going to? Yeah. So my fellow, Dr. Rajiv Patil, he will conduct this scientific program. Thank you all.
Good morning, everyone. A warm welcome to 4th JSF, Jaipur Surgical Festival. And we'll begin our session with the first topic on definition and classification of complications. And do complications affect in long-term survival? I'll be calling upon Dr. R.P. Chaube, former professor and head of the Department of Surgical Gastroenterology at Mahatma Gandhi University of Medical Science and Technology, Jaipur. and to chair the session. And with him, I'll be calling upon Dr. J.M. Mehta, Senior Consultant in Surgery in Narayana Hospital, Jaipur. And for the discussion, I call upon Dr. Rajiv Panwar, Associate Professor of GI Surgery and Liver Transplantation, AIMS New Delhi, and Dr. Avinash Tank, Senior Consultant Gastroenterologist at Apollo Hospital and the Dwarika Hospital from Ahmedabad. Dr. Mehta.
Right. Good morning, ladies and gentlemen. It gives me immense pleasure to start the scientific proceedings of this fourth JSF. My colleague, Professor Mehta, has not been able to be physically here because of some reasons, but I can see a lot of my old friends. Bhatta is here, TD is here. So without wasting any further time, I start this session and request Dr. Rajesh Panwar to come and deliver his talk. Dr. Rajesh and me, we share the alma mater. He is assistant professor in surgical gastroenterology. I'm not sure, assistant now, associate professor of surgical gastroenterology at All India Institute of Medical Sciences, New Delhi, where I was trained way back in 90 to 92. So I request now Dr. Rajesh.
Thank you, sir. First of all, I would like to thank the organizing team, and especially Professor V.K. Kapoor, for inviting me to this talk. Theme of this JSF is complications, and as Dr. Kapoor pointed out, this is one topic which is often neglected in usual conferences. And this also is a topic which is close to my heart. I have done some work in this regards. So I hope I would be able to do justice in the next 15 minutes. So the topic for my talk today is definition classification of complications. Let's start with the usual surgical audit of an institute. There are two different surgical units. Surgical unit A both did around 1,500 cases in the year. The unit A reported a mortality of 5% and complication rate of 40%, while the unit B reported mortality rate of 5% and complication rate of 70%. So who do you think So who do you think performed better? It seems like that unit A performed better because it had a lower complication rate. But are the two audits comparable? We don't know how they defined the complications. So it is important to define the complication. You came out with a number, but how do you know that number is comparable to some other number which some other person is quoting? And why do you need to define? Because if you define a complication, you are likely to pick it up early. and that will increase the patient safety. It also helps in training and education of the surgical residents, because if they are able to identify complication early, then obviously they learn how to manage those complications. And it is an important outcome measure for research, because if you want to do comparative analysis, then you have to and it's an important outcome measure for research, because whenever you want to compare, you have to have identical definition. It is an important benchmark, because something that if you achieve a complication rate of 10%, that is the benchmark you want to achieve. And that can only be defined when you have a proper definition of a complication. And then your own quality improvement. You want to improve from year to year. Last year, say your complication rate was 30%, next year it is 20%. So you're improving day by day. And you have to have a measure to know that. You have to measure complications effectively to achieve that. So what is the definition of a complication? As it can be simply defined as any undesirable, unintended, and preventable outcome of a surgery which negatively affects the patient's health. In other words, you can simply state that any deviation from a normal postoperative course is a complication. Now, some people differ in what complication means. Some people say that it is only the technical part of the surgery which is leads to complication. Then only it should be called complication. However, for all practical purposes, any post-operative outcome, whether it is related to surgical technique, whether it is related to the patient, anesthesia, or any other factor, it should be termed as complication. So no matter what, if a patient developed stroke in the post-operative period, even though the patient had the risk factors, but it develops after your surgery, then it will be called a surgical complication. But it is easier to define a complication if you can define a normal postoperative course. A normal postoperative course for me, for a patient of Whipple's, would be say that I want to discharge the patient in say 10 days. Another person says that if the patient is not discharged by day 7, it is not normal postoperative course. So people may have a different definition for a normal postoperative course. Once you have a definition of normal postoperative course, you can easily define a complication, because any deviation from that course will be a complication. But is definition enough? So you say the complications is occurred and you have defined. So the same example, now both the units are using the same definition. They are defining any deviation from the normal postoperative course, and they have defined the normal postoperative course as well. And now unit A has a 60% complication and unit B has a 70% complication. Now can we say that unit A is better? Let's see. Does severity of complication matter? So mild versus moderate versus severe. Does timing, intraoperatively, early postoperative, 30-day, 90-day, late? Cause of complication will not matter that much further, but obviously for classifying it may matter. So complications can be further classified based on their severity, timing, system affected, and cause. So all these factors may be used to classify. So now we go back to the audit. Now they have ticked all the boxes. They have defined the complications. So in unit A, there were 20% mild, 20% moderate, and 20% severe. And in unit B, there were 50% mild, 15% moderate, 5% severe. Now we can say that unit B performed better than unit A, even though the complication rate was higher in unit B as compared to unit A. Now we have reached somewhere. So we have understood that a standard classification system is required if you want to compare outcomes. So are there any standard classification systems? First of all, these are the attributes. It should be simple. So if you give a complex system to people, they are unlikely to adopt. It has to be simple. It has to be objective. What I measure, the other person also should be able to measure the same. If I say it is a severe complication, other person should be able to say that it is a severe complication. And incidence has to be measured. So you have to count the percentage of the complication in a group of patients. Severity has to be assessed. So it is not enough that complication has occurred. You have to tell whether it is a mild, moderate, or a severe complication. And ultimately, if it is possible, you should be able to assign a score to a complication. Like you can say, out of 100, this patient had 30 complication or morbidity. 30 is the score that that patient got. So this, whether we have achieved that level, we'll see later. So there are already some standard classification systems. The most commonly used Clavin-Dindo, we'll see all them in detail. And all of first two are based on mild, moderate, severe. Next two, comprehensive complication index, and these are scoring systems. All these are based on the one seminal paper that we'll report later. And there are some standardized definitions of specific complications. Suppose you want to measure a specific complication, you want to decrease postoperative pancreatic fistula rate. How to do that? For that, you have to define what is postoperative pancreatic fistula. So there can be separate definitions for postoperative complications, and those can be compared. So this was a seminal paper. Both Clavian and Strasberg were a part of it. They defined, gave a T92 system of classification. Previously also people try to define, but this was the one paper that forms the basis of all further classifications. So they defined mild, moderate, severe, and they defined on the basis of how you are going to treat the complication. If your complication is self-treated, that you don't require any treatment, then it is mild. If it requires some management in the form of medicines, then it is moderate. And if it requires invasive procedure, it will be a severe complication. Grade 4 will be death. So this was the initial paper. And based on this, the landmark publication from Clavian in 2004, Annals of Surgery, they further refined this and put forth the currently most commonly used system, the Clavian-Dindo classification. So it was developed initially in 92 and then modified in 2004. The purpose was to standardize the assessment and reporting of postoperative complications, and it will facilitate comparison across the studies, and grading is based on type of intervention. So this is the original classification. I'll make it simple for you. So grade 1 is when it is self-limiting complication, no treatment is required. Grade 2 is when only medicines or pharmacological treatment is required. Grade 3A, if a procedure which can be done under local anesthesia. Grade 3B, if procedure under general anesthesia. Grade 4A is single organ failure. Grade 4B is multi-organ failure. And finally, grade 5 is death. So this is a simple ordinal scale which can be used to classify complications, and it has been extensively used. This paper has been cited more than 3,000 times. Based on the T92, Strasberg also was part of T92 classification. So he gave his own version of classification called the accordion classification. So this essentially is almost similar, but not much used. It has two forms: contracted forms, which has only 4 parts, and then the expanded form, which has 6 parts. It is more or less similar to what proposed by the Clavian-Dindo classification. So then the definition of individual complications, like the International Study Group of Pancreatic Surgery, they have defined pancreatic fistula, delayed gastric emptying, and post-pancreatic hemorrhage, all have been defined. So these are the standard definitions. You can define for every study, whatever the most common complication of that surgery is, you can define that complication and use it to compare. Now, if you see papers on delayed gastric emptying, you can find 100 different classifications of delayed gastric emptying. So if you have so many classifications, you cannot compare one study to the other. So for example, somebody defines delayed gastric emptying as, if NG is there on the day 4, it will be DG. So incidence will be high. So in such studies, the incidence reported will be more than 50%. But in Japan and in Eastern countries, initially DG definition was that patient should be able to tolerate a porridge-based diet up on day 30. So that was the definition of delayed gastric emptying used some time back. Now everybody uses the standard definition. So in that, the incidence will be 10%. So you're talking about the same thing, but incidence will vary from 10% to 50%. So you cannot compare studies. Similarly, there is an international study group of liver surgery, which defines a post-operative liver failure. But it's still something is still missing. We have achieved something, but let's see a patient who develops 2 grade 1 complications, 2 grade 2 complications, and 1 grade 3 complication. The final score is a grade 3 complication. Another patient develops only 1 grade 3 complication he also gets a grade 3A because Clavin-Indo only considers the grade of the most severe complication. So obviously in this scenario, you are ignoring the 4 other complications that this patient suffered. So still we are far from perfection. So how to account for multiple complications? So this was a paper which came in 2013 by the Clavin group. They uh, introduced a comprehensive complication index. I'll subsequently tell you in some details. And then we developed our own complication severity score, which was on similar lines but had some basic differences. So that was CCI, and we gave a CSS. So what does these complication score do? So they account for each and every complication. Minor complication will have less weightage, and weightage will increase as the severity increases. And then you add the weightage of all the complications and take a square root. That gives you the final number. And death is assigned a score of 100. So this is the relative weights. So you give a weight of, say, in CCI, grade 1 gets a weight of 75, then increasing weight, and then you add all the weights of all the complications, take a square root, you get a final complication number. So don't get confused. You can find this in the paper, and it can be done on an app based. So you don't have to calculate yourself. You can just feed the data in the app, you can get the answer. So the same patient would develop 2 grade 1 complications, 2 grade 2 complications, and 1 grade 3 complications. You'll add the weightage of all these complications, take a square root. For CCI, you'll get 41.4. For CSS, you get 9.9. So this is the final. You can measure the morbidity on a scale. So that is what the output of these complication scores is. And this can be treated as a number and can be compared, mean can be calculated, standard deviation can be calculated, and then you can do comparison across the studies. The advantage is that it takes into account all the complications. A numerical best value is assigned. You can calculate mean standard deviation, and by doing that, you may actually reduce the required sample size of the trials. But there are some disadvantages also. It makes data collection cumbersome. So you have to keep a watch daily if a patient, note each and every complication that a patient develops. In the other scenario, you only had to bother about the most severe complication. Here you have to take into account each and every complication. Weights defined in the studies, uh, there are some logic to that, but they are not 100% because we don't have any gold standard to compare with. So if you don't have a gold standard to compare with, these weights are, all these weights are actually assumptions. So you don't have nothing concrete in your mind, and you are basing on some logic, but you don't know whether it is true or not. And you don't account for within groups. So 3A complication can be a simple one-time aspiration of a pleural effusion, while it may be a pictorial drainage of a liver abscess, are both same. So in the groups, they're both 3A, but there is difference. Duration of complication not accounted for, and it is difficult to validate as there is no available gold standard. Sometimes it may be too sensitive. The difference that it detects may be too small clinically. So if somebody has a complications rate of say 38, somebody has 40, is 40 actually more than 38? Nobody knows that. So in summary, standardization, the standard definition of complications is very paramount, as we have seen. Clavin-Indo is the most commonly used classifications. Complication scores may be a step better, but still they require a lot of refinement and validation. Thanks for your patient here. Thank you.
Good morning, Chairman, Professor P.K. Kapoor, sir. And thank you for giving me an opportunity to present the topic on this platform. And my talk is made easier by the previous speaker. In the same continuation, I will discuss the do complication affect the long-term survival. I got Kapoor sir shared this topic so less to make. Do you like to do that? I find this topic little bit unusual. I thought does it really it makes a difference in outcome? My first response was no, it does not make usually enough for at least for benign diseases. In malignancy, it may yes. So I discussed with my colleague also, putting same question. What do you think so? Does complication makes a difference in long-term survival? And with their anecdotal personal experience, they said no, it does not make. But I thought if Kapoor sir has gone through this topic, let me see, dive into the literature, what does literature say? And the results are really remarkable, eye-opening for all of us. So I will discuss this topic in detail. So post-op complication has been associated with a decreased long-term survival. It means it is already proven in a cardiac surgery, orthopedic surgery, and vascular surgeries. And there are few case reports about the GI surgery as well. So this is not a new topic, new for us because we never thought of. And so my presentation will focus how the long-term complication of the abdominal surgeries, including all organ, esophagus, liver, colorectal, and the liver transplant, bariatric surgery as a part, and gallbladder surgery, does their complication affect the long-term outcome? I will cover in this presentation. Although the definition of complication has very well covered by my previous speaker, but I want to reiterate that the complication means unexpected problems or adverse event that arise during or after the medical procedures or medical treatment or the illness. They can range from mild issues to major issues, including the organ failure or the sepsis, and complication to the point can be the surgical procedure related, like wound infection, bleeding, or anesthesia related complication. They may be medical treatment related also, like adverse drug reactions or prolonged hospital stay that may invite development of deep vein thrombosis or pulmonary embolism. And lastly, the chronic condition related. It means it's a patient related factors, maybe the cardiac disease, neurological disease, they may invite more complication in the post-op period. So I found this study, the landmark study, it is one of the first study what I found in literature that focuses on the long-term outcome after the complication. That is more than nearly 5-year outcomes. Other studies are presenting only 30 days outcome also. So this is the study, primarily observational cohort study of nearly 860 patients that covers the major abdominal surgery from esophagus to colorectum and conducted at the Amsterdam, Netherlands. The cases included over here were the patient who underwent the bowel resection. It means esophagectomy, gastrectomy, colectomy like that. And cholecystectomy was the not included in this surgery because they thought there is no bowel resection for this particular point. So they excluded the cholecystectomy for this presentation. They do classify the complication and they do include the benign and malignant disease for this. They do include the laparoscopic surgery and the open surgery for the assessment. And they divide the complication based on the Cleveland Dendo classification, that is the most commonly accepted classification system. And they also made it easy for their analysis. They defined grade 1 and grade 2 as a 1 complication, as a minor complication, and the grade 3, 4, and 5 as a major complication. And if you see how type of surgery were done in this study, the upper GI surgery was making nearly 23% of the surgery. HPB surgery was nearly 12%, where the pancreatic liver resection, biliary duct resection was done. And thirdly, is the colorectal surgeries that were making the most common component of the study part, and where the colectomy was done predominantly and followed by the rectal resection in this study. And the outcome was that the post-op complications were nearly 42%, but major complication, major means Timnido grade 3, 4, 5 were the 24%. And the outcome was that the patient with minor complications was significantly older compared to patient without complications or the major complication. And second outcome was that patient who underwent the upper GI surgeries had significantly more complication compared to HBV and colorectal surgeries. In that 30 days follow-up, 11 patient has the mortality, and upper chest surgery patient had the anastomotic leak, mediastinitis, sepsis, they died because of that. In SPV surgery, they reported only one mortality. The patient had the aggressive nodal disease, they done aggressive vascular resection, nodal clearance. The patient had a post-op bleeding. Or in a colorectal surgery, they had anastomotic leak. Along with that, patient had deterioration of the existing cardiac and lung functions. The average follow-up was ranging the 1100 days. That makes nearly 6 years, the ranging from 36 days to 2,300 days. The mean survival in a patient who had uncomplicated case was the nearly 1100 days. That is nearly 5 years. The patient who had the minor complication and their mean survival was 1500 days. And the patient who had the major complication, they had mean survival of only the 1500 days. So that shows significant decrease in the overall survival, the patient who had the complications. This is well displayed in this survival curve also. The patient with a colorectal uncomplicated, followed by the colorectal complicated disease, followed by number two, the HPV, those uncomplicated, they had a better survival, then followed by the HPV complicated cases, and third was upper GI uncomplicated, and lastly the upper GI complicated case. So the sequence of outcome they could analyze through this survival analysis. I also look the different perspective of the patient, like liver transplant patient, how does it happen in the patient? I could find only one study that also retrospective of 164 patient, and they said over 7 years, and their conclusion was like similar, as a complicated post-op care always influence not only the short-term survival, but also the long-term survival. Then I thought that this primary study excluded the gallbladder surgery. Does either any study assessing the impact of gallbladder surgery complication? I did not find any direct article carrying this title, but I could find one study that assesses the mortality after cholecystectomy. It's a population-based study of the Swedish registry. So I think we can discuss in a little bit. So this study shown the 30-day mortality of nearly 0.15%. And they found predictor of mortality were age more than 70 years, ASA scores high, patient underwent for acute surgery, but later two part, open surgery and the presence of the post-op complications. They were predictor of the survival. So this study focused only the 30 days mortality, but here important what I could understand is that the patient who had the complication, they had the less survival. Would have been this study go for a long-term survival, they might replicate the outcome what previous studies shown in this. Regarding the bariatric surgery, does bariatric surgery complication really has a similar outcome? I didn't find any studies, but I could find that bariatric surgery given an overall survival benefit because of disease resolution, because of metabolic disease resolution, and also cancer-free survival. So far there is no literature reported about this subset of patient, but I think so in due course of time, we may find a similar outcome suggesting the bariatric surgery outcome, whether they really impact the survival or no. So what are the predictors for long-term survival in this patient? So patient those underwent the upper GI surgery, those with preoperative weight loss and having the positive lymph node, they have worse outcome. But good point is that those underwent the minimum invasive surgery, they have protective effect. Similarly, for the HPV patient, they divide in two parts. Gender basis also male patient and female patient. In the male patient, the 2 points were common: increasing age, weight loss, and the positive lymph node. They had a poor survival. In a female patient, they found that along with the weight loss, the patient who had the post-op complication, they have the poor survival. So this is one of the subset of patients. They found that these patients have the poor survival in a long-term time. And lastly, about the colorectal surgery patient, here the predictors were increasing age, ASA classification of higher grade, pre weight loss, and positive lymph node. Like usual, they had the poor survival. But here again, like a upper GI surgery, the minimal invasive surgery had a protective effect for these patients. So what is the hypothesis why it is happened? So why it is the so researchers have given their own hypothesis. They said the patient who develops the post-op complication, whether it's infective complication or the non-infective complication, they usually found to have the sustained level of inflammatory markers in form of C-reactive protein and the procalcitonin. And this persistence of the inflammation that impacts the other organs, especially the heart and neurological dysfunction. So these they could propose. Regarding the cancer patient, what the cause? If they propose that there is surgical stress, activate the neuroendocrine and the immunological pathway that suppress the normal immune system. And because of that, there's a growth of residual malignant cells in a cancer patient. They also highlighted that the importance of stress following the surgery and adding with a critical illness in the patient, if patient develops sepsis or the patient requires the blood transfusion during the course of recovery, that further increase the cancer cell seedling in these patients. And of course, we all know any oncology patient undergoing the surgery, if they develop the complication, the adjuvant therapy is delayed for some reason until he recovers from there. So all these factors cumulatively impact the low survival rate and disease-free survival. So points comes, can we improve it? Can we make it better? Yes, there are way has also been reported in the literature that is the prediction of the complication early phase that can be done. The one of the study they show if do the CRP as a inflammatory marker is more than 140 on post of day 3. If you do a CT scan, we can find some complication, upcoming complication in these patients. The another study that made a prediction module and they basically systemic review of the various studies, and they predicted that if CRP less than 75, we can safely discharge this patient, and if CRP is more than 215, we should add the CT scan to find out the upcoming complications. So what are other studies we can have to minimize this complication? So first is we should have the risk assessment protocol that can predict the complication like we discussed now. Then the important common denominator I could find that there is a importance of surgical stress response. The physiological stress after the surgery, after the complication, if we can modify it, we can minimize these complications. And the important part that surgical techniques come as the foremost parameter where where should we have minimum tissue trauma. If you are using a minimal invasive surgical approach, that can also control the surgical stress. And the utility of, or I would say, incorporation of the ERS protocol in a day-to-day care of the patient, and the goal-directed therapy if patient had a sepsis, if managed by this philosophy, the outcome has already been proven that they improve the outcome. Now, there's a role upcoming of the robotics as a way to minimize more stress beyond the laparoscopy, and the technology, the AI coming as a predictor of the predicting some complication like for eye diseases. They have the protocol where they predict the complication in eye surgery. So similarly, we can see the long term, this technology can be a useful tool for us. So in the conclusion, the post-op complication negatively affect the long-term survival in upper GI surgeries, female HB patient, and the gallstone surgeries. Minimal invasive surgery has a protective effect. For as a surgeon, our aim is should be to minimize the surgical stress by using meticulous surgery technique, use more of the laparoscopic technology, and the ARS and gold direct therapy for our patient if that are the complications. And if we should include the predictive model like CRP or CT scan for a early prediction of the complication. And still, these are limited study I could find. We need a more study, more wide application of the marker to get a better insight on this topic. Thank you.
We'll have 7 minutes, and I must thank both these speakers for finishing their talk well in time, and we have 7 more minutes for questioning. Both topics are open for.
Wonderful talks. Both of you have completed the whole spectrum of this. But I'm a bit uncomfortable because when we talk about complications, we are talking about surgical complications from the time I take the knife in my hand. You've talked about stress, that is okay. So what happens if a patient comes to the theater, has a drip on one side, but you want it on the other hand, and the drip is changed on the other? The patient has stress. That is not included in. What about the errors? You have said that it ultimately affects the health of the patient. So errors, whether the patient has been postponed once and taken again, it doesn't count as a complication. We are not counting that as a complication. Patient is on table on anesthesia, patient is claustrophobic, the anesthetist puts the mask on the face, patient feels stressed. That induces a stress response to the patient, right? So all these things, I think, ultimately have to be included. If you don't want to call it complication, you want to call it error, but there is something which needs to be a patient-centric, like a questionnaire in the post-operative period, which is answered by the patient or the attendant. They will exactly tell you what psychological stress, what things could be improved. The patient goes into the theater, he's made nude, and it is very cold. The patient feels very cold. And so these things, I think, should be included in the whole spectrum, which will ultimately affect the health of the patient. Thank you.
most of these classifications and gradings, they say that need for intervention, need for blood transfusion, need for PCD, need for reoperation as a criterion. Now, you may intervene early, I may not intervene early. So I in principle disagree with this parameter being used for classification. That is the consequence. And that is one point, whether you'd like to comment. And second is to Avinash, benign diseases, cholecystectomy, if there's a bile duct injury and its consequences would definitely affect the long-term survival and more importantly, the quality of life. And third, you said that use CRP and CT and other predictors. So does early diagnosis and treatment of a complication, does it decrease the long-term effect of complication?
So, okay, sir. Okay. So we do not have a perfect system for measuring complications. The intervention part was chosen because it was the easiest to do. So that is the reason why intervention was chosen. And another point is that if somebody is intervening early or somebody is intervening late, and if it doesn't change the outcome of the patient, then I would say that for all practical purposes, it is similar, because suppose you started antibiotics 3 days late, but still the antibiotic worked and patient recovered, whether somebody started 3 days earlier and the patient recovered. So obviously the stress of the patient is more, maybe the hospital stay is more. So both in true sense they are not same, but for all comparison it should be same. And suppose because you started antibiotic late and then you had to do a pictorial drainage also, then obviously your complication is already increased, so that would take care of the delay in treatment. So, and this part was intervention part was chosen because it is easier to document. So if you see a patient chart, you can easily find that what all antibiotics were added. So you don't have to look for the patient every time and go whether he has developed this complication or that. You just see the chart, treatment chart. If pigtail has been put, if patient has been operated, if oxygen is given, all these things will be there in chart, and then you would be able to know the status of the complication. So it is easier to do, but I would agree with you that it is not the perfect system.
Sir, regarding your query, I do agree for malignant disease, we know it is a malignant. They may, majority patient may, I would say, may not survive longer despite our best surgical approach, based adjuvant therapy. But the concern, what I had in my mind, they got benign disease. So this particular study, they excluded the gallbladder surgery patients. So looking for any study that documented about this, because I know through the HGPG experience with your all efforts we are doing on this subject, I didn't find any study that look into this scenario for long term. We all know presence of complication improve and decreases survival, but I didn't find beyond the 30-day complication rate. I'm sure the way we start documented it, it may given some scenario that it affect not only quality of life, not only financial impact, not only social impact, but yes, overall survival also should go down. Thank you, sir.
If no more question, yeah, please.
Thank you very much for the presentation. I had one question about, you said that in upper GI surgery.
Kindly just identify yourself.
Okay, I'm Lukan Sharsen from Tanzania. I wanted to ask that you mentioned that in upper GI surgery and HPV surgery, one of the reasons for postoperative complications is lymph nodes. I wanted to know, how does lymph nodes lead to postoperative complications? Is it because of the advancement of the disease? Is it because of the extensive dissection which takes place, or is it because of most of these patients they undergo preoperative radiotherapy? Maybe they can lead to these complications postoperatively. And about the classification of these postoperative complications, do we divide them into early and late complications? Because I think the reason for the early classification for the early postoperative complications within 30 days will be different from those which occur later in the time of after operation. Thank you.
Regarding your query, I didn't find that type of discussion in the paper that I discussed right now. But I could see one case where, in the case of the underwent the penetrative that and the nodal dissection, where they mentioned because the aggressive disease, nodal disease around that area, so they want to remove the complete nodal dissection. They've done the periartery dissection as well. So there they could document it, that's the reason of the complication. For the upper GI, yes, we know usually disease in advanced stage, nodes are more aggressive disease, so biological disease may be advanced. And nodal presence, weight loss, they are otherwise also a good negative predictor of the less long-term survival. But how the compressive latent, I think more study will be required to put analysis on that, and then we come to a conclusion, yes, these are the exact cause for the patient compromising that.
Regarding your early
those kind of subset of patients can be looked for long-term effects on survival, putting them into those who had complicated and had no complications.
Yes, I do agree. I think this paper has given eye-opening for me, for the audience as well. So people sitting over there from working institutes. So at least we start looking at our own data. How does our results shows in that part?
I think Dr. Rajesh mentioned that saying this minimal invasive surgery has decreased the rate of complications. And for very obvious reason, common sense also tells. And as soon as there are lymph nodes and you have to do a dissection, it is obvious whichever way you use, the invasion will increase, and hence the chances of complications are likely to be high. Whichever procedure you adopt, open, laparoscopic or robotic, because the dissection extent of dissection increases, invasion increases.
And another thing with upper GI surgery is the involvement of the lungs. So if you are doing dissection in the lung hilums or near the nerves, so obviously you are more likely to get post-operative pulmonary complication, which can have a direct consequence on the post-operative outcome. So upper abdominal surgeries and upper GI surgeries usually will have more pulmonary complications.
That's really different. We're still working on the same pattern for last 20 years. If a patient has a complication following a lap chole, which is a major complication, it is most disastrous than a patient who is having an advanced disease, malignancy, in which you are trying to do a resection. Because the family scenario, the long-term survival, everything gets affected. The quality of life gets affected. So we need to rethink into it that we can't just define everything as a blanket statement that Clavendino defines like this.
I'll have a counterpoint to this, sir. Clavendino is not something that you identify that this is the complication. It is a means to do studies. So when you are comparing, say, 100 patients of lap chole, they are very homogeneous population. And if you want to use Clavin-Indo in that kind of population, you can easily compare. But if you point out a scenario where, say, all the patients are having advanced malignancy and some patients are having, say, only simple laparoscopic surgery, obviously you can't use Clavin-Indo complication to compare these patients. So Clavin-Indo complication score is used when you have a homogeneous kind of a population, which usually would be in most of your RCTs. You try to make your population as homogeneous as possible. You take ASA1 patients, ASA2 patients, less than 70 years. So all those criteria, if you are using, then obviously the next best thing would be to use Clavin-Indo.
I think
Exactly. That's what I want to say. That Clavin-Indo is for a particular group. We want to compare within the group. Now, the discussion is a long-term survival following the surgeries with a complication. So the discussion was a lymph node disease. So you can't compare a periampulary carcinoma which has a T1 disease and undergoing a PD versus a T3 N2 which is undergoing a PD. You can't compare these two because they will have a different post-operative course.
Absolutely, sir. Absolutely.
The medicine, particularly surgery and complications, it has a lot of philosophy involved into it. What Ajay told, that you see, if the expectation of the patient, the relatives, and everybody, and your own expectation out of his laparoscopic or robotic or open cholecystectomy for saying gallstone, symptomatic gallstone disease, and patient lands up with a complication of bile duct injury, you see the difference between the morale of everybody. A patient whom you have already told, the relative patient knows, know that he has a second stage or third stage disease, where we are trying our best to give you the best chance of survival. And that survival has already been explained to the patient and relatives far too many times. So the philosophy is always, so we can't write a paper.
My residents or students when taking a branch, GI surgery is the most catastrophic branch because the patient comes fit. He comes to you when he's absolutely fine. Doesn't know that he has to do a laparoscopy and can have complications. Vis-a-vis a patient who is undergoing a CABG, he knows the patient is already, he may not survive. A patient who is undergoing neurosurgery, they accept, but इस बच जाएगा तो बहुत अच्छा है. बचा लोगे डॉक्टर साहब तो बहुत अच्छा है. Same thing with onco surgery. They say cancer से बच जाएगा तो GI surgery they don't say that. They say अच्छा है तो अच्छा जाना है. So your complication rate decides your future. So GI surgery is different from rest all the ones.
But there are two things in your session, like Dr. Rajesh spoke about how do we define complication, the simpler part of it. But sir has put up a mind-boggling question of whether it affects long-term survival. So you'll have to put it into subsets, and it's an area for way forward to learn about in different subset of patients. Whether a complication happen as simple as a leak, whether it affected with formation of adhesions, quality of life, and then the last and the more difficult question, whether it affects survival.
You see, these will always be, remain a matter of conjecture and debate. You see complications. This survival, the quality of life now most of the people in you see when we were poor, then we are only thinking of roti, kapda and makan. When we have something, then we start thinking. So quality of life is a very important thing. And in a patient who has a cancer, he is not bothered about quality. He is more bothered about quantity. And a person who has a benign problem, which is much more rampant, he is bothered about the quality of life. So it will remain very staying. It will require, I don't know how long a study it will require to compare the long-term survival in each and every scenario. I think with this, no more discussions, and we come to the end of the first session. Thank you very much.
Next topic of discussion is rehabilitation and optimization. To chair this session, I invite Dr. Avnish Bharadwaj, Emeritus Professor of Department of Anesthesiology, former Professor and HOD of Department of Anesthesiology at Mahatma Gandhi Medical College, Jaipur. Along with him, I also welcome Dr. Priyambada Gupta, Professor and Head of the Department of Critical Care Medicine at Mahatma Gandhi Medical College, Jaipur. And to present this session, I welcome Dr. Gaurav Webb, Professor and Head of Cardiac Anesthesiology Department at Mahatma Gandhi Medical College, Jaipur. Thank you, sir, for giving me this opportunity to give insights on optimization and rehabilitation.
While Dr. Gaurav is starting, I must add that he is the backbone of our liver transplant program and also all the complicated GI surgical procedures that we do.
So, in previous sessions, we understand how even a minor complication can lead to negative outcome. So how can we reduce or predict complication is going to happen? So this is by the optimization. Optimization is doing adjustment for the judicious use of available resources. To reduce complication rate, we all do optimization in our patients long way back and mostly focused on control of comorbidities, blood sugar levels, blood cycles, and other biochemical values. But as more and more complicated patients are coming to us and for more complicated surgeries, we do need a little more thing, not only using optimization, we want to improving overall status of the patient before going for the surgery, and that is what it is called rehabilitation. So basically, rehabilitation is preparing individuals to weather the storm of their surgical stress and to avoid overcome complications. Classically, it is defined as any preemptive intervention intended pre-operatively to strengthen patient physical, medical, nutrition, and mental condition, aiming towards increased patient capacity for resisting surgical trauma and facilitate post-operative return to pre-operative condition as soon as possible. It is an integrated services require several multimodal interventions and the results say literature says that it can reduce complication rate up to half of the previous value. Basically, rehabilitation is an extension of ERAS protocol. It's a first component for the ERAS protocol, and a little bit insights of how surgical stress has happened, as Raju sir has already pointed out. Whatever stress, whether it's a surgical one or psychological one in the preoperative area, it stimulates the hypothalamic pituitary axis, and lots of inflammatory and hormonal neurohormonal transmitters are released, which causes release of lots of hormones and interleukins, interferons, TNF alpha, growth hormone, thyroxine. All of them causes increase in metabolic rates, which requires a lot of energy to take over it, and all the energy stores get depleted in form of glycolysis, proteinolysis, lipolysis, etc., which increases inflammatory response to the body and also increase blood sugar levels. So let's see what literature says regarding the preoperative aerobic exercises taken in the pre-elective area and the cavity surgery. This aerobic exercises giving a precondition to treat the stress responses and improve functional capacity to help withstand the stress of surgery. It includes dietary modification, relaxation strategies, sleep hygiene, and exercise prescription. Rehabilitation reduces in this review article, they concluded that length of stay decrease of complication accelerate return to preoperative function area quickly. Another type of rehabilitation is nutritional enhanced recovery rehabilitation and immunonutrition training 3 times a day for 5 days previous to the surgery. Carbohydrate loading during night prior to surgery and preoperative multi-species probiotics with 10 to 15 million daily of probiotics can reduce complication up to 49% and hospital stay reduces by 14%. Direct hospital cost reduces by 60% and time to return to normal bowel function is quickly in these patients. So basically, rehabilitation has a 4-pillar program. It's a physical component where the patient endurance is increased. Medical optimization, we all do this. Nutrition support in selected patients, while the mental, psychological preparation and education for the lifestyle modification training programs are also there. The 5th pillar of patient education and post-operative lifestyle modification has been added recently in this case. I would like to explain this graph here. This is the minimal physiological threshold activity level, which is seen here, and this is the resting aerobic capacity margin. When the patient in a preoperative area is at the level of A, the only result is this much, while with the prehabilitation, it has been seen that the result is increased. So what happened is, this is the line of dependency. If the patient, a normal patient coming to the surgery, this is the independent phase. Suddenly after the surgery, this goes to dependency level for a short period of time. And when gradually recovery occurs and the patient comes to return back to its normal independency level at this point of time. Work forwards, if some complication occurs, the dependency period goes down and it takes longer time to recover, but still the even later period also patient remains dependent one. While with the pre-rehabilitation, what we do is we increase the functional status of the patient up to this limits. So in the early post-operative period, the recovery during the early recovery is quite early, and the dependency part is only this much, and even the patient from the baseline also in the postoperative period, patient's functional capacity is increased. Even in this case, if some complication happens, patient can have dependency period little bit longer than the previous one, but it's still from the previous patients, the dependency period is lesser one. So how we go for this rehabilitation program? So this is a tailored approach, not an algorithm one. Every patient is different with different comorbidities and different physics. So we can't make a we can't make a statement for all. So this is a first to optimize the patient in according to his condition also, and do not push too much or do not delay the surgery too much, so the disease can increase up to a certain limit. Initially, what we do is physical activity is score where the respiratory function increased by the spirometry cardiac function. We can do the patient can walk around 2 flights of the stair, can go up to the 4 mats, or those who are not 6-minute walk test to assess whether how much the patient is doing muscle strength and mobility during this, and also training about the pain tolerance. But again, this is to be done in a vigilant manner. Everyone has different capacity and should not be put into a risk. So, ball getting scale of perceived exertion was used initially, which was 6 to 20 scale assessment, has been now refined into 1 to 10 scale. And with the assessment of patient's activity score, we can see in preoperative area how the patient is improving with our training or rehabilitation programs in terms of physical activity. Again, patients have different type of comorbidities and so many comorbidities in one way, in one patient. So to compile it, it's a very difficult task. So there is a Charlson morbidity score where you can quantify amount of risk where the patient is on with different comorbidities, and there's a scale given, and more than 8 score is supposed to be these patients are ending up to more complication in the post-operative period. So during the pre-operative period, how much we can optimize it, so we can also have to record it. Nutritional rehabilitation is required in patients where most likely in oncosurgeries, where hypex surgeries, where patients are not taking much of nutrition previously and depleted one. Weight loss of more than 10% in last 6 months, body mass index of 18, less than 18.5, and serum albumin of less than 3 are the major risk factor, and these patients require active nutritional rehabilitation in terms of replacements. Again, Sir has already tell that anxiety is one of the major factors for the stress response. So there is a assessment for how much patient is anxious about the surgery, about the anesthesia, post-operative recovery, and post-operative complication factor. So there is again one score, Amsterdam anxiety score, what we are using in our patients to assess, and all these scores are given in a form of a booklet to the patient as a patient education tool to the patient, and this is a prototype of patient information booklet what we use in our institute. This has a pictorial simple diagrams in patient's language, and also have a table to have with them. Patient has to bring this booklet at every point of time, at least 4 visits at the time of first surgical visit, second at the time of PAC, at the time of prior to day of surgery, and at the time of patient taking into the OT period, so we can assess how the patient is improving, and it is a written form. There are certain challenges for this pre-op program, though we already are overworked, overburdened, so this is a time-consuming one. It requires a lot of more things. Another thing is now we have this. Now we have AI-based mobile applications of rehab. It's a new thing to come upon. At home, patient can contact everyone, make a community guide, take a guidance for a few weeks without again coming to the hospital under vigilance and supervised manner. This is the prototype how this works, and thank you very much.
Thanks, Dr. Goyal. Please. Please come. Thanks, Dr. Goyal, for your comprehensive coverage of this important area of perioperative medicine in a short period of time. Before I set it open, I would like to set the ball rolling by asking you one thing. Please be seated here. Now, this is agreed that prehabilitation focuses on prevention, early intervention, optimization, and personalized medicine. And this definitely helps improve the quality of life, long-term survival, outcomes, and also reduces the healthcare cost to the institution and to the government. Uh, Prehabilitation is more useful in long, prolonged surgeries and chronic diseases. So this is a general concept which everyone agrees. What are your comments regarding rehabilitation and optimization in oncosurgical patients? You have an extensive experience in oncosurgery. So on one hand, in this part of the country, patients with oncological cancers, they present late. They present very late and are not well preserved. On the other hand, they undergo prolonged surgery and we focus on optimization, and there are limitations imposed by the beneficiaries of the government schemes and the risk of progression of the disease. So, what kind of a policy do you suggest here?
Oh, sir, actually, we want to have this rehabilitation program clinics in our every centers, and this is a need of a time, right? Our hospitals are overworked and overburdened, and we can't overburden surgeons or anesthesiologists on this. So I want what my suggestion is, there should be a dedicated center, yeah, dedicated centers from there to who can previously look at the patients, compile all the data, and make them fit for surgery. So there should not be any, as sir said, cancellations of surgery or last time postponement of the surgery in terms of optimization in that order.
Well, now, can we have a few questions, sir? So it's open for question. The house is open for questions, please.
Very good. So we have in PGI, we did one project, and we have involved the physiotherapy and the dietitian from the PGI and our patient family. So what we are doing, we have developed on that on WhatsApp, everybody puts their exercises and posts in the WhatsApp. So because it's said to be very meticulously supervised. Suppose you tell the patient,
Yes.
go and walk for 6 meters.
Yes.
He might not be doing.
Yes.
So regularly, every day, they are putting their WhatsApp exercising, whatever they are doing on the WhatsApp, and our registrar then calls them that these are the mistakes you are doing.
Yes.
So you have to do like that. Certain people get motivated because of the other people doing the same thing. And in the same group, the thing is being put. So that is the way I think we can make it better.
So even smartwatches are automatically take up your physical exertion. Yes. So this is an app-based one. So all the patient motivate each other. They can even talk to. Can make their own community in that way, forum like that, discussion, a social media type of a thing. This is what the plan is.
Sir, what I may like to add is, besides whatever academics we are studying, whatever scales we are using, we should always give a personal touch to the patient. We should be empathetic to the patient, and we should give him or her the assurance that he'll be well, he'll be fine. Because what happens when the patient is on OT table, as already it was discussed. So at that time, we have to take care to respect the dignity of the patient. Besides all preparations, it is very important that patient's dignity is respected. Just keeping your palm on the forehead of the parturient who is come for cesarean section gives her a lot of faith, lot of belief. Okay, everything will be fine for her and to her baby. Nothing will be wrong. So that assurance is very important. Besides, whatever we estimate the risk, yes, correctly, that risk is estimated in terms of the outcomes. What will be the intraoperative and postoperative challenges we'll have to face? That is very important. But giving a personal touch, giving some time to the patient when she comes for the pre-anesthetic checkup is very important. A senior person should talk to the patient so that she has a belief, because she should, most of the people don't know much about anesthesia, especially in India, what I have seen. So they should be given assurance this will be your plan of anesthesia, it is very safe and everything will be fine, don't worry. But you have to take care, like bariatric surgery. It is very important that patient's lifestyle is changed before surgery, because if you are going for a sleeve gastrectomy, it is useless if patient is not taking care of his or her diet and not exercising. Likewise, it is mainly means tailored approach for individual patient. Patient going for a ligament repair, ACL repair of the knee joint. So that patient should be taught the exercises prior to surgery, because in post-op period, patient may not be able to do it properly. So these are some finer points which we should touch.
Dr. Gaurav, in a minute for the young people who are watching this, can you tell that in case of an emergency surgery, how much optimization can be done and what are the specific things which can and should be done?
So psychological support is the first one. First, 50% of our struggle can be taken care of just by talking to the patient for the first 5 minutes, and 5 minutes time everyone has, right? So even if we talk to the patient for the first 5 minutes to reduce his stress, then surgical stress will reduced by 50%.
Metabolic parameters.
Yes, ABGs and that all, we all are doing it. We all, I'm sure everyone is doing all those things regarding that creatinine level or blood sugar levels or blood pressure levels, medication level point of time. Though we can't do physical much, but yes, psychological one we can do what we can do at that time.
So thank you, Dr. Gaur. Do we have more time for more? Thanks, Dr. Gaur, for a nice talk. And thanks, Dr. Kapoor and JSF team for inviting us and giving this opportunity. Yeah.
That time you can optimize the attendant only.
No, actually.
Just resuscitate the patient, look after all the requirements.
That is also optimization. You do ABGs, there is a acidosis, you correct it. That is called optimization.
Other problem and the patient died during the post-op because unknown cardiac disease. I think this is very important to do your surgery and evaluation in the post-op for the cardiac disease is very
Even
important.
everything.
That's why I think our resident just evaluate the patient for the cardiac issue patient have. You may not know it because you already have operated and you have a bad outcome.
So once again, my personal thanks to Dr. Kapoor. This has given me an opportunity to meet my senior and my teacher, Dr. J. Mehta, for after a very, very long time. Thank you so much.
For the next session, a panel discussion on acute pancreatitis. I invite Dr. T.D. Hadar as moderator. Dr. T.D. Hadar is a professor in the Department of Surgical Gastroenterology and Liver Transplantation at PGI Chandigarh. I also invite panelists, Dr. Rajendra Desai, professor and senior consultant in GI and HPB surgery, unit chief at IIN Institute of Medical Science, Hyderabad. Dr. Rajesh Palwar, Associate Professor of GI Surgery and Liver Transplantation, AIMS Delhi, and also Dr. Sadaf Ali, Professor and Head of Department of Surgical Gastroenterology, Sher-e Kashmir Institute of Medical Science, Srinagar.
A very good morning, and once again, everybody is thanking sir as he started this meticulous program every year, and every time we get benefited by preparing the talk and listening to others. And I welcome my panelists, Dr. Sadaf, Dr. Desai, and Dr. Rajesh. So what I have done, gone little bit again what sir said, because acute pancreatitis is very, it will be very short if I just talk about some complications after the surgery. So I have, from the regional point of view, I just try to make few, three, four slide basics, then try to discuss little bit early part of the management, then going to the complications. So all the protocols have been already sent to all people by Dr. Kapoor. So everything has been done. So there has been a extensive advancement in the management of acute pancreatitis. So nowadays, as a surgeon, we are seeing so less number of pancreatitis because everything is being taken care of by the intensivist and gastroenterologist and ICU competent persons. And surgical people are called only when there is a problem, like, and then endoscopic management of the pancreatic necrosis. Earlier it was not there, so we were called earlier. Nowadays we are at the corner, but we are part of the team. So it is a multidisciplinary approach where it is required, and because of the evolution in the nutrition management, intensivist and antibiotic coming up, evolution, all these things have taken to the decrease in the mortality. So when I was registered, I used to say when patient requires surgery, hardly used to see any patient going home. So time has changed a lot. So if you see what is the clinical course, hardly 20% of the patient they will require any surgical intervention. And as I said, that has multiple components now. And out of that 20%, if they require surgery, then after the surgery, local complications and complications during surgery or complications because of the multi-organ system failure, because of the sepsis, the mortality of the all is very, very high. And today, even if you see the mortality rate, overall mortality is still about close to 18 to 20% in the best centers in patient requiring surgery. So management principle, as we say, it is a bimodal disease process because in the beginning, all the problems are because of the extensive inflammatory mediators. So people are going into multi-organ system failure, coming with organ failure. But later on, the sepsis component takes part. So that's why delaying surgery is the basic management principle nowadays. So the presentation, as I said, is because of the early mods and late mods. And early mods is because of the inflammatory mediators, and late mods is because of the setting of the sepsis. So these are the things one should know. So rationale is why we are talking about delayed surgery. So if you see all the pictures here and same patient, according to the change of the time, there is more localization of the inflammation. Wall is nicely made. So if you are going late, your debridement also will be localized, and you can do the tissue so the less hemorrhage and well-defined tissue, and then you can take the tissue out only necrosum, not the pancreas, and that has led to the decrease in the market. So this is my all basics. Then I go to my first panelist, Dr. Sadaf. Dr. Sadaf, we are talking too much about fluid resuscitation. So such an important component of pancreatitis management. So initially it was that give lots of fluid because of the vasodilatation, and lots of fluid is shifted inside my extravascular compartment. So nowadays there has been, it seems a little bit a paradigm shift. So can you please give your comment on the what fluid should be given, how fluid should be resuscitation should be done in the patient having good severe pancreatitis? We are talking only about severe pancreatitis. We are not taking aside the mild pancreatitis.
See, if it is not for mild acute pancreatitis, where initially people used to think that they are over restricting and not letting you slip into from mild acute to severe acute, then in all cases of moderate acute and especially in severe acute pancreatitis, there's a lot of capillary seepage in third space fluid. If you don't give a goal directed fluid therapy, then the patient is likely to have pulmonary edema. It is likely the patient is likely to have AKI and many other complications. Then the organ failure creeps in and so many things happen. So it's very important that that there's also that waterfall trial which was subsequently stopped as they wanted to give an aggressive versus a not so aggressive fluid therapy. Initial resuscitation few hours they were thinking of giving 200 ml versus 300 ml, and then the maintenance was 1.5 versus 3 ml per kg per hour. So then more appropriate is till when you streamline the hemodynamics. It's all important that you assess in what condition your patient's fluid and electrolyte situation is when you are taking the patient. What is the respiratory status? How he has been treated by the previous center? And a goal-directed fluid therapy of initial few hours till your hypotension is corrected, and then reassess, put in a central venous catheter, see the pressures, and accordingly you should give fluid to these patients. And the type of fluid is also very important. Like the concept of normal saline is no more, because there are many comparative studies which have shown that lactated ringer solution, what we call as RL, is having better, decrease in the inflammatory markers like CRP and other cells, which again helps in the recovery of or controlling the SIRS. So the type of fluid and the amount of fluid are very important. It should be goal directed.
So if I can summarize that, the concept of pancreatic ischemia, which leads to the damage. So in the beginning, we have to try to control the pancreatic ischemia by resuscitation. And in first 6 hours, you can give the fluids maybe little bit more, but after that, you have to go to the 1 to 1.5 ml per kg body weight per hour, and the fluid is required. Usually, and there is, as you said, there is a RCT between the lung ringal lactate and the normal saline. Normal saline is almost isotonic saline. Ringal lactate is a little bit hypotonic, but it has been found that ringal lactate is the best solution, and there is no scope for the colloidal solutions in the resuscitation. So, to agree, if I summarize that, so second important issue in the management of pancreatitis is antibiotics. So, Dr. Rajendra Desai, can you go give some thoughts about the starting antibiotic?
Yeah, I'd like to trace the evolution of the use of antibiotics. We started with a phase where we started it in all patients of pancreatitis. Then it came down to treating only severe acute pancreatitis with complications. And now it is goal-directed antibiotic therapy. So basically, when you choose an antibiotic, it should penetrate the pancreatic necrotic fluid and the pancreas. So mostly the agents that are used are meropenem and etrapenem at the moment, because they are broad spectrum. They cover aerobic negative organisms, gram-negative organisms, and they also penetrate the pancreatic tissue. About antibiotics being goal derived, it has been shown that unless there is infection in the pancreatic necrosis, there is no indication for antibiotics. And nowadays, antibiotics have assumed a role in the treatment of infective pancreatic necrosis, that in many patients, you are able to avoid surgery while treating with antibiotics, even in the presence of necrotic tissue. The third thing is, when you give antibiotics, the beneficial effect that has been seen has been that there is a reduction in overall incidence of infection, but no reduction in infective pancreatic necrosis. So pulmonary, GI, and renal infections are reduced when you give antibiotic early. But this is balanced out by an increased incidence of fungal infections in patients with acute pancreatic necrosis, where antibiotics are used excessively. So briefly, I would say that it has to be goal-directed antibiotic therapy only in infective necrosis, and this is imaging evidence of infective necrosis.
So if I suggest, I summarize by saying that prophylactic antibiotics, which used to be the starting point when patient is coming in acute severe pancreatitis, it should not be used. And there are multiple trials. Before 2006, there were some trials where some benefit there is a calculated also. After starting early antibiotics were found, but as Dr. Rajendra has said, that nowadays, if there is no suggestion of infection anywhere in the pancreas, you have to rule out other organs. So why there is a problem like the patient is going to search. So if there is no documented source of the infection, the antibiotics has been not found to be of any use. And infected pancreatic, as I said, you can see the references and you can go and read this, that infected pancreatic necrosis is not synonymous that you start. But the practical point is most of the patients, when they come to us, they have been already started with the highest antibiotics. So that is the biggest issue we are seeing. So to summarize, that prophylactic antibiotics to prevent pancreatic infection is not recommended at this particular time. Tomorrow we don't know.
So there is a level 3 evidence about that. So recommendation is when there is infection, and then there should be antibiotics, and choice, as Dr. Desai said, antibiotics should be concentrating in the pancreas. So like aminoglycoside, they don't concentrate, but some of them are very broad spectrum. So not only broad spectrum. So you try to cover about fungus. So prophylactic fungal, antifungal.
It's been shown that if you use prophylactic antifungal, you again end up with resistant fungal organisms. Most infections nowadays are because of Candida gallipirata, which is not responsive to fluconazole. Only fluconazole has been shown to show some help in infected pancreatic necrosis if it's used. But antifungal agents like caspofungin and anidardoflungin are now required when they're based on a culture report of fungal growth. Only in those patients you are supposed to treat them with antifungals.
So when you are doing necrosectomy, you can send the tissue for the even staining also, because culture takes time. And if there are everything is going on, lots of antibiotic has been given, and suddenly patient goes into sepsis after necrosectomy, then probably you might think of starting antibiotic, but with a caveat. So again, prophylactic antifungal has no role. So coming to third very important component, Rajesh. So what about nutrition? Because this is the neglected area in our so what about nutrition? How, when to start nutrition? What should be the rule? And is nasogastric as good as nasojejunal? We to start nasojejunal in the beginning, TPN or parental. So please, in short, can you just summarize?
So as acute pancreatitis is an inflammatory process, and it has been compared to the same systemic stress as burns. So a patient with acute pancreatitis requires nutrition similar to a patient who has severe burns. So obviously this part is very important. The fear of giving oral nutrition in pancreatitis is that it may increase the inflammation in pancreas. It may stress the pancreas to release more enzymes, and that can further increase the complications. But this effect has not been found in the studies. So if the other problem is that these patients, you often have nausea and vomiting, and they have local complications, collections around the stomach. So there is sort of a functional gastric outlet obstruction. So they may not tolerate oral nutrition, and in those patients you may supplement a parenteral nutrition if they're not able to tolerate oral or enteral nutrition. But if a patient is feeling like eating orally, the oral nutrition is as good as any other form. Only thing is that it has to be low fat, low residue diet. And if the patient is not able to tolerate oral, the next route would be the enteral nasogastric route. And multiple studies have shown that nasojejunal is no better than nasogastric route. So if you are able to give nasogastric feeds, that next choice. And it has been shown that if you are giving enteral nutrition, then it maintains the gut lining, and it maintains the gut barrier, and it may actually prevent translocation of bacteria, and it may reduce the infection complication. On the other hand, parenteral nutrition has been associated with infectious complications.
TB-related sepsis.
Yes.
And the only statement is, so you can see these are the landmark studies that compared nutrition, nasogastric and nasojejunal. So nasogastric, if there is no lots of vomiting and compression, nasojejunal, nasogastric can be started. Nasojejunal only when there is a huge collection, acute collection, and there is a patient is not able to take, then you can go for nasojejunal. It's very clear that internal nutrition should be started as early as possible once patient is stabilized. Is it okay?
Yes. Yes.
So nutrition in acute pancreatitis from old paradigm to new evidence. And new evidence is that patient should be given, and there is no rule of rest the pancreas nowadays. So resting pancreas has no role, and we say that get the gut going. So gut should, if it is working, it should be. Even distension in the abdomen. Only contraindication might be intra-abdominal hypertension, which might create some problem. Otherwise, there is no rule of this thing. So all these three pillars of the mind management of the pancreatitis: resuscitation, antibiotic, and nutrition, which are in the beginning for the region point of view, we have taken care. And now we go to the case capsule. So Dr. Sada, here is the summary of the patient. Sudden onset, there is a lady, sudden onset severe pain, radiating to back, multiple episodes of vomiting, no fever, no jaundice. Managed conservatively in the beginning, and then there is a similar episode about 20 days back.
So she was diagnosed as acute nephrizing pancreatitis. It was related to gallstone. There is a local complication in the patient. So you could see this, there is a local complication. However, there is no fever, there is no tachycardia. She is walking and about, up and about. Only the problem she had is postprandial fullness. So how would you approach this patient?
As this is just 3 weeks post acute pancreatitis, and I can see a big collection over there, which is subsequently likely to be a walled off necrosis. And as you said, that symptomatically her only concern is that she has more of vomiting due to some local compression. So this site of collection seems to be amenable to either to external drainage, or you can pull it for a week or so, and intragastric drainage can be another option. So endoscopic. So it you can make an assessment, see the bulge, and take a decision. There's no role of any open surgical treatment in this kind of walled off thing as of now in early phase of the disease. It doesn't look infected.
Just give 2 more points about timing of polycystectomy in this patient as well as other patient of gallstone pancreatitis.
See, as it seems that she doesn't have any organ failure, and she is not a very severe kind of pancreatitis. So the timing of surgery for gallstone pancreatitis, as far as the Ponchu trial goes, it was mild to moderate. Then it can be operated in the same setting. But on the background of this kind of collection, you have to take a call about what you are going to do this about this collection, and it can be done earliest after in moderate acute pancreatitis, after the complications of this kind of collection and all of the fluid, which might be of lesser complexity than this one, settles down, and then you can take it. And when it is severe acute and the patient's stay gets prolonged for months or years, then you understand that it gets delayed even beyond. So only mild acute pancreatitis you can do it in same setting. Other patients you have to take a call based on the local findings.
So if there is no necrosis, there is no severity, mild acute pancreatitis, if they are admitted in the same setting and operated polycystectomy, the complications in the future are much lesser, and the re-attack of the acute severe of the pancreatitis which might be severe. So this is very important message that gallstone pancreatitis should be managed, and a patient like this can be managed on case and case basis. Like she has no symptom, but there is a collection. So for the collection, she is not able to take. You can go do PCT, and later on, maybe after 2 weeks, we can go for a calculation. Okay, thank you. So gallstone pancreatitis, as I said, we have already summarized, so we are not going there. So now, Dr. Desai, here is a patient, a resident, 4-5 days, whatever time within this CT scan is done, and this is the CT scan. So what message you will give to the resident?
Yeah, it's important to notice that this is a contrast enhanced CT scan, and there are increased densities inside the lucent area which is seen. This lucent area is probably a collection, the exact nature of which is very difficult to say because it's iso intense. But these hyperdensities inside the lesion suggest a hemorrhage or a recent hemorrhage into the cyst. And we should make special effort to look for pseudoaneurysm formation in these sort of patients. If we can identify a pseudoaneurysm, that should be called, and no attempt should be made to operate on these patients in an emergency. Even percutaneous drainage would be contraindicated. And if you find a pseudoaneurysm in any of the territory, either in the celiac or the superior mesenteric territory, you should embolize it and only then proceed with treatment of the local complication.
So I think very important as a registrar, please be aware of the enhancement inside the collection. And if it is there, first statement is go do a CT angio, and then go, and if there is the commonest is I will show in the slides is splenic artery, then followed by gastroduodenal, whatever is there needs symbolization. No intervention at that particular junction of any kind should be done. So this is the patient where embolization and transarterial. So that's why I say in the beginning, the acute pancreatitis is no more only surgeons business. You have to have everybody in the armamentarium. So it is very, very important. So Rajesh, this patient, you are managing this patient and the CT scan done after 15 days. Here is the picture.
So here's a collection
So
behind.
options, I will ask for the options. Are you going to do straight away surgery required because of the hair, or do some FNA culture, or you are going for PCD?
So there's a lot of air inside the collection, which suggests that there is infection. Either there's infection or either there's a bowel communication. Previously, this was an indication for straightaway surgery, but it's not anymore. Now you can manage it per goodness. A study from our institute has already shown that FNA and culture sensitivity antibiotics hardly makes any difference as patients, so that is not required. So I would say that you can manage these patients with PCD nowadays, and the step-up approach can be applied to this sort of patient as well.
Very important that the only gas in that collection is not a state of indication for the surgery. So if you put a picture, not only that you are getting something, the intra cavity pressure goes down, and that is the one of the reasons why patient improve even without surgery. Even there is lots of semi-solid material in the collection. Even then people improve. So this is another scenario, Rajesh, same type of patient. But here is the patient, you see minimum postprandial illness, and there is nothing, no sepsis at all. So same like Dr. Sadar. Here is the patient. How will you approach this?
So this is 1 week post pain. So this is still in the early part. So obviously you don't expect any localization at this part. And since the patient doesn't have any sepsis, so this is a patient who has to be managed conservatively. And then you have to see for over the next few weeks, this collection may actually spontaneously resolve in some time. And if it doesn't resolve in the 6 weeks, then obviously you have the option to go in at that time. But right now you manage the patient conservatively. And since there's no sepsis, there's no need for antibiotics. And oral nutrition, if the patient can tolerate, is good enough. But you can see here that there is a tube inside. So if the patient is not able to tolerate oral or NG feeds, then obviously you can put in a nasojejunal tube in this patient.
Because the nutrition was an optimum, only tube had been fed. So very nicely summarized. So you don't need to rush after the CT scan. The patient is the first priority. Patient should be seen what are the symptoms, and based on that. So to summarize this collection, the sterile necrosis is doesn't require any treatment. Wait and watch policy, and based on the time also. So Dr. Sada, the contrary to this is 45-year females, idiopathic pancreatic necrosis and CCT abdomen on day 20, and you could see that score. So now, how will you see?
This seems to be a very high score with lot of necrosum. If I am correct, there's a central, as he said in the previous patient, there's some hyperechoic area in the center of the necrosis. It is air-filled, and this would need a management. I don't think it will be amenable to step-up approach. He has already, it has been 40 days, you said. So this patient only 20 days. So you can go for a good CT angio, and if there is an aneurysm over there, you will have to embolize it, and plus you will have to drain it. Maybe you will have to serially upstage your catheter. Because this is extensive, or it might even require multiple catheter placement because it goes onto the right renal space right up the pelvis.
So there was no enrichment in this patient, and this patient, you meant to say that we go by the first step of the approach, increase the size of the PCD, what we have did, and if patient doesn't improve, then only any type of minimum invasive surgery can be recommended. So this is what is the management ability. So there is they say when you are doing necrosectomy and you have removed this type of cast of the pancreas, but suddenly you are seeing that patient is having coming back to the having extensive hemorrhage. Patient is bleeding like anything.
Basically, this sort of situation is not uncommon in patients with pancreatic necrosectomy. Especially when a younger surgeon is operating, one of the main precautions is don't break any connections between the anterior part and the posterior part of the abdominal wall, because most of these will be thrombosed vessels or patent vessels. So you have to be very gentle. You have to remove it with a sponge holder, no traction. don't disrupt these bands because you could end up with a major bleed. Now, if you end up with a bleed despite anything, this is basically because the pressure has been released in the cavity. There is an erosion of the wall. There is a rupture of the wall, and there is rapid bleeding. The bleeding can be venous or arterial. If it is venous or arterial, the first step is to pack the cavity with gauze and try to arrest the bleeding. If it's an arterial bleed, what you need to do is after this, you need to wheel the patient out and get them to have an angioembolization of the vessel that is involved. Please don't try to take sutures through this tissue and try to catch the vessel, because sutures cut through and you will change a simple bleed into an emergent hypotensive massive blood loss. So don't try to suture, pack it well. If you have interventional facilities, do interventional radiology. If it's a venous aneurysm, you can put a wired mesh stent. If it's a arterial bleed, you can then do an embolization of the cavity, and you can put covered stents which prevent lateral disruption of the arterial wall. So that's what I would recommend.
So just let me summarize. I always say that in acute pancreatitis, the management is aggressive, but the surgery is gentle. So I even don't recommend sponge holder. So you take just try to fracture if you are doing minimum invasive by the suction, very mild, or if you are using your hand by your finger, index finger and thumb, little bit of fracture, then suck it out. So water does disrupt the tissue. So digitoplegia is one of the important issues. Rather than pulling anything which you are pulling, then you are in danger. And the best thing is that you should pack. Don't try to do anything more. 90% time this bleeding stops. Go and remove after 72 hours. So this is Rajesh. Are you able to see something? This is another complication.
This is the migrated human opposing lamps.
Yeah. So necrosectomy done by yes.
So nowadays necrosectomy is done by endoscopy. So they like to place large stents, and these human opposing stents actually make the procedure very easier because their scope can go inside the stent and they can do directly necrosectomy. But these stents are initially they were associated with very high risk of complication. They were associated with hemorrhage because you are punching the stomach with a large stent. So these are associated with bleeding. Another problem is that these stents can migrate.
Migrate, yes.
So once they migrate, the stomach wall is closed off, and now they lie in the connection. So you will be called upon to send in such patients. So the treatment depends on whether the stent has migrated only into the lesser sac or is it transmigrated to the mesocolon or other parts and it has come to the normal peritoneal cavity. Because if it is only in the lesser sac, then you can go transgastric, open up the same neck side, endoscopic side, and can retrieve through that opening, and you can do a lecosectomy, transgastric lecosectomy. But if it has migrated intraperitoneal, then it is a big problem now because it will lead to a gastric fissure.
Yeah.
So
even sometimes in colon also.
Yeah.
So, yeah.
This is going to be a difficult problem, and then you have to individually treat those patients depending on whether you can suture the defective stomach. The suture may not hold. So it will be a difficult situation here. The only thing is that you have to put wide board drains so that if there is a leak, it is controlled leak rather than an intraperitoneal leak.
So every advancement has its own accuracy, and we have to know that. So this is another patient, Rajesh. You see this 25 years male and blood in the bag after the necrosectomy. So necrosectomy was done. Suddenly one day after, on the rounds you are finding this type of hemorrhage.
So if there is hemorrhage, then obviously you straight away do a CT angio. You are worried about is any pseudonism which can cause life-threatening hemorrhage. So that is what we need to rule out first. So here it's already it's showing pseudonism.
Yeah.
In the splenic artery.
So patient is doing well. After 20 days also you can have this complication. And there is something called a cavity bead also. You do a CT angio, you don't find anything, but there is a granulation tissue starts bleeding. So there also the only treatment is go and pack it. Pack and pack. Many times packing might be required. So There was a patient who had a massive lower GI bleed after the necrosectomy. How will you proceed, Rajesh, in this
Sir,
case?
in most of these instances, your necrosome has eroded into the colon, and so the bleed is actually may not be in the colon, bleed may be again in the intercavity, and that is tracking into the colon. So again, you have to do a CT angio to look for residualism. And if you find that, then obviously you embolize that.
So you could see the younger people are sitting behind. You could see that this is not something where surgeon will go jump. Every time we are talking about CT angio, then you go and do a embolization. Surgeons are only required when everybody fails. So that is the good point and bad point both ways. So this is the patient where colonic massive GI bleed. Obviously, would like to resuscitate, stabilize, then probably try to do upper GI. But usually these people don't give so much of time. So CT angio probably first priority, and then stabilize, and this was the patient having colonic fistula, and your student was bleeding inside this. So this is the bleeding complication. I have tried to whatever scenario we have seen cover, and but try to have a broad area to vision to everybody to understand. Then another very important complication is making up a fistula, GI fistula. So this is another problem which we face, and this are usually they are either they can be duodenal because of the necrosectomy, because duodenum is very close from any part of the duodenum, second, third, or it is colonic. Very rarely it can be gastric. So Dr. Sadaf, can you please?
If you have a colonic fistula, it doesn't become very complicated. And if you have a significant colonic fistula, patient becoming very sick, colonic fistula patient do become very sick, then you might have to give a diversion for the patient. And ileostomy would be a better option.
This thing, procedure
Uh,
you cannot.
we have done it for quite some patient. I don't have much experience about duodenal fistula. They do fistulate and have internal issues, and accordingly you have to take care of the complication. Bile in the drain would be, I would say that it would need, it would warrant an endoscopic ERCP if the patient is stable enough.
So usually if there is a feeding duodenectomy, nothing much is required. If there is no feeding duodenectomy, then you might need to have a nasal duodenal or something for the nutrition. Colonic fistula usually as you said, feculent material in the drain, or there is a colonic necrosis also. So you said you can, in a colonic fistula, a small colonic fistula, there is no necrosis, then you can go ahead. CT scan would be the first thing to do. And you can see whether colon is necrosed, if there is air around it. And if necrosis, I think a colectomy has to be done. Sometimes it's very, very difficult. So ileostomy is there is no gangrene. So this is the, I think, covers most of the complications which are seeing early complication. So this is our data summary of the GI bleed, and you could see that splenic artery is the one which is the biggest culprit to get involved by the pancreatitis. And at the time of surgery, because of the inflammatory mediators, wall gets weak, and then out of 3, you could see that the one died because of March 7 had pseudonuria, 4 DSA, 3 required surgery, and 1 rebleed, and 3 rebleed and died. So this is a very dreaded complication, and it needs lots of support care from other departments, and then very nice team which can recognize the complication at the earliest point of time, and we can do the this appropriate treatment. So another important complication has been this. I am summarizing as this thing, that post-operative complication has been GI hemorrhage. We have found this upper GI or lower GI, so intra-abdominal bleed or GI fistula. These are the complications which are there. So we have to recognize this complication and take care, as we have discussed most of the things. So intra-abdominal abscess after the necrosectomy or recurrence of the necrosis is another, because in one go you cannot do everything. So if there is a patient is deteriorating, you are suspecting abscess, there should be low threshold to have a CT scan, and if CT scan suggests you do a percutaneous drainage or whatever is required. If there is a systemic sepsis in spite of all antibiotics, then you can think about prophylactic antifungal, which sometimes we do it, or do some biochemical parameters which are available today to support your thinking. Wound infection and wound dehiscence after open is another important issue. So coming to post-operative, as I discussed, post-operative intracutaneous fistula, it can be gastric. As I said, gastric is the minimum, colonic is the maximum, and the small intestine very rarely. So these are the fistulae side, colon and duodenum, and it depends on the management, depends on the
symptomatology of the patient. So as we have already discussed, and mortality, please remember, is very high when there is a fistula. So there could be a delayed complications, which can be exocrine insufficiency, endocrine insufficiency, complex pancreatic fistula, pseudocyst, and there is a pseudoaneurysm, and sometimes biliary stricture also. So these all is happening in acute pancreatitis. So this is one of our patient with complex pancreatic fistula. We had to do a fistulojejunostomy. Pseudocyst can be there later on. Patient is gone home and coming back with the some issue, not in a related to sepsis. Then this patient might require some treatment based on the presentation. So I think I have tried to cover all these things. So in summary, about 7 minutes for the discussion, we can take the question. So I can summarize later on. So we can take the questions and then summarize. Any important points from the panelists more you want to add?
Sorry, before you take, for the sake of the young surgeons in the audience, can one of you please explain how to suspect that colon may, suppose you're doing a necrosectomy, how to suspect that colon may be involved, and if you have a doubt, what to do? Stoma, nothing, resection, what to be?
Yeah. The thing most important is when you are faced with a patient with sepsis, the patient presents to you as severe sepsis. You then do imaging to rule out pancreatic infection, necrotic infection. During that study, the radiologist will report to you whether there is evidence of colonic leak, whether there is any evidence of colonic necrosis, such as non-enhancement of the wall. If the colon is necrotic, we need to go for surgery. It needs to be a segmental excision and external derived stoma. The stoma depends on the location of the necrosis. So either an ileostomy or a colostomy, you bring it out as a loop and leave the other side closed and leave it inside. Because most often, because of abdominal swelling, you can't get the stomas up to the surface of the skin. So these difficulties are there, especially in obese populations. Ileostomy is drastically difficult to do, and you have a lot of post-colostomy, post-ileostomy retractions in these patients. So the simple question is, if there is necrosis, resect and exteriorize. If it's a floppy colon, you're not sure whether it's blocked, feel for the pulsations in the mesentery. If there are no pulsations in the mesentery or there are thick cord-like veins, you still excise the colon prophylactically and do an exteriorization. That's what would be my recommendation.
So I think, Rajendra, I could understand such question. Well, what is the
Intraoperative.
where is the necrosome? If it is on the left side, much more which is usually there, and it is going behind the mesocolon, then when you are putting your incision and going behind the mesocolon, sometimes your finger gets stained of little bit of equivalent, but you are not saying anteriorly any type of colonic necrosis or something. In these patients, there may be small hole because of the necrosome or atrophy, because you are doing something, this wall is weak and this wall is little bit less vascularized. Then what you do? In this patient, put a drain there, always you are putting a drain, and important thing is do IVS. Here would be that patient. And second group, as Dr. Rajan discussed, that patient may be colonic necrosis. And I agree that one time you could not, and remember also, if you are not able to remove, take the extract the colon, not such a blind segment is there. And if they are there in the abdomen, this patient is not going to have a good course in spite of a proximal diversion. So it is very, very important that if you are not able to take ileostomy loop, then it is important that you just do an end ileostomy. And ileostomy can be done with a little bit of mobilization. Yes. So any other comments are? Yes, please.
That's one. The second, my concern is regarding patients with necrosis which we manage the ward with the tube drainage. If they bleed, so rather it's a logistic thing. Rather than taking these patients for CT, why can't we just take them to the for a conventional endo and plan for embolization rather than wasting the time on doing the CT?
Yeah, I'll answer both questions. The first question being whether you will do any endoscopic ultrasound for the biliary tract. As you know, in 90% of patients, in the stools of patients who have had biliary pancreatitis, stones have been isolated. But as you know, in pancreatitis, there is ileus. You put in your scope, pump in a lot of air, you will end up with a highly distended abdomen. You will end up with what you call abdominal compartment syndrome. So you don't do it in the initial stage. Early ERCP again is controversial. Only in impacted stones with obstructive jaundice, there is an indication for ERCP in which you do a sphincterotomy and remove the stone. Endoscopic ultrasound, I wouldn't do. I would prefer to do an MRCP because next day I want to do a lap chole. If I do an endoscopic ultrasound, same problem, distension of the gas of the abdomen, laparoscopy becomes that much more difficult. So my preference is for an MRCP.
I think I can just modify his answer. You said whether you are talking about every gallstone pancreatitis. Every gallstone pancreatitis.
Every gallstone pancreatitis.
Because
So mild and
you
moderate.
can operate at the same setting. So even doing an MRCP might be, because of the fluid collections, it may event some. The MRCP may not be good.
The mild pancreatitis, there won't be collection.
There will be
And
collection.
you have to see the liver function test. You have to see the ultrasound. And if you are going to do it, usually MRCP without evidence, without history of jaundice, without history of any type of biliary dilatation or liver function being normal, usually is not
Required. It's not recommended.
Yeah.
Yes.
Recommended is only when there is a jaundice, when you are having some strong suspicion, then only it is required. So evaluation, US can be done delayed. When you are doing a mild this thing, delayed only when there is a history of obstructive jaundice or you are suspecting strong suspicion based on the liver function test. So that would be one. Second, your question that you are going for CT angio, in our institute, nobody will do direct angiography. So CT angio doesn't take much time. You have to wheel the patient, see, because for them also it becomes a good way of targeting the vessel. So it is always recommended CT angio if you are very strongly suspect. Once we have knocked off the splenic artery, because there was no aneurysm, but cavity bleed was there. So we said cavity bleed is only from the splenic artery. So I asked our friends to just knock off the splenic artery. So these are the certain ways. May not be have a 100% black and white guideline, but here are the people. In TJ, at least people will not do straight away.
It will be based on a clinical scenario as such.
Yeah.
How rapid and massive the
Yeah.
bleed is, and what is the quantity of bleed, and then all the, as he said, all radiologists don't believe in upfront conventional angio and embolization. They would like to have a roadmap before.
There's another reason. Is it a vascular erosion or a venous erosion, whether it's arterial or venous, that you will confirm that there is a bleed first from the CT angio. Second thing is, if you have colonic erosion, you get bleeds from the coronic eroded wall. So you can't be sure whether it's just a colonic erosion or it's a pseudoaneurysm. That's why we get a CT. If there is a leak, the chance of an angiography succeeding is higher. And if there is a bleed and you don't find any abnormality in the arterial vessels in the form of a dilatation or an obliteration of the vessel, you have to look for venous bleeds. And that will be triggered only by finding positive evidence of a bleed in the absence of an abnormal artery.
Another reason why radiologists don't do a DSA directly is that you will require a lot of contrast if you are hunting, you are doing DSA without a roadmap.
Yes.
So if you have a CT angio showing a splenic arterial aneurysm, they'll just put in the contrast into that. It will be a limited study and DSA is not going to take much time. DSA again is an invasive procedure. You don't want to spend too much time. If you are going without any roadmap, you will calculate the CDX first, you don't find anything, then you calculate the SLA. So your DSA is going to be much more complicated. So you have to understand from the point of radiologist also that they want to spend less time on the invasive procedure.
So,
I have two questions. They are basically for understanding of the excitation and to serve the antibiotic. When the patient with SAP comes in emergency room, as a junior registrar, how should I give the goal direct therapy? Should I give an empirical only, or should I start invasive at the same time? Number one. Number two, regarding with the antibiotic. In this period, how to differentiate with the inflammation from the infection, so I can decide for the antibiotic.
I'll answer your question. The first thing is the duration from the day of pain. If the duration is late, then it's more likely due to infection rather than SIRS. And the SIRS which is there is because of infection. The second thing is if it's an early inflammation, so patient has presented with abdominal pain and SIRS, do procalcitonin. Procalcitonin does not get raised in inflammation. It gets raised only in infections. So if procalcitonin is more than one, then you go ahead and start antibiotics. That's how you do goal-directed antibiotic therapy in patients with pancreatic disease.
Calcitonin, I think, correct that it will only increase in.
Yes, I checked just yesterday.
Yeah.
And not only that, it also decides whether your antibiotic is working or not. If there is a
Fine, but for pancreatitis, the procalcitonin rule has been deferred now just because procalcitonin is falsely positive in the patient with acute inflammation.
I can give you the reference.
Second thing is, procalcitonin has only relevance if it is increasing trend. So procalcitonin single value, if it is 1, it does not have any relevance, it will be inflammatory. Now you have to see, now repeat it after 3 days, repeat it after 5 days. If this procalcitonin for 1, it becomes 2.5. Now it has a very important relevance, there is increasing inflammation. This might indicate a success. But an independent value.
See, the thing is that like CRP is definitely increases in both, but the procalcitonin little bit different and more so, as you said, you monitor it. The important is at what particular time patient has presented. It has been shown in different studies that in first week usually until unless there is a colonic perforation ischemia, something mesenteric ischemia, which is another component of acute severe pancreatitis. Usually infection doesn't settle. So that's why so many trials have shown. The very nice trials, RCT double branded, 2 RCT double branded have shown that prophylactic antibiotics is starting. We are talking about it with severe pancreatitis. The starting antibiotics in the first go doesn't help, and it is rather more dangerous. So I think it is important that we should know the timing and then try to include other armamentarium and then decide. So just to summarize, nothing to summary, management of severe acute pancreatitis is a multidisciplinary approach. And as I said, surgery is only in failed PCD or this thing. Sterile necrosis, no antibiotic required. Step-up approach is the first choice. MIS is nowadays performed, have lesser complication than the open. Open necrosectomy still has a role in reoperative surgery. So complications are sometimes life-threatening, and a dedicated team, a good team of the SRs, our junior agents are required to recognize the problem at the earliest point of time and take care of that. Thanks a lot for your kind attention.
We come back in 10 minutes. A cup of tea.
आप लोग बनाया है पर नहीं है तो सब लोग
अरे यार मत करो मत करो
that is this. And I invite Dr. Ajay Sharma, sir, professor and head of the department, surgical gastroenterology, Mahatma Gandhi Institute of Medical Science, Jaipur. Joining us online will be Dr. Ravela Pradeep, professor and senior consultant, Department of Surgical Gastroenterology, Asian Institute of Gastroenterology, and also with him, Dr. N. Murugapan, consultant gastroenterologist at Sastra Hospital, Bangalore.
Everybody, at the outset, I need to thank Mr. Kapoor and all the organizers over here for planning a nice theme-based fourth surgical festival and giving me a chance to moderate this session. Apologies to Dr. Anand, I think I have not included his name in this team of panelists. I welcome all my panelists, Dr. Yadav, Dr. Anand, Dr. Desai, Dr. Pradeep, and Dr. Murjan, who are available online.
Okay. Ajay Sharma.
Dr. Ajay, sorry, Dr. Ajay. I'm sorry.
People will also start calling them.
So, I just brief background for some students, if around. That chronic pancreatitis is a chronic irreversible disease with morphological changes, inflammation and fibrosis, structural stones. They do due to the Tigaro hypothesis of the etiopathogenesis, where toxic metabolite and other as described criteria are important. There is a damage to outflow and early activation of the enzymes autodilation, stimulation of pancreatic red cell and fibrosis, which lead to most of the symptoms. The main presenting symptoms, noise. The main presenting symptom is pain, and the treatment hovers around the pain. So all the complications would be related to pain. I need to put a disclaimer that as such, there are a lot of complications associated with chronic pancreatitis while you're operating. But it's an area of ease and I'm talking in terms of exact course of complication, except for something related to recurrence of pain, which you counsel your patients pre-operatively. The other presenting symptoms beyond pain would be the weight loss, diarrhea, vitamin deficiencies, frail thin-built patients, the common patient come across, and over the time the damaged pancreas doesn't produce enough insulin, there will be diabetes. There may be symptoms related to gastric obstruction, there may be dehydrated in these patients, and they may be presenting with obstructive jaundice or symptoms of cancer in the pancreas. Can we get the quality of is it okay the quality of voice? Not the primary cause of pain is usually duct obstruction, hypertension, active inflammation over there leading to pain, tissue ischemia, and altered nociception. The secondary cause will be related to giving pressure symptoms which you need to decompress, stricture, and then visceral neuropathy due to diabetes and hyperalgesia due to chronic dependence of drugs. We usually measure the pain based on Isabecki's scoring system, which takes into consideration four basic parameters, and then you try to target the disease output based on these symptoms or intervene based on this score. It's usually diagnosed on ultrasound, CT, MRCT because they pick up the disease rate type of 3 and 4 disease, but some early disease need endo ultrasound, which is an important role in diagnosis, where you can pick up little dilatation and cyst, hyperechoic ductal margins without dilatation to point towards symptoms are due to chronic pancreatitis. Majority of the time, the patients go untreated till when they come with presentation like this. Less number of time you have this kind of presentation, a small dilatation or a hyperechoic wall of the duct, and you are eager to diagnose it early. And this is the severity of the disease, usually use Cambridge classification. And each is a baby of equally, as we discussed, acute pancreatitis is the baby of more of medical gastroenterologist, and so is the chronic pancreatitis. And the disease is usually surgery is indicated in a step-up manner where you have pain and the therapist or the medical management fails. There's also an upcoming protocol of early surgery in these patients. And of course, there's surgery for complication. So this is most of the people take guidance from this kind of working formula that initially you try to control pain with medical management, endotherapy fails, or just small duct disease and the pain is severe, you need to have an upfront surgery. So coming to the surgical target, when we operate on the patient, we think about giving a better pain relief, preserving good amount of endocrine and exocrine function, rehabilitation of the patient so that he has a better quality of life. And surgically, when we come across the procedures, we have major description of three kinds of drainage, the resection and the combined procedure where you combine resection with drainage. So luckily, chronic pancreatitis is an area where you don't have much of complications post-operatively. Very rarely you may have a post-operative bleed, but most commonly the problems come across once you're operating on the patient. So you take a call between all these procedures based on your resection procedures, the drainage procedures, partition blocking is the one we do commonly. The combination procedure, the phrase is being done more frequently by many centers. Then the Vegas, the Burmese, and then you can do a total pancreatectomy or distal pancreatectomy. So coming straight to discussion of what all problem do we have intraoperatively. We'll take it to case capsule. This is a young female who is 30-year-old. She presents with you with jaundice. She has a long history of pain, which is not that specific, but she has pain and it has been treated over the counter with PPIs and all. And she did not find much relief in that. She has history of some amount of analgesia. C19-9 is normal. There's no family history. So her picture is like this. She has a dilated biliary tract as well as she has a dilated tract with filling defect. So what would be your protocol? I would put it to Dr. Yadav. Would you tailor the procedure as the patient merits, or you think that one best operation for all, as I hear in most of the conferences, is that phrase is a better answer to most of the questions? And if you are a proponent of phrase in this particular patient, and if you don't want to add another drainage to the tract, then what usual problems or surgical risks you have while doing phrase, so that we tackle with the intraoperative issues while doing phrase?
So, if you see, there are two problems. One is this picture in the common bile, lower down, and secondly, dilated pancreatic bed. So, I'm not sure how symptomatic is the chronic pancreatitis. So, if a patient has medical therapy, obviously there is no history of jaundice. So, only non-eccritic picture is there, which is sometimes a very small.
No, this is an eccritic picture. She presented with jaundice.
Presented with jaundice, okay. So it presented with jaundice and there is a pain also. So little bit of tricky this situation is that some people would say that let's have drain the pancreatic common bile duct and wait for to see that whether the pain is the pancreatic duct is also same type of pain it is producing, or the pain is classical pancreas pain. If pain, we are sure that pain is because of the chronic pancreatitis, then I think the best procedure would be normally, I normally don't do LPG now since the beginning, and I will tell why. And then, since there is jaundice in the preoperative period, this patient usually pouring will not be very effective, not take care of jaundice. So we have to pour the head and do this drainage of the gut. Simultaneously, we have to do some lateral this cholecystectomy also. I am doing cholecystectomy. Why I am saying, because once there is a jaundice beginning, only picture is a different scenario. Once there is a jaundice, it means this picture is very significant. And yeah, whether we should go do a drainage procedure like put a stent, then go for pancreas would be a little bit controversial decision. But
In this patient, I would prefer doing
Okay, we agreed that you took an option of doing a double drainage procedure, plus you would like to do a phrase for, because you do it for reasons. And I think I will not take a call of putting an this thing, ERCP drainage, because she's not in cholangitis.
Yeah.
And
Of having some sort of issue. So it's better. It's very nicely take the same loop and take it to the gut area, and it is about 10 to 15 centimeter away from the TJ. And nicely in the same loop it can be drained. Unnecessarily opening another system like duodenum, and lots of scarring sometimes present in the duodenum because of the continuous pancreatitis. So when I have to drain, I probably can go a little bit higher so that serous area in the gut as well as in the jejunum is nicely going and sitting there, and take another extra 20 to 25 minutes.
And if this lady did not have any significant jaundice, but she had leaky grace, ALP, and mild picture, you would manage it with phrase. So, what would be your surgical complications which you can anticipate while doing phrase? And
So
what would be the, how would you tackle them?
Clinically, there is a stricture, but there is no jaundice. Then we do a put a tube in the duct, cystic duct, and after plate procedure, we push contrast and try to see whether it is freely moving. Because usually these small structures which are not getting active, they will respond to the this coring procedure. And the problem in the coring is one that there is a, because you are coring the head, it is a blind thing. So you might have lots of bleeding, pancreas is such a vascular organ. So bleeding is the bipolar cartilage, and use the bipolar cartilage to control the small spurters. If little bit bigger spurter, then we take some 4 or 5 PDS inside the duct and we take a suture. So that is the.
Luckily, the timer is not telling us anything. It's staying at 60 minutes as of now. So you can add to it.
Yeah.
You can continue.
Okay.
So he put up a very good point. And regarding if you take a lead from the cystic duct and you find a stricture over there, which is not a very serious kind of stricture, and phrase operation can tackle the stricture as well.
Small strictures which are not.
A little dense fibrosis around, it takes simultaneously care of. So, anything else you would like to add?
So in the just beginning, since you asked, so we know that we do a good cauterization. So left hand is lifting the pancreas up. So it's not in that the retroperitoneal, which is left hand is lifting. And we just where this gastroduodenal artery goes and bifurcates anterior posterior. In that area, prophylactically we take a suture because it crosses, it becomes dorsal pancreatic artery and it crosses the pancreas through and through. So when you are coming from back to the head side, then there is lots of bleeding. So that is one thing precaution. Second is we take a suture about 5 to 6 millimeter away from the medial wall of the duodenum. Hemostatic suture. And they become a guide also when there is a bleeding. So we are not going more medially and injuring the duodenum. In the inferiorly, we are not going more toward the SMB, and that is a guide also. And then you go bit a bit. Don't take it one go suture. Bit a bit suture, slicing the pancreas and going depth, and posterior wall of the duct is our limit.
So exactly what Dr. Yadav has put it very nicely, that you have to tailor the procedure according to disease morphology and localization of the symptoms. There is a concept of, as he rightly said, that he prefers to do phrase procedure. In our series also, we take it 60% of the patients are phrase, but it's not that we do away with pancreaticogynostomy alone, because we have some patients in whom LPJ is required. And it is always a must if you have a lot of head dominant disease and inflammatory mass over there where you are sure that's only inflammatory, because it can move all stone strictures in the head area. And the trick as he rightly said, is to do a safe procedure is to core the head in bits instead of in making a big bleeder over there. And you have to restrict your coring up to posterior duct wall. Some of the aggressive coring people actually go up to the posterior capsule of the pancreas. But once you go more deep inside, you have the risk of injuring the bile duct. So as it can take care of bile duct stricture, so it can injury, you can find bile living surgery. It's a procedure which can have excessive bleed. And of course, you lose the last hope of treating surgically the patient of pancreatic cancer if you have not differentiated the mass appropriately. So you need to have an adequate mobilization. You disconnect the gastroepiploid. You take away all of the mesocolon up to the duodenal base. The anterior head and the ulceration should be exposed well. You put your left hand behind after an aggressive cauterization, and you can buy time till when you suture the bleed. Usually, all of us who practice chronic pancreatitis is just a pinch in between your back of hand and the thumb that you expose it nicely and give a suture, an accurate interrupt suture over there. You have to anticipate in a congested, inflamed pancreas bleed. And while pouring, is appropriate, as you said, that you should take sutures all around the C loop by up to 5 millimeter margin. And in case it's still bleeding despite of those sutures, then you should, as you rightly said, that ligate the anterior superior branch of the pancreaticoduodenal artery, or even sometimes you may have to do it with the GDA. So this is how a good coring can be done, and you should have a good control while operating. And these are the areas where you put the suture. To avoid bile duct injury, you should actually believe in doing a sharp resection once you're coming to the area of a lot of cautery coagulation going. But if you want to release a stitch in particular and you want to go beyond the area where there's intrapancreatic portion of the bile duct, then you should use tweezers over there. And then if there is a significant EHBO, then he said that you can take a guidance from CBD catheter, which was actually placed if there was cholangitis, so that you avoid injury. And if you see bile during surgery, you can just make the opening big instead of attempting to repair it because you're going to create an occlusion. If it's a significant stricture, of course, he said that we add a second drainage, the hepaticogynostomy. And this opening, once made bigger, can be tucked around to the fibrotic pancreatic tissue so that there's a free flow of bile. You want to take phrase as your procedure to take away the stricture as well simultaneously, and then you can take it in the one group of pancreatic osteomy. Of course, phrase has shown outstanding results. Most of the studies claim to have pain control beyond 80% or around 80%. So this is another patient who's a young lady, 20 years old, significant chronic pancreatitis pain, no icterus, no complications, and a straight away duct which is dilated. And you can see there's no significant head over there for pouring. So I would like to take other panelists. Sir, is there Pradeep? Dr. Pradeep is there?
Pradeep is online. Pradeep and Murugapan are online.
So I think Dr. Pradeep can take this question that what is your appropriate area of opening the duct if you want to know? Would you like to do an LPG first? I would like to know in this patient. I think he's not there.
List of participants दिखाएं.
Hello.
Hello.
Can you hear me?
Yes, sir, we can hear you.
Yeah, I couldn't get your question. Can you please repeat the question?
This is a young lady who's 20 years old and she has significant chronic pancreatitis with a dilated duct and strictures area at the neck. And she has no icterus and no other complications of chronic pancreatitis and no significant head mass or bulky head or disease in the head. So would you like to do an LPG with this? And what would be
I would like to, because young female and as of today, current guidelines, based on current guidelines, I would first offer a conservative medical management in this patient before I decide for
She has failed with conservative management. She has severe significant pain on and off. And this putting her on analgesia protocol, the usual protocols we follow because we are focusing on surgical complication. She qualifies for surgical procedure. For 6 months, she is almost taking an analgesic every second day. Though she has likelihood of failure post procedure, and an important part would be counseling, she has a lot of drug dependence.
Okay, I can't see clearly the CT picture. Does it have multiple stone strictures? Because to what I could see,
No,
only the duct is grossly dilated.
yeah,
That's all.
the duct is grossly dilated. She doesn't have multiple stones or strictures. So simply dilated duct with no add-ons like a distal disease, lot of stone in head. So would you do a Partington Lodge's LPJ? And
If the
what
head is
would be a
bulky,
technical? Yeah.
if the head is bulky, I'll go and do a coring. But if the head is not bulky, probably one can get away with. Sometimes you do encounter that the head is not bulky, not or even atrophied. In that case, a good drainage of the pancreatic ductal might be adequate in these patients if there is no inflammatory mass.
So where would you exactly like to open the duct? Because you have the parenchyma is almost very little, and if you want to avoid injury to portal vein inevitably, and yes, the dilated duct with little parenchyma around, for the knowledge of the student, what would the safe way of opening the duct for LPJ? And how would
The easiest way, there are many ways to open the duct. The easiest way, if the pancreatic parenchyma is less, duct is dilated, you can just palpate, you can just feel the duct on the surface of the pancreas and put a needle, aspirate, and then open. It's much easier to open. The biggest challenge comes when you have a small duct and a big gland. That is where you will encounter problems. When there's a small duct and a dilated duct, much easier. If a stone is there, it again makes your life much more easier because you just bang on the duct, stone you can date. When you cannot find in a big pancreatic gland, small duct, I rather go start coring out the head of pancreas, and then you can get into the duct much more easily. From when I start coring, you will enter the duct.
Okay. So Dr. Anand, Dr. Ajay, this is a straightforward case of dilated duct with little structure in the head area, and she has got pain, and you have thin parenchyma. So which is the best side to open the duct so that you have less complication?
Obviously, as Sir has said, you will find the duct, the uppermost portion in the pancreas. Even palpated with the stone, it becomes easy. Head coring is one method which everybody should know to identify the duct. When you core the head at the region of neck, you will find the duct opening, from which you can then extend the duct onto the lateral wall.
So the ideal place to open the duct is
Beyond the neck.
Beyond the neck.
Beyond the
You should go on to the left side of the neck, and then once you are safe at opening it in between two sutures, then you take place multiple sutures, because once an inflamed pancreas, we talk a lot of about bleeding during pouring of head, but we actually have bleeding even when you open up the duct in left pancreatic nostril. So usually we keep for technical ease, pre-placed sutures, you hook them up, and if an area bleeds, once you cut it open, you tend to suture it and control the bleed at the cut edge.
For most of the beginners, you should understand that why it should be coring or beyond the neck, because in the neck there lies a portal vein just posterior to it. So in the attempt that if you injure a portal vein, there is no replacement for that divide other than dividing and then repairing the portal vein. So that area is non-retrievable. So you have to do either to the left of the neck or to the right of the neck, coring and then identifying the duct, or onto the left side of the body.
So palpable duct without coring can be opened up onto the left or to the right of the neck, and then you have to go beyond. So the important key point over here is that you have to keep in mind that you can injure your portal vein in a very thinned out pancreas with little parenchyma around, and you should be mindful about it. So now this is another patient who is 38-year-old male. He has pain abdomen, which is severe in nature. He doesn't have any jaundice. His CA19-9 is slightly elevated 67. He is diabetic. He also has symptoms of exocrine insufficiency. And this is his CT imaging. He has a mass in head of pancreas. And if you can see over here, and a dilated duct system. So you have few more cases where you have to take a call about malignancy in chronic pancreatitis. Very important subject. Where would you like to take a call of pancreatic duodenectomy? Beyond management of pain, we all know that it has a role in management of pain also. So in this particular patient, would you give him an the benefit of doubt and go for Whipple's as I did in this patient, but histopathology did not show any malignancy. Many a times we know that's a straightforward case of CA head of pancreas with CCP. But in a tricky case with a mass like this, or a bigger mass like this with lot of necrotic area, very high CA19-9 1700, with almost most of the features suggestive that this is malignant, a loss of weight, appetite, but having a severe pain. So you have multiple cases where you come across a mass-like lesion. And this is another patient we operated upon. Is that again an inflammatory mass? So I would like to know from doctor. Will discuss these cases later. Sometimes the patient may also present with GI bleed, which is recurrent. In upper GI endoscopy, it looks like hemosuccus pancreaticus. This man is from a remote area who has recurrent bleed, and he has been managed conservatively with repeated upper GI endoscopy at a local hospital. Then he comes to us, and this is what we find on his CT angio. So, Dr. Desai, I would like to know from you that how exactly you take a call about taking a decision whether you want to go for an inflammatory mass associated with chronic pancreatitis or a malignant mass, and what procedure you should be doing. And sometimes if you go with an old imaging, you get surprised on table by seeing a mass, and you need to differentiate it whether it's inflammatory or malignant. And thirdly, I would like you to address that how challenging would be pancreatic duodenectomy, what would be the intra complications when you want to attempt it for chronic pancreatitis.
This is a difficult problem. Every pancreatic surgeon is going to come across this problem. Now, there are certain features in the history which should point you towards malignance. One of them is significant weight loss, obstructive jaundice in an elderly individual with a bulky head of the pancreas. Here, and there is gastric outlet obstruction. These are late instances and they are of not much use to a surgeon if the patient has come to him early. When you face this problem of a bulky head, doubt of malignancy because he is elderly, weight loss is there, you want to think of how am I going to prove that this is a malignant mass. We have certain investigations that we normally do. One is the thing that we go to now is endosonography. Endosonography, we do plain endosonography, digital image analysis of the endoscopic ultrasonography. We do elastography of the pancreas using endosonogram, and we do contrast enhanced endosonogram. Now, with the first instance, where you do a normal CT, up to 2 centimeters masses can be easily identified by a endosonogram. Endosonogram nowadays also has a possibility of doing an endosono FNA or an endosono biopsy. You can do either an FNB or an FNA. FNA is less accurate, but if it is positive, it is 91% specific. The other thing is, if you get an FNB, people say, why don't you do a frozen section on table? It has been shown in carcinoma of the pancreas in chronic pancreatitis. If you do a frozen section, it is not reliable, even if you do a core biopsy transduodenally. So endosonographic fine needle aspiration fine needle biopsy is probably the way forward if there is a clear-cut mass. If there is no clear-cut mass and there is a dirty head, you're not sure whether it's malignancy, you then do endoelastography. This can be color-coded endoelastography, where a blue signal indicates a hard mass, a red signal indicates a soft mass, and a green signal indicates an intermediate mass. Obviously, because of desmoplasia, carcinoma is the hardest of all the entities that are seen. The other advantage of endosonography is that it will identify microcysts in the head of the pancreas. You can also trace the pancreatic duct and the bile duct. If you see a thin tapering and a narrow tapering of the pancreatic duct, the reason is most likely to be chronic pancreatitis. If it is an abrupt closure and there is an irregular nature of the duct, then you can suspect that it could be because of malignancy. Now, just color coding is not sufficient and confusion is rife in such cases. So we do endoelastography, we do quantitative uh, ratios of elastography of the mass versus elastography of the normal pancreatic tissue. There it has been found that you get a 1.68 ratio if you do an endosonogram in a benign lesion. In chronic pancreatitis, it goes up to 3, while in case of malignancy, it's as high as 18. So this is one way of differentiating whether you have a pancreatic head cancer. The other thing is you can do a cutoff for the, you can look at whether there are microcysts visible in the head of the pancreas, which will put it more in favor of pancreatic chronic pancreatitis. The other test that you can do is an MRCP. MRCP, the advantage of MRCP is you can study the ductal structures very well. If there are ductal structures in the head of the pancreas, it's chronic pancreatitis. If there are no ductal structures and there is a mass-like lesion, which is hypointense on T1 and hyperintense on T2, you can think of malignancy. Also, there is diffusion-weighted imaging of the pancreatic head done by MRI, where the amount of fat which is present in pancreatic cancer is more than the amount of fat present in chronic pancreatitis fibrosis. So if you have more fat, it's more in favor of malignancy. Then a routine CT scan is helpful if it shows evidence of lateral spread, if it shows a deformity of the portal vein, then it's more likely to be malignancy. It also hints at the difficulty which will be found if you do these cases when you are trying to do a pancreatic duodenectomy for a suspected mass, which could be either chronic pancreatitis or malignancy. The other thing that one can do is, in these sort of situations, is to do the contrast ratio. You administer contrast, you do an arterial phase, a pancreatic phase, and a venous phase. And in the arterial phase, it is seen that in malignancies, the enhancement is not significant, but the enhancement is incremental. If the enhancement is less than 0.17 as compared to normal parenchyma, it is more in favor of malignancy. The other thing that has to be observed is that if the gradient in pancreatic tumors is that the pancreatic tumor starts accumulating contrast and the contrast increases as time goes on. While in chronic pancreatitis, it is increases and then reduces. While in case of normal pancreas, it is a washout, a rapid washout. So this is how you can differentiate the clinical picture.
So thank you very much, Dr. Desai. The message is that you should avoid a surprise on table. By and large, if you have a imaging done quite some time before, there might be many number of patients who might be having exhibition of pain and inflammatory mass over there, but few of them may be harboring malignancy. As you rightly said, that based on clinical signs and symptoms, things become very easy sometimes. Yes, based on history, there's significant loss of weight, appetite, and then the patient has jaundice, icterus, which is more commonly seen, but it is equally seen in biliopathy and edema around the duct. And you have to have investigations which should be practically available. And maybe the elastography and the enhanced endo-US may not be available to most of the centers. But a simple CT, as you said, and MRI with diffusion restriction would give you some pointers toward the masses malignant or benign. Very importantly, we did not put up any cutoff levels for CA19-9 because we have been seeing, if I would say about this lady, whom we did not operate because it looked like encasing the vessels. Actually, after adding antibiotics and doing an FNA where a lot of pus was aspirated, she had subsequently a decrease in her CA19-9 by few hundreds and then again increase. But it looked like that she has a malignancy which is unresectable. We still did not get the biopsy, as again he said that many a time the biopsy or the frozen section may not be the right kind of an answer. You have to do an extensive evaluation of the specimen. And sometimes you might have to do it for based on the resources available. If today's era we need to have a bleed, we can do it with angioembolization and subsequently take care of pain. This patient had extensive pain due to chronic pancreatitis, and we did a 2-in-1 kind of a treatment of aneurysm as well as the chronic pancreatitis. And sometimes a chronic pancreatitis may not be harboring only mass in the head, but it may be a mass in the tail where you need to go and dissect it. But the key thing is that with all those that he has said, I will not repeat it, that you have to look into those signs wherein you think that there's a duct penetrating sign which is smooth or irregular in inflammatory and malignant. The side branches are more dilated in the benign. And then the parenchyma ratio is grossly dilated in malignant. You have displaced calcification in the malignant. You have a double duct sign, which is a very common sign, which may or may not be very accurate. And your vessel encasement is peculiar in malignant as compared to benign. The ratio of SMA to SMV actually changes. The SMA becomes more bigger. So having said then, endo ultrasound has to be the gold standard to take an FNA and try to look into whether it's malignant or not. Because at the end of the day, chronic pancreatitis malignancy does not have a very high benefit of survival, you can say. And the challenges while doing operating on a patient chronic pancreatitis with pimples is very high because it's very technically demanding. There's all fibrosis around. Even a simple making of tunnel may create a lot of bleed or a vascular injury. And you have to have a highly skilled pancreatic surgeon to take care of this area. Very important message for the beginners. You are also likely to come across a lot of portal hypertension in chronic pancreatitis. So it's not a matter of opening of duct and boring a small area in the head, but it's a matter of doing an extensive surgery where you have to mobilize so many things. So these are the problems. You have to be well versed with taking care of bleed from the congested vessels if there's additional subclinical portal hypertension in these patients. And you may have a sudden bleeding while tunneling the superior mesenteric vein. But if you are properly and accurately cauterized, is as I said in the previous case, just a pinching in the in between and a fast division of the neck or other division of the vein under the clamp. Are the two options as Dr. Ajay has said before. And of course, we repair the vein with very fine sutures, with very watertight kind of thing. Now going to another.
The next, can I just two or things important for all the beginners. Take it as a rule that CA19-9 in chronic pancreatitis is not a marker of malignancy. The most common mistake.
Yeah, that's what I told them that you have to
whatever may be the level. Some people say that it is 1,200, so I am worried. Some people say it is 5,000, so I am worried. No, don't take increased CA19-9. We have got a reference from a patient who was operated elsewhere undergone a PD for a CA19-9 21,000 and biopsy was negative. So that has actually after that we have read it a lot and we have realized that CA19-9 is not a marker and saying it so emphatically to you. Second thing, it has been very well said that they are very good markers on CT, MR, but to read from a book, they all look easy. When you see it on CT scan, it becomes very difficult. It normally takes 15 years to understand what book has written and what CT is showing. So it is not easy that you differentiate on CT scan or MR. And more difficult area is when, as I said, that Desai was saying endoscopic USG, it looks easy endoscopic USG, but even the best of the people in specifically in case of chronic pancreatitis with inflammatory mass in the head, it is not easy to go into the duodenum. Beyond the fibrous, the endoscope does not enter. And then to turn it, and then to fix it, and then to identify the site, and then to scan the entire inflammatory mass, it becomes very difficult. So you have to, as Dr. Kapoor said, tells us most of the time my residents are here, they will agree. It's the time which tells some time. In spite of your best efforts, you can't identify it. It's the time which will tell.
Exactly.
Yeah.
In the
What point I'd like to emphasize is if you have confusion whether it's malignant or not malignant, treat it as malignant. Because in largest series of pancreatic duodenectomy, incidental pancreatic duodenectomy for chronic pancreatitis assumes only 5 to 6% of cases. And if you lose out on a patient who is resectable and wait, you're going to end up with a patient who's going to die on you. And he should not die just because you have not been aggressive enough to remove the head of the pancreas.
So that Dr. Murugappan also is on.
Yeah, so I have, we would have another set of patient for him. Dr. Murkan, we have another young lady who is 17 years old with severe pain. Lot of analgesics are dependent. I have those, will not go into discussion of how to decide on surgery. I ask them to keep a record, either they are referring for medical G for long treatment, or we see whether they merit surgical intervention or not. But I am counseling her many a time that I will not operate on you because her duct is very small. I am a surgeon who is looking for better size duct. But then I am compelled by the patient that if I have even 50% chance of recovery and I should operate on the patient. But you go into and operate upon the patient, this is again an intraoperative issue. You start sweating for at least half an hour, 45 minutes, and you prick here, you prick there, and you are not able to enter the duct. But once you are senior, you know many more methods about how to get into the duct and what all to do. So, Dr. Murgan, if you are there, you can please elaborate on how would you take care of such patients when the duct is not formed while operating on the patient? Like
Yeah,
few of such cases are there.
Yeah, so this is the subgroup of chronic pancreatitis called the small duct chronic pancreatitis. It is variably defined. Some groups put it as duct less than 5 mm, whereas other groups call it as the duct less than 3 mm, a non-dilated pancreatic duct. The usual methods of identification of the duct, like the palpation, digital palpation, or use of a needle aspiration of the pancreatic juice, or palpating the stones, or for that matter, even a intraoperative ultrasound, which is used as an adjunct, may not help us in identifying the duct in these cases. The primary reason being the head being the pancreas being woody and indurated, and it being bulky, you're not able to locate the duct. What we have found to be successful in these cases is to forget about the duct once you have gone in with the plan of doing a fray, and I go in, get in, do a proper complete cauterization, identify the SMV, identify the portal vein, ligate the GDA either in continuity or after you have isolated it, and take these sutures along the pancreaticoduodenal arcade so that you're clear on the tissue that has to be cored out. And so now, with the surgeon's hands, fingers being behind the head of the pancreas and the thumb on the anterior surface, one is able to palpate the thickness of the tissue in the head region. And then, as others have mentioned in the panel, to start with the coring. But one point I would like to make here is adequate preparations that need to be taken before one starts the coring. At least have 240 prolines on long needle holders ready, one 5 core suction, the assistant being ready with the suction, and start the coring, start off with small slivers so that you're able to control the bleeders as and when you identify them. So the bleeders can be controlled with the surgeons.
Voice is gone. Your voice is gone.
Using the proline, these stitches can be taken and the bleed can be identified. So as you go with the coring, you identify the duct of the Versen, and once the duct is identified, then one can use either intubate the duct either with a.
I think we have some issue with audio, though his visuals are there. So as he has put most of the things in the right perception, for those,
Available to do the anastomosis
yeah.
quite high. Um, it's as in a 3 mm duct, when opened up, will give us a length of around 1 centimeter.
आपके यहाँ आ रही है आवाज, इसमें क्यों नहीं आ रही है?
Dr. Mulkar, we cannot hear you, but we have taken your points well. You have put forward most of your points. And as he rightly said, that many a times they might not be very helpful. But sometimes you have a 4 mm, 5 mm duct also, which is not very dilated, becomes very difficult to locate it with just palpatory method. And so you need an intraoperative ultrasound. And if you are having still smaller duct, then you can start with coring of the head of the pancreas, and sometimes somewhere down the lane, you will have an understanding where the duct goes. You can give a direct incision on a palpable stone, as you rightly said. You can incise, or you can say excise a full thickness of the duct and see from the distal area whether you can probe the duct and come retrograde and open up the system. And if the duct is small or a side branch disease and severe pain, and you've decided to operate on the patient, and patient is every second in hospital, I must have come across at least 5 to 6 such patients in a denominator of 200 plus chronic pancreatitis surgery, where we had no options other than going in and giving the chance to the patient. And I tell you that the Isabekis procedure actually fetches good result. The lady was so surprised that she did not have pain. I had counseled her that you have drug dependency, you are likely to come back with pain, readmissions. I could not trace her even for her imaging this time. She had a rubbery pancreas, hardly any duct being seen. I just poured out the head and gave a V incision on the rest of the parenchyma. Mine was a broad and a heavy lady, and you have to give the amount of V incision based on the size of your patient, and just give an on-lay pancreaticogynostomy in these patients. You do come across such cases, and these are the ways of we handle small duct disease. If some of the panelists want to add some more points regarding small duct disease, we can add and then take questions from other audiences.
Yeah, the SVK's procedure, it's not audible, is actually defined for a very limited duct line onto the pancreas. What now? What you're telling is a much more difficult area where you don't have a duct. When you don't have a duct, you can't see the duct, which is less than 3 mm size. So in that case, it will not come under the definition of SBK, but it is just coring of the pancreas. You expect the second order ducts to drawn into the opening that you have made. So that is actually to decompose the pancreas and it relieves the pain. What you said is very correct, that this has a equal or even a better result in pain relief, especially in the patients in which you have a dilated duct. Because in this group of patients, it is not the intraductal pressure that is the cause of the pain. Rather, it is the inflammation in the entire pancreas that is the cause of pain, which is as in other chronic pancreatitis, the inflammation in the head of the pancreas that is the most major source of pain, which is indicated by protein. It is always storing of the body and tail. I think.
It's like that. I mean, to make it a point that you don't give all trans thickness suture. Your anastomosis should restrict to the capsule only with limited ischemic add-on effects.
Audience can you raise one, which is yeah.
Yeah, Dr. Pradeep, would you like to add a point on small duct disease, sir? Because the online
Yeah,
audio
yeah.
is
I think small duct disease. Most of the surgeons are hesitant to operate, and they try to push medical management. And endoscopist also is not interested in small duct disease. Those are the cases which they actually ask the surgeon to handle it. So I know it's a very difficult problem to handle, but still I think you can still get a decent amount of results if you do proper drainage of the system, where you might not get the duct anastomosis, you might have to attach to the capsule itself. But the biggest challenge would be identifying the duct. Now with the use of intraoperative ultrasound, or you can just start if the gland is slightly bigger, you can just core out and you can get in the head region, and then retrogradely you can get into the duct and then anastomosis. But the problem would be you can't do mucosa to mucosa anastomosis in many situations. You take in a capsule and that is sufficient to, and you do get a decent amount of long-term results, though it is inferior to compared to a large duct disease.
With Dr. Pradeep making a very valuable point. Can we have some questions from the audiences? Somebody wants to make a comment? Nothing is easy. Those who are doing it, no.
So the section is difficult in CP, but anastomosis is easy and results are better. It is non-secreting, but it doesn't leak.
But you have to modify your technique of making the region. You have to lay open the whole of the duct and make an anastomosis. It's not just on the stump of the.
Yeah, but you have some references for that?
Yeah, I have.
Because I have done quite a few CA head of pancreas with chronic pancreatitis, and there is like a tube over there in anastomose. I have anastomosed it with L2. I don't know whether
inside.
Yes, stasis over there. Stasis over there may be a possibility.
I think both of you are on the correct platform. Only thing is that the point is different. If you have multiple stones in the region of body and tail, you have to lay it open for the entire gland. What you have said is patient is having a dilated duct and not having, it is having only obstruction in the head of pancreas. Simple PD will do as we do at normal anastomosis. Not a couple of questions like that. Oh, that's time is over.
Is one of the senior most surgeons of the country, and he told me that he's still very active, and he was to be in Jaipur for some, I think, social or family, but he saw the program and he said, I must attend. Thank you very much. He wants to know.
I know Dr. Kapoor for last almost more than 40 years. No? SGPGI, I met him at SGPGI almost 40 years back, and since then we are friends. I would like to ask you that in chronic pancreatitis, in spite of doing all this, sometimes the pain does not go away. So do you do any additional procedure like sympathectomy or excision of the, the lymph nodes there around the pancreas to take care of the pain,
No,
which is not getting relieved?
Like you want to say that pancreatic flap denervation kind of thing, we don't
Yes.
add it intraoperatively, but quite a few patients may come back, and if they come back with 1 or 2 episodes in a year, it's okay, we admit them and give a routine protocol of IV fluids. But those who have persistent pain or failure to respond, we try to tie it up with celiac clock. A celiac clock, it gives us some time buying for 6 months or 8 months, and many times they do settle them. They do settle with 1 or 2, but if the pain is very chronic and debilitating, then the next step would be, as you said, that you can go to pancreatectomy, and all those options are there. But I personally don't believe in redoing the procedures unless I pick up a malignancy in my follow-up case of Graves or a follow-up case of LPJ, where I think that I can possibly resect it. And I have done few cases resection.
I totally agree with you, but recently I read that small dose of irradiation also helped in relieving the pain of pancreatitis.
Yeah, maybe, but we are not using it as of now. We are using it celiac axis block.
Able to quote that article.
In fact, a total pancreatectomy can be an answer even
Yeah,
for that disease. We did not
answer,
discuss
yes.
it previously, as well as for those who have recovered.
Now slowly this total pancreatectomy, autodigestion
coming
and
back
the
again.
islet implantation is slowly increasing. I think
Coming
Dr.
back
Pradeep will be able to tell us. His group is doing that.
Yeah, and JAIPUR group is doing a lot of total pancreatectomy. They are showing good results.
Yeah. So I think the problem with chronic pancreatitis going for a total pancreatectomy is the amount of islet cell yield will be much less. That's a challenge in. So if you want to do total pancreatectomy and get islets for patient to become euglycemic, you really require 3 normal pancreas. So only then the islet value will be that much. So that is a challenge. But we have done few about, I think about 12 patients where auto transplantation was done, where the patients required insulin, but probably the smaller dose of insulin. In those patients where we have done a distal pancreatectomy, those were the cases where we have selected and found. The challenge we faced was the amount of islets we get in a fibrosed pancreas is much smaller than actually a normal pancreas. That's a challenge we faced.
Correct, rightly put it over there. Those who are not diabetic, then you can have smaller doses. Those who are already diabetic and already on higher doses, so you have to weigh your patients for chronic pancreatitis, total pancreatectomy. But there is an upcoming trend of using total pancreatectomy more frequently with the present era of very good endocrinology support, and it can take care of recurrent pain. But as of now, I haven't read any article where you add a procedure while operating that you don't take care of the pain not coming back again. And those, if you take hardcore recurrent pain, that subset of patient 200 would be only 5 or 6 or maximum 8, not beyond that.
The other thing I would like to see is when a patient already had an LPJ or pancreatic gynostomy, if he comes back with pain, we should first evaluate properly because the pain might not be related to the pancreatic origins, which we have seen in a couple of patients. The second is you have to evaluate whether the drainage is adequate or not, because sometimes the drainage might be incomplete, only they might not have drained adequately the head. So we had few patients where we have redone the procedure and then we completely drained, poured out the head. So these are some of things we should not forget rather than condemning a patient that it's a failure of surgery, particularly when you are not involved in the first surgery and you do not know what the surgery was done.
I've encountered the patients who have been waiting for the surgery, but in between they come back with observations. And then when you do amylase lipase, it's very high. So now in that case, would you proceed with the the drainage procedures or you wait again?
That should not be done. You have to wait until the inflammation comes down. I've had a situation where one of our colleagues proceeded and did a phase procedure, and then he went into pancreatic necrosis in the postoperative period. Luckily, we had tubes in place. We just started irrigating the tubes like a Bejer's procedure, and the whole pancreatic cast came out one day from the wound, and the patient settled down. But don't expect such good things to happen.
How long do you wait?
3 to 4 weeks, and give octreotide to prevent any further episodes of inflammation.
And reevaluate with the CT or
Yeah, if you have reevaluated CT and if you have that kind of situation, you have to do the procedure very well.
Amylase lipase with inflammation in the hepatopancreas. Repeat. Increase amylase lipase, pancreas appears to be normal. Just wait for a shorter time, reevaluate. The pancreas still normal, go ahead with surgery. So it depends upon CT scan. Basically, upon your investigation, what does it show? If it shows inflammation, you have to wait anyhow.
Thank you.
Thank you.
For the next presentation on pancreatic ureterectomy, focusing on intraoperative aspects, I invite Dr. Rajendra Desai as moderator. Dr. Rajendra Desai is professor and senior consultant, GI and HPP surgery, and unit chief at IIM Institute of Medical Science in Hyderabad. I also invite the panelist, Dr. Patta Radhakrishnan sir, director, GI surgery at Malar MGM Hospital, Chennai. Dr. Ajay Sharma, professor and head of the Department of Surgical Gastroenterology at Mahatma Gandhi Medical College, Jaipur. Dr. Mohammad Shahidul Rahman, professor in HPP surgery and liver transplant division, Bangabandhu Sheikh Mujib Medical University, Dhaka, Bangladesh, and Dr. Yoji Kishi, HPV surgeon and professor of Department of Surgery, National Defense Medical College, Saitama, Japan. Joining us online will be Dr. H.H. Nag, Professor, Hepatobiliary Surgery and Laparoscopic GI Surgery at B.B. Pant Hospital, New Delhi, and Dr. Nisar Hussain Hamdani, Senior Consultant, GI Surgery, HPV Oncosurgery and Advanced Laparoscopic Surgery
at Super Specialty Hospital, Government Medical College, Srinagar.
Just one minute, a quick announcement. Any polyclinic who requires access to the internet can be provided by issuing a certificate to them. So if needed, please let us know. Thank you.
Rajan, we'll try to finish by 1:30. I'll cut down a little bit.
Yeah. Pancreatic duodenectomy is the Ferrari of all operations. Everybody wants to do it. Everybody is thrilled by it, but it can make you cry like a baby if you start getting complications. So based on that, let us start the discussion. We're short of time, so I'll go straight to the discussion. Professor Ajay Sharma will be answering first. The first question I have is, day by day the use of neoadjuvant therapy is increasing. Neoadjuvant chemoradiation, neoadjuvant chemotherapy is increasing. Does this increase complications intraoperatively in pancreatic cancer? That's my first question. And my second question is, if you have a positive resection margin in CA pancreas or IPMN, what is your strategy?
In both slides.
Okay, so the enough data, enough data which shows that there is an increased incidence of complications. The complications, but the thing is that these complications are not severe. These complications are only in the form of skin infections, subcutaneous collections, and maybe a leak. If you go details into these articles which are related to bowel, you will identify that neoadjuvant therapy has a complication related to the therapeutic aspect of the medicine. So what all it can cause is, it causes a lot of destruction of the cells. There's less of regeneration. There's lots of vasculitis in this group of patients. So you have to tailor your procedure on your timing. As a rule, we have made it that best time is around 45 days, wait for 40-45 days. But depending upon what chemotherapy you are using, it can get deviated. It can get different time intervals. Sometimes maybe in 17-18 days, a lot of the vasculitis has resolved. Now, if in a PD, if you operate with a patient who has a vasculitis, who has less of regenerative capacity, definitely all complications of PD can increase. There is not literature. All the literature shows that there is no increased incidence of complications. That is just because most of the surgeons who do it following a neoadjuvant therapy take all the necessary precautions. So the most important benchmark or message for everybody is that if you don't understand what that chemotherapy is doing, don't do that following neoadjuvant therapy. If you understand what it is doing, then only you should undergo the surgery. Second thing, the neoadjuvant therapy is given with a particular intent to reduce the tumor size. So what happens very often is, you're given a chemotherapy, the tumor is still compressing onto the portal and you want to do it. No, that's a wrong way. It is still, it goes into an unresectable category. It was actually not a borderline lesion. So you have to understand, if a wrong chemotherapy or a wrong timed chemotherapy has been given, it is not a borderline lesion. That does not indicate surgical intervention. Can I have my second question? You were asking something? Positive resection margin of error. So definitely for a CA pancreas for a CA pancreas, it is relatively easy. You do this has happened to me almost I think three cases which we had a positive frozen margin, we resected it, again had a frozen margin. These patients I had to resort to a complete total pancreatectomy. They had positive resection margin till the end. The worst scenario is IPMN. IPMN, the food is actually having the malignant cells, but your frozen section margin pathologist will report as positive. And we don't know whether that was actually negative or positive. So IPMN is a difficult area. But for a CA pancreas, if it is positive margin, you should resect it. IPMN, I would go if it is having a PET scan showing the hyperactivity at other places, I would go for a resection. But hedopancreas, margin positivity needs a complete resection. Sometimes you may have to resort to total pancreatectomy.
Thank you, sir. So, Dr. Nisar Hamdani, the questions are, what are the preoperative predictors of a difficult pancreatic anastomosis? Before you start your procedure, can you say that I'm going to have difficulty with this pancreas? and prepare for it? And if so, how would you prepare for it?
I think SR has been joined. I don't see him, so maybe.
Doctor?
What are the preoperative predictors in digital pancreatic anastomosis? Now, one of course is a small duct. Then two is any suggestion of a soft pancreas. These are things I can think of preoperative prediction of digital pancreatic.
So, soft pancreas, which can be identified preoperatively, not as difficult. Preoperatively, if you find a fat around the pancreas, that is a subtle marker that you will have a soft pancreas. Undilated duct less than 3 millimeter size is most difficult. 3 to 5 is okay. More than 5 millimeters, you are all happy. There are two markers. If you have any marks, find suggestion that there is an inflammation around the pancreas, which may be subtle marker that he had a pancreatitis or he had an inflammation, that will again a poor marker that it implies that you should wait for a surgery. And definitely a preoperative vascular encasement or close to the vessel is a poor marker of the disease that you are going to have a difficult anastomosis.
What would you do if the pancreas was friable and sutures were cutting through? What about Blumgar's procedure? Would you use that?
I have to tell somebody who has to answer it. Otherwise,
Dr. Yogi Kish.
In cases of fragile undefined timer, sometimes we need to cut additionally the to a unique method of kind of stumps and make other osmosis. Especially, I think rather than find timer osmosis, the gut to gut osmosis to be much more difficult.
You know the ISGPS classification came out with information on this. They have graded pancreas into 4 types. One is you have a soft pancreas and a duct less than 3 millimeters. You have a hard pancreas with a duct less than 3 millimeters. You have a hard pancreas with duct more than 3 millimeters. And the last is soft pancreas duct more than 3 millimeters, and that gives the grading of difficulty. Soft pancreas, small duct is the most dangerous. Hard pancreas, big duct is the best. So these are the things we would look for. Another thing that has been reported is if you do a CT scan and you observe a serrated pancreatic margin, that is because of the fat infiltrating the pancreatic head, you have great difficulty in dissecting it. And Strasberg has also highlighted this point, is that the neck of the pancreas is the watershed of the pancreatic blood supply. If you cut to the left of the portal vein, you have better results and lower leak rates as compared to through the middle of the neck of the pancreas. Nisar is Nisar online?
Nag is there. Nag is online. Yes, joining. Nisar is waiting. Dr. Nag is here.
Dr. Nag?
Yes, sir.
Yeah, that's not found after distal pancreatectomy. How would you manage that case?
That not found actually. First, we have to see how we have divided this thing. Usually, we use energy sources to divide. In such cases, we may not find duct because it may be clipped and obstructed. In that cases, we should freshen the margin with the knife and look for that. Most of the time, we will get. Other thing we can do, we can use the endoscopic ultrasound to look for the duct. Another thing we can do, we milk the distal pancreas, and by oozing of this pancreatic juice, we can get the duct. And if all the this sort are not useful, then we have to opt for this thing, invagination technique or dunking technique for the anastomosis.
What is your experience with stapled pancreatic closure in distal pancreatectomy? Is the risk of, without ligating the duct, if you just slice through with a device, Do you find that the leak rate is higher, or is it the same, or it is less?
Usually I do, if I divide the distal, I further overrun with the proline switcher, and usually I don't have any leak most of the cases.
Thank you, sir. So what are the indications of biliary stenting? This is a controversial topic and this keeps coming back every meeting. We don't know when we have to stent the biliary duct. It's well known that in obstructive jaundice, you have a higher incidence of cardiac suppression. Bile salts act directly on the heart and they can cause hypertension in the intraoperative period. There are many people who would stent a duct when the value is 15. The controversy is ongoing. So, Patta, would you like to answer this question?
Can I go to this
When
next
would
slide?
you stent?
Next slide, yeah. Now, actually, the common indications are symptomatic jaundice, cholangitis, but these days these are uncommon. The commonest indication at this moment is the patients for planned neoadjuvant treatment. Next slide. Can you move the slide? Yeah, actually, as Dr. Ajay was commenting on patients with neoadjuvant, actually the number of patients coming into the category of borderline resectability is increasing progressively, and we are more aggressive with neoadjuvant treatment. So this is the category which are the ones who will benefit by preoperative stenting. Just move on. Now, the most important take-home point is preoperative biliary stenting should be avoided at all costs. Actually, historically, if you see the biliary stenting for malignant obstructive jaundice started in 60s, 70s, and progressively increased by 2000, and everybody is doing. Even now at this juncture, majority of the patients whom we get to see are the ones who already been stented. I mean, that is the message has not gone well to the physicians, but they, that's their learning curve. They try learn sending the CBD for a malignant obstruction, but it should not be done. The reasons are: one is there's a procedure related morbidity, and there'll be migration of bacteria from the duodenum into the biliary tree because the sphincter is violated, and three is the subsequent whatever organisms that grow in the bile are very resistant. In addition, the stent in itself can cause some sort of inflammatory reactions. All these things are the cause for patients having trouble after PD when we have a preoperative biliary stenting. Next slide. Having said that, I just want to make one point here. There is something called a Pombilast technique. I don't know how many of you know this. This is tackling the bile duct last when you do a Whipple's procedure. You start with a cattle brush maneuver, then you go for a Cocker's maneuver, then you transect the stomach, then you transect the jejunum. Keep the bile duct unopened till the end of the Whipple's procedure. Slide. When you do that, you're not, because one of the commonest causes of in postoperative infection, intra-abdominal or wound infection are due to the infected bile there. So, and the very, very precautionary thing, you open the bile duct at that juncture after the pancreatitis is over, and then suck out all that, remove the stent and do an anesthesia. This is what is called the Combelas technique, and this seems to sort of decrease postoperative morbidity when you have patient already been stented.
Yeah,
Can I ask some small thing?
Yeah.
But how does it make a difference if you open the bile duct early or late? Even a drop of bile will have 10 to 10 bacteria. So once it is having already having even a drop of bile will lead to a localized infection as well as the systemic infection. So maybe I feel it the other way around, that let it drain as much as possible. Open it up early. Let it drain as much. Let the bile get sucked. You have 3 times option to wash once you have resected, once you are doing a PJ, then once you are doing AJ, you have 3 times to wash. So possibility of maybe it will not make a difference, but if statistically it has shown a difference, maybe that is important. Yeah, see here, this one group has shown some results with this.
So this is a new technique. I don't think anyone will follow. One of the first things we do is open the bile. We do open the bile duct, do decompress the bile duct actually. Actually, good bile will keep flowing at the end of just before when we go in, and we are happy about it. The liver congestion comes down. That's the first thing we ever do is the bile duct. But this is an interesting twist to this procedure of this particular group has done a few cases and have seen that there's a difference, and I think we should keep our minds open about it. I did this coming actually to understand the basic procedure. These people also do all laparoscopic procedures, the Pavlov's technique when they have put it in. So when you do a lap feeding, thing first, and most of the people, when they divide the neck of the pancreas, they divide the uncinate from the portal vein from upwards, not from above down. As we do from head to foot, but in this we do from foot to head in laparoscopic. So once you do it from foot to head, you keep the bile duct in that, and then remove it at the end. So it was implemented onto the open procedure. This we used to do, we still do it very often. So I think that is the only thing, and it had been given a name. Whether it will have an advantage, you don't know. Yeah.
Very good team. I got a then it's a good idea what you say when I follow that I doing the it's
That's yes. That's good.
Yeah, so back to the bile duct.
Both of them. Yes, are also.
Yeah, the denuded bile duct of dissection. I mean, actually, I haven't come across a situation where I can make out the bile duct is denuded. Next slide. It's quite uncommon. And but then the problem with the denuded bile duct when it anastomoses in a Whipple's procedure, these are the ones who can lead to bile leak in the postoperative period, and also anastomotic stricture, and these two are difficult to manage subsequently. Slide. Now, one should understand the blood supply of the bile duct. You see that it's got the upper ducts, especially left and right ducts, get the blood supply from the right and left hepatic artery. There are small branches there, but the majority supply they get from the gastriduodenal, pancreoduodenal, and then vertical arteries at 3 and 9 o'clock position. Whenever we are operating on the bile duct or transecting the bile duct, we have to make sure that there are 2 arteries there, and we don't, denude the whole thing, the upper bile duct especially, because we're going to transect above the cystic duct level. Likewise, we shouldn't try to loop the right and left hepatic arteries when I'm doing Whipple procedure while doing lymph nodal dissection. That will cut off whatever blood supply that can go to the right and left duct. So you're very, very careful of tissue dissection around the bile duct and the proximal vessels above the cystic duct. Slide. Now, you also realize that about 60% of the blood flow for the bile duct goes from below and only 38% comes from above. And we should be very, very careful of not injuring the 3 o'clock and 9 o'clock vessels. Slide. Now, more important than that is the presence of vascular issues in these patients. Very often we see radiologically a nutcracker type of celiac axis. It can be due to mid-arcuate ligament or atherosclerotic narrowing, and that happens. The circulation to the biliary system will usually go to the superior mesenteric artery, and if there we very carelessly try to ligate the gastriduodenal artery, then there can be ischemia. Actually, one of the major issues for all the problems of Whipple's procedure is due to this vascularity, whether it is a pancreatiojejunal anastomosis or a gastriduodenal anastomosis or hepatico-jejunostomy. So vascularity is very, very important. So we all have to make sure we read the vascular pattern in every patient of Whipple procedure, keep those pictures in the operation theater, make sure that everything is fine and there are no vascular anomalies and there's no narrowing of either the SMA or the celiac axis before going. Slide. So we have to detect the celiac axis stenosis to sort of avoid any complications to have extrahepatic biliary duct injuries. Then this is done by CT angio, and then if we find out there's an abnormality, if there's a median arcuate ligament, but that has to be corrected. If there's a definitive narrowing of the celiac axis, that has to be corrected either by interventional radiology or by a vessel graft and so on. Slide. But having said that, if you really see that the proximal ducts are not bleeding at all, actually, if you see when we release the clamp, whatever bulldog we apply to the bile duct, there will be more blood than bile coming out, and I see that I'll be very happy that okay, the vascularity is good. We see only bile and no blood is a thing of issue. When we have to go more proximally, and then we sometimes have to go into the left duct and make a bigger anastomosis, and very rarely I haven't seen literature either that we have to just put drains in both the ducts and tide over the time and then later on go in. So the proximal or bile duct denuding has to be managed on these lines. Regarding the question on bile staining, this is something which I see often actually. However, well, you do an anastomosis hepatogenosmy, you have some bit of a bile staining, and that is a thing we have to keep in mind. Slide now. The thing is, whenever we do a hepatogenosmy, biliary enteric anastomosis, we would have to stay sutures on either side so that you'll be able to turn it, see the posterior aspect. Quite often, the leak will be from the posterior aspect. First, if you see any staining of the gauze, you try to take extra, just see the anterior line, suture line is all right. If there's any, very commonly, a trio vicryl, in spite of putting 4 knots, they might come off actually. Coming off these knots are not uncommon, that we have to be very sure. If there is an extra defect, you take a suture, making sure that you don't take a cross bite. If the anterior suture line is normal, you just turn it around, see the posterior suture line, and then if there's a issue there, you have to suture it. In spite of it, still is leaking, open the anterior line completely. I do interrupt it, some do continuous, and then suture again the posterior thing, then suture anteriorly. Now, occasionally you have to completely redo the anastomosis. These are the ways you deal with bile staining of the. But then one thing is, when in doubt, redo the entire anastomosis and slide, and should close the abdomen till your gauze becomes white. If you close the abdomen with a drain with the bile leaking, that's the best time you can do anything there. All other times, of course, majority of the times, the small leaks will stop on their own, but we shouldn't take a chance.
Yeah, the next question is to Professor Yogi Kishi. What is the approach to hemorrhage in pancreatic urinary? What are the various causes and how do you tackle them?
Thank you for the. This is also a very fearful situation. And first of all, we must. It is mandatory to encircle the upstream and downstream of the brain or in the vascular structures, especially in cases with vascular resection, would be indicated to control the incidental hemorrhage by using the tapes and circle tapes. It will be very easier to control and perform complete hemostasis. And in cases with hepatic vascular injury, the most fearful situation would be the injury just behind the pancreatic coma, which will be very difficult to visualize the site of the injury. But in such cases, first of all, anyway, this vascular structure for the hemostasis, and then if you cannot visualize the injury, usually the dissection behind would be helpful to visualize the site, and then after the vascular structure, you can safely and calmly close the injury sites using a product.
Thank you. So, Professor Rahman, what is the effect of abnormal vascular anatomy influencing intraoperative complications in pancreatic surgery?
Thank you very much for giving me opportunity to say something here. I'm from Bangladesh, Dhaka, Bangladesh. I'm working in a private hospital, retired from Bangladesh Sheikh Mujib Medical University. The question is that aberrant hepatic artery, how it affects the outcome of PD. It's because most of the fluids supplied by the common hepatic artery, that is dependent on right leg branches, supply the whole liver. And that That during operations, there is in vascular anomalies like aberrant artery that is replaced right hepatic artery or axillary hepatic artery. And if you ligate about during the operations, major disaster may happen, like ischemic hepatitis or liver failure or sepsis or multi-organ failure. So before I do, next slide, please. Discussing about this anomalous arteries, I'd like to say of them. That is, I have checked all based on graphic analysis, thousands of cases, and Mitchell evaluated 200 cases by autopsy. And upon this concept, surgeons are doing operations to avoid vascular injury. Next slide, please. The incidence of most hypertension is about 7 to 40%. Extrahepatic artery incidence is about 8%. And it is mentioned that he is describing this extrahepatic artery as a aberrant right hepatic artery. Incidence is 7% to 21%. Next slide, please. These arteries, how injury happens? There is a major chance of hemorrhages, and there is local recurrence of cancers after these operations. And sometimes aberrant artery does not comprise radical intent of surgery. But the West centers, they are doing their practicing without stopping the aberrant artery, and their success rate is very high. But center should be highly established center. Next slide, please. Like computer engineering, the graph is very much important for the evaluation and detection of the vascular anatomy. There are two theories for PD surgery, or is conventional approach, and there is artery first approach. In the conventional approach, usually like to crocodile can be decayed with followed by lymphadenectomy, lymph is counted by that pancreas, and clearance of connective tissue around the SMA. Artery first approach, this will continue around the SMA, ligation of inferior pancreatic artery, that leads to decrease of less blood supply, leaving restriction around the head pancreas. Next slide. Usual side of aberrant artery origin. Single arterial variant is more common. Replace right usual origins from SMA, GDA, and celiac trunk. Replace left aortic artery, some origins from left gastric artery. Replace GDA origins from celiac trunk and SMA. Extrahepatic artery origins from SMA. Replace gastroepiploic artery origins from celiac trunk, and replace middle colic artery origins from GDA. Next slide. Morbidity and our own sections does not increase outcome in the PD operations. Local evidence PD without the local evidence of arterial encasement may have inflation in the celiac trunk and have contribute to positive decision margin and local recurrence. Locally advanced cases undergo surgery with resection of hepatic artery and suprahepatic artery have poor prognosis. Borderline cases, operational advanced unresectable cases become resectable after intensive chemotherapy or chemoradiotherapy become resectables, but outcome arteries have poor. Next slide.
Okay, done. Hepatic artery thrombosis on the table after finishing dissection. How would you manage?
Just a moment. Certain complications will occur after appendectomy operations. Incidence is 0.02 to 0.06%. Mortality rate is about 50 to 100%. Usually happens within all week operations, causes difficult operation injury to hepatic artery happen. Next case. Next slide, please. Common outcome influenced by injury to hepatic artery. timing of injury, site of injury, presence of collaterals, obstruction of bile duct, presence of sepsis, quality of portal flow. Immediate repair will prevent life-threatening complications. Next slide. Where is the last? I think.
Professor Ajay Sharma. The bowel gets congested after division of the metabolic vein. Should it be ligated? Should it be left alone? Should we dissect with it intact? What are the dangers of leaving it intact? Could you please illuminate the audience?
I think congested bowel needs to be resected. If you have a congestion, it is very rare that it may again get revascularized. You can try that, you can put in a hot mop or something, but for a PD, I would never take that risk. Once you have ligated a vein, whether it is a first jejunal vein or you have divided any venous drainage, if it gets congested, resect the small bowel, whatever is congested, and do anastomosis to the healthy bowel. So that is the basic principle. I don't think that I'll compromise or adjust on that.
Thank you, sir. What about portal veins, supramesenteric venous injury? How would you approach this? It's one of the drastic complications during a pancreatic duodenectomy. When you're doing it, you're tunneling and you have a sudden gush of blood. How would you manage this case?
So now we have to understand when are we getting that injury? Suppose say first you have said that while you are making a tunnel. If you are making a tunnel and that time you have an injury, simplest thing is just put in a gauze and pack it. Don't do any dissection or trial at this time because this is not accessible to you for repair at this point in time. Second thing, if you have once you have divided the head of the neck of the pancreas and you are dividing the uncinate, and that point in time you find some bleeding occurring. So simplest thing, just pack, loop your portal vein from either of the sides or put a clamp and then repair it. 99.9, I've hardly seen a patient having a portal vein injury and not being repairable. Only thing is you have to be mentally ready, you have to be having instrumentally ready and the staff ready to replace or either reconstruct or put in a graft to redo that anastomosis. Sometimes it happens that a major chunk of the portal vein has got injured by you, and then once you do an anastomy, you find that there is a very narrow tunnel of portal vein being formed between the superior mesenteric vein and the hepatic vein. So this narrow tunnel will not work. So now you have to put in a graft. Let this work till that time. Arrange for a graft. See that even if you ligate the splenic vein, it is not going to make any difference. Splenic vein you can re-anastomose, or you can just ligate the splenic vein and do a superior mesenteric vein to hepatic vein anastomosis, or to the portal vein anastomosis. So be ready with the graft. Be ready with the structures, with the instrumentation. You may require to dope it. You may require to clamp it. A good assistant, 2 suctions. That is the basic requirement that is required, and it can be reconstructed.
Professor Nisar Hamdani, how do you manage the thrombosis of the portal vein after reconstruction, either on the table or in the immediate post-operative period? How critical is it, and what would you do?
So sorry, can you repeat the question? I was not able to get it.
If you have portal vein thrombosis after reconstruction, either on the table or in the immediate post-operative period after Whipple's, how would you manage this situation?
Portal vein thrombosis after reconstruction, I would prefer to manage conservatively with thrombolysis, giving low molecular heparin, or get my interventional radiology colleagues on board, and if they are able to contribute and put a intravascular that thrombolysis, I'll prefer rather than reoperating.
Would you do this in the immediate post-operative period? Because I'm discussing a situation with it on the table and in the immediate post-operative period.
Okay, on table, sir. On table, we'll manage the way we do in most of the thrombosis, like shunts. We will then reopen and re-explore.
Okay. So you would do a thrombectomy and then
do the
you see how it is. And in the post-operative period, you would use minimal anticoagulation.
We'll use minimal anticoagulation, yes, sir.
Yeah. And in the post-operative period, it occurs, you would use an interventional approach like you suggested.
Yes,
where interventional radiologist would try to remove the clot.
Right, sir.
And take
in the
either
immediate post-operative period, we'll try to avoid the surgical intervention and resort to interventional radiology approach.
Yeah. Thank you, sir.
Thank you, sir.
At what age would you consider the influence of age in the incidence of post-operative or intraoperative mishaps?
No,
Would you put?
Sir, are you talking about a surgeon's age or the patient's age?
Both. Both. Young surgeon
No,
and old patient.
I think a senior surgeon should answer.
Young surgeon and an old patient.
Yeah.
You're eternally young, so obviously.
That's something which I often keep wondering. Maybe Dr. Agarwal can say as to what age he should stop operating and doing impulse procedure. Then I will go to the patient.
See, I think age is just a number. Consider your physical fitness and mental fitness. As long as your, the matter does not age, I think age does not matter. So your matter should be intact and you should not be having trembling hands. But even now, even the robotics are coming to, even patient, surgeons with a trembling hand can operate with comfort.
Absolutely.
So I think it is all in your mind rather than the physical or the age.
Yeah.
And what about many surgeons whose hand would tremble normally when they are going out? When they're operating, the person never tremble. So it is very common with old age surgeons. Because I often keep hearing that surgeons still do pupils. I mean, that is the criteria to say you're not become old or whatever. That is the test of age and ability. Now, I think the same thing holds good for patients as well. See, actually, it is the severity of the disease which is in responsible model, not the age of the patient.
Frailty index.
Right.
Consider the frailty index of the patient. If they are very frail and this thing, then you should consider that, optimize them if possible, and then probably.
Yeah. The biggest problem that comes with operating on these patients is they don't have a physiological reserve. If they have a complication, they don't recover from it. That is the main problem. And also they tend not to thrive in the post-operative period, despite enzyme supplementation, despite nutrition, they don't tend to thrive in the post-operative period. So with this note,
And I don't remember ever refusing a patient because of the age. I don't know whether any one of you have done so. We can refuse because of comorbidities rather than the age per se.
Yeah, I agree. Yeah.
Not over. Once your volume high and tend to have less complication. You tend to have less complication. Your volume is high and you increase the limit of the patient. But at the point of time, one patient is going to give you that you assess the physiological age wrongly.
No, but this is a very common thing which we face as GI surgeons. Yeah, patients let us say, is he fit for surgery? 60, 70 above, first thing is he fit for surgery? The age they think is the most important thing. But as the literature says that age is no bar as far as pancreatitis is concerned.
So with this, we'll summarize the findings of this session.
One more question. Yeah,
What to do if you discover cirrhosis during workup or during exploration for either a pancreatic duodenectomy or a distal pancreatectomy? How would you manage cirrhosis? Because these are alcoholics, you're doing a procedure for chronic pancreatitis, you find cirrhosis in the pre-op workup, or they are people who come with a pancreatic cancer, they're smokers, they're alcoholics, they come with cirrhosis. What would you do?
Now, actually, if you see, a chronic liver disease is increasing worldwide. Not just Whipple procedure, we tend to see all diseases, all surgical problems with cirrhosis, which we manage. Actually, we rarely refuse doing surgery. But when it comes to Whipple's procedure, the most ideal patient is cirrhosis, child-stage cirrhosis. Child-stage cirrhosis is as good as any other patient. When it comes to anything little more than child-stage, well, when we should be thorough in selection of the cases, that we should make sure that the patients will not go into post-operative liver failure. They should be, these are one other group which should be stented pre-operatively, to reduce the bilirubin before we go in. We have to take care of coagulation, start with vitamin K. We would have very good energy devices, not simple cutting will not do. We need to have good harmonic scalpel and stuff to control bleeding. And we have to also make sure that the electrolyte correction, the coagulation correction should go on immediate post-op because they may go likely to go into liver failure. So in very simple terms, child's A cirrhosis is as good as any other patient. When it is little more than, and most important thing is these should be done in high volume centers, and this should also be done in centers where liver transplantation is available.
Yeah. Thank you, Pata, for handling that difficult question. Dr. Ajay?
Worst case scenario, rather than, I always say, worst scenario which will actually be
is you should be alarmed. If the patient is EH2U and planning to do a PD, I think that alarmed by that particular scenario that is going to give you more troubles.
Professor Kaur.
But I would like to divide the question into two parts. One is pre-operatively, you know patient has cirrhosis. What do you do? Second is you did not suspect cirrhosis, everything was normal as expected. And when you put the telescope or when you go in the abdomen, you find that the liver is cirrhotic.
So if patient preoperatively has cirrhosis with portal hypertension, that's a very serious situation. Without portal hypertension, so I want to make sure if we are doing a preoperative with patient is portal hypertension, presence of varices and also varices in the hilum, I will not consider the patient for the procedure. And as I said, again here this patient we have to have rehabilitation is important in this patient where we have to correct the electrolytes, decrease the bilirubin, which generally when we say we shouldn't stent in this patient, these are the group which should be carefully stented. And they have some portal hypertension, they can be bleeding when you do a cut in the ampulla. And then immediate on table, if you diagnose again, if when we know all the parameters that is child's A, I think we can go ahead. If we find ascites there, if we have prominent varices, I think we shouldn't go ahead. And in the post-operative period, well, these people have to be very closely followed in the intensive care unit. As I said earlier, there should be a liver unit there to tackle liver failure and to preempt liver failure and manage it to save this patient, because mortality in cirrhotics is about 4 times the mortality in normal patients.
Another thing that you wouldn't do if you have a patient with cirrhosis and portal hypertension is lymph node dissection. Lymph node dissection in either carcinoma of the stomach or carcinoma of the pancreas is very dangerous, leads to a lot of oozing, blood loss, and rupture of retroperitoneal varices. So you have to be very careful. You have to individualize. You can't give a blanket recommendation. You have to individualize.
Definitely.
So I lay these questions open to the floor, please.
Yeah, first I'm also agreeing the patient have a cirrhosis, already knowing the cirrhosis pre-operatively or per-operatively. The procedure like Whipple and distal pancreatitis should be avoided, I think, because the cirrhosis may lead to the very lethal kind of complication, decompensation, even with the lapoli, even with the IPOM hernia, where we have seen the patient remain in the ICU CCM for the 10 days and it's very difficult to recover. And PD is totally different procedure technically, and if you're proceed and you got good result, probably we may have a problem in the post.
I think the point that Pata is trying to make is, if it's type A or a good B, you take a chance. If it's a bad B and a C, no.
8 and 7 is difficult. Child A, I think in my experience, I am having around 7 PDs which are in child's A cirrhosis. And I don't remember a patient, two of them were doctor's relatives. So I still remember that doctor asking for a PD in that he knows that it is going to be a difficult case and we have done it and it has gone smooth. So what I mean is child's A, I think you can go ahead. With everything covered, that he may have decompensated the post-op, he may have ascites, he may have difficult course, but yes, this will not have always. Child B9, B8 and beyond is clear cut no, even for a lap chole. If you see Mongo saying lap chole, child's B8 or 9 score has a 90% mortality rate.
So it applies to any surgery. It applies to any surgery virtually.
And I think better evaluation, if we have the good result by seeing the drug, dilation time, good pancreas, you have a feasibility to operate, I think you may be right.
It is often difficult to differentiate the jaundice if there is due to liver disease or obstruction. That's another area where
10, 12, and you have missed at early cirrhosis of child's age, then it's difficult because he made a very important point that in these patients you should decompress the products, even if they have a better score 8 or less. So these patients who tend to do surgery and you get complications.
Couple of comments on arterial anatomy. The preoperative CT, if we look at the arterial anatomy, we should one look at the Thank you. So when we look at the preoperative CT scan in the arterial phase, specifically we should request a radiologist to give some sagittal sections to see if there is any median arterial ligament syndrome and compression of the celiac axis. Because intraoperatively we will see and clamp the GDA, and if the GDA shows, if once after clamping the GDA, if there is no flow in the hepatic artery, then we have to release the median arterial ligament. Then there will be flow established on the common hepatic artery if it is a celiac artery, median arterial ligament syndrome.
Yeah, and it's also important to realize that when you have median artery syndrome, because of flow abnormalities, there is endarteritis and there is narrowing of the celiac per se. So pre-CT 3D angiogram is very important in PD and liver sections to rule out this problem, because in these cases, if you have a absent hepatic artery, you're going to get biliary complications. If you have an absent portal vein, you're going to get early death. So in pancreatic duodenectomy, both these problems are very critical and need to be managed properly.
Absolutely. So we have to
What's the incidence?
It's quite low.
Because somehow I'm having very good luck that I've never seen it. But if
encountered one case. That is fine. That is fine. I have had one case where intraoperatively we have to release the median arterial ligament syndrome and the pulsations reappear. So it's very important as a routine to see all patients. And we have to differentiate between celiac artery stenosis or atherosclerotic stenosis per se versus an extrinsic compression. So sagittal cuts have to be seen. So that is one point on the vascular anatomy. The second thing is just for the benefit of the residents. If you see a replaced right hepatic artery going through the pancreatic head and the pancreatic tumor, it should not come as an intraoperative surprise. You should actually look for it if it is going through the tumor. If it is, then intraoperatively it is possible to resect and reconstruct it without compromising oncological safety. If it's a replaced right hepatic artery going through the tumor, you should begin a preoperatively and have a strategy to deal with it intraoperatively. Thank you.
Dr. Hridayanath, could you just summarize today's proceedings for the audience, please?
I congratulate all the panelists for well coverage of the topic. I'll quickly summarize. Regarding tumor-related factors, Dr. Ajay has clearly stated there should be adequate time interval before considering prosthetic surgery in patients with neoadjuvant chemotherapy, and non-responders should be carefully assessed for the surgery. And in patients who had positive resection margin during the surgery, extended dissection should be tried. And in some cases, it may be only total pancreatic resection may be feasible, may be the option. And in post-operative period, patients should be referred for chemotherapy. And in pancreas-related cases, factors, pancreatic soft pancreas, small duct size, and obesity have been are the common risk factor. And some scores like Fitzgerald risk score or assessment by the CCT and MRI may be helpful to assess the softness of the pancreas, and intraoperative assessment in the form of inspection and palpation finally will confirm the texture of the pancreas. Accordingly, we can tailor our procedure. In patients with fragile pancreas and when sutures are not holding, most of the discussion was regarding maybe we try the Blumgart technique of the pancreaticogynostomy. Some literature also suggests transgastric pancreaticogastrostomy and standard pancreaticogynostomy may also be the option in such patient. And patient with acute pancreatitis, we should postpone the patient surgery for the future. Regarding ISDPS classification for the deciding the risk. There are four factors, four groups, one A, B, C, D. From A is the being the best with the non-soft pancreas and more than 3 millimeter size duct. And D is the worst soft pancreas less than 3 mm duct. And lowest risk is with the A type of the cases and highest risk is with the D type of the case. So in patient with where pancreatic duct is not identifiable, we should revise the margin and reassess the relook for the duct. And if possible, if still not we could find the duct, then we could resort for the intraoperative ultrasound. Sometimes milking through the distal pancreas may be helpful, and if these are not helpful, then we should resort to the imagination techniques. Regarding a bile duct, preoperative stenting should be done in all cases with acute cholangitis or severe pruritus. However, in patients who are going to neoadjuvant chemotherapy or primary chemotherapy should be given endostenting. And intraoperative stenting, there is no literature to suggest. However, their recent study has shown the postoperative fistula rate may be higher in patient with intraoperative T2 placement. And while standing on job, we should reassess, clean the surgical site, then put the saline, look for the site of the leak, and we should re-strengthen that area. Even if the duct is fragile and there is some problem, we are not able to repair, we should place the drain and monitor that post-operatively. Regarding the intraoperative hemorrhage, this is the most worrisome complication. If hemorrhage, all cases with hemorrhage, we should apply pressure, identify the bleeder. If this is minor, then we suture, ligate or cauterize the vessel. In major cases, we should put the pressure, clean the area and call for help if needed, and take another section and attempt repair when everything is ready. In cases with portal vein, supramesenteric vein injury, we may identify the defect and suture the defect. Some cases with major injury may require autologous vein graft or vein patch or vein graft repair. Arterial injury, GDS can be ligated. Repair of right major hepatic artery and SMA should be done. In patients with refractory hypotension, vasoplegic syndrome usually respond to vasopressor drugs and IV fluids. And in some cases where everything is not helping, then we should pack and come out and go again for the surgery. Patients with vascular injuries should be during distal pancreatitis should be repaired carefully. And patients with abnormal arterial anatomy, all the patients should be evaluated carefully, and most of the abnormalities are usually detectable on CT angiography, and we should prepare properly for the surgery. If some surprise occur during the surgery, then we should assess them and then safely deal with that. If needed, we can call for help. In patient with weak hepatic artery pulsation, we should replace the ligature that may be abnormally placed or wrongly placed. We should reassess for them, confirm that with the Doppler. Then again, if there is some problem with the celiac artery like celiac stenosis, release the median arcuate ligament. We may take help of vascular surgeon. In patient with hepatic artery thrombosis, we should confirm that we should first differentiate from the spasm and between the spasm and thrombosis. Put some warm normal saline, reassess and do the Doppler. If it is still, if you are sure this is thrombosis, then we should do transaerial thrombolysis and anticoagulant. And some cases it may be required to take the surgical devascularization treatment. In patient with bowel loop congestion, Dr. Ajay said, if it is congestion is not going with the surgical adjustment, then we should resect that questionable segment, and because it is not advisable to take risk in the patient with like surgery. Portal vein SMA injury should be treated properly. If major, there should be direct pressure. We should define the defect. We can call for the help and anastomose or use the vein graft for this. Thrombosis of the portal vein requires thrombectomy. If it is surgical thrombectomy may be done if it is confirmed on the Doppler. And post-operative period and anticoagulation should be given. Regarding old age, there is no evidence to suggest old age is if everything is fine, their old age is not a contraindication for the surgery. And in patient with cirrhosis, if the child say an early child B, results, we should go ahead with the surgical resection. However, mortality or morbidity are high regarding laparoscopic malignant. Whenever we are venturing for the laparoscopic pancreatic duodenectomy, we should select out patient properly. Patient with periampullary tumor, a small lesion in the head of pancreas, BMI less than 30, no comorbidities, which is contraindicating that prolonged laparoscopic surgery should be there. All of the residents who are trying to venture, we should assist somebody who is doing some senior surgeon and then venture that, and we should keep a low threshold for the conversion in such patient. Regarding, there are some inherent problem with laparoscopic inherent limitation that we should consider while dealing, and we should not persist with the dealing complication with the laparoscopic method. We should convert as the time be. Thank you.
Yeah, thank you, sir. Thank you for that summary. So we call the session to an end. I'd like to thank Dr. P.K. Kapoor and the organizers for calling me to attend these sessions here. I'd like to thank my panelists for their wonderful comments and their intelligence that they have contributed to us. Thank you very much to everyone. Thank you.
If any of the lunch is adjacent to this building, the volunteers will guide you there. I request you all to be back here at around 2:15 so that we can resume the rest of the sessions. Thank you.
हमारी दुनिया ऐसी में
I want to tell everyone.
Hello.
Uh, Good afternoon, everyone. I welcome everyone for the post-lunch session. Our next panel discussion is on pancreatic chorioidenectomy, focusing on the post-operative aspects. I invite Dr. Paleswan J. Lakhe as moderator. Dr. Paleswan is professor and head of the Department of Surgical Gastroenterology at Tribhuvan University, Institute of Medicine, Maharajganj Medical College, Kathmandu, Nepal. And also as a panelist, I invite Dr. Ram Dhaga, professor and head of the Department of Surgical Gastroenterology, SMS Hospital and Medical College, Jaipur. Dr. Sandeep Jain, consultant, GI and HPB surgery, Fortis Hospital, Jaipur. Dr. Yoji Kishi, HPB surgeon and professor of Department of Surgery, National Defense Medical College, Saitama, Japan. And joining us online will be Dr. Ravela Pradeep, senior consultant, Department of Surgical Gastroenterology, Asian Institute of Gastroenterology.
Thank you very much. At the outset, I would like to thank Professor V.K. Kapoor for the invitation and the hospitality. So I hope I'll make sure that nobody sleeps during this post-lunch session. And my job has been made easier by the previous moderator and the previous discussion. So some of the things may be repeated, but I'll make sure that it will be very, the pertinent things will only be discussed. So can we start? So one of our panelists wants to say something through the presentation. So he's downloading. So I think we should wait for him. This one. So in the previous session, pancreatic duodenectomy was so how do I move the slides? It's not moving. Sorry, I bring greetings from Tribhuvan University Teaching Hospital, Kathmandu, Nepal. And in the previous session, pancreatic duodenectomy was considered as a Ferrari, but most of the literature considered it as a Cadillac of abdominal surgery. And the mortality has decreased to less than 5% in high volume center, but morbidity is still high. And we all know that complications are part and parcel of any surgery and they are inevitable. But what is important is identification of these complications and managing them appropriately so that the downstream complications and the mortality does not happen. And it is very important to discuss complications because it defines the quality of surgery, and it is important to see what we are doing. And use of uniform language and comparison of results between various centers was emphasized in the first talk in the morning, and all the procedure-specific complications of pancreatic duodenectomy has been defined by International Study Group of Pancreatic Surgery. So the first 5 complications has been defined, and I will be basically focusing in these 5 complications. So these are my our esteemed panelists, and I took all the pictures from the internet. I hope they are correct. So in 2005, the International Study Group for pancreatic fistula came up with the definition of postoperative pancreatic fistula. Accordingly, any measurable drain on and after day 3, which is more than 3 times the serum value, normal serum value, is considered as postoperative pancreatic fistula. And along with these 9 parameters, they are graded into A, B, and C. And as you can see here, grade A is actually does not have any clinically relevant change in the management, while in grade B and C, there is definite change in management and are considered as clinically relevant postoperative pancreatic fistula. But in 2016, this definition was updated because grade A was not considered as a complication. So it was considered as biochemical leak. And any patient who has persistent drain for more than 3 weeks and there is requirement of percutaneous or endoscopic drainage or angiographic procedure required or any signs of infection without organ failure was considered as grade B fistula. And when reoperation was required or there was organ failure or death, it was considered as grade C fistula. And if you see in these illustrations, most of the biochemical leak and even grade B, they recover without mortality, while grade C, almost 40% of the patients, they die because of the development of multi-organ failure and sepsis and multi-organ failure. So I just want to ask actually all the panelists regarding whether they are following the IHPS definitions or not, and if not, then what they are following, specifically the POPF.
Since 2018, we are following these guidelines and we are keeping all our data according to all these guidelines.
Thank you.
Same for us. We are also following. Okay, so let's see follow the meetings.
Okay, so 2 of our panelists are online. I don't know whether they are with us or not. Dr. Pradeep Rabela and Dr. Vikram Chaudhary. Okay, so we at our institute are also following the same guideline, and the clinical implication of the 2016 definition was validated by the study from the Verona group, where they showed that the patients having no biochemical leak and patients having biochemical leak has similar reoperation, readmission, and major complication, as well as 90 days mortality and length of hospital stay. And they also showed that in terms of ICU admission and in terms of hospital readmission, length of hospital stay, and even the cost of treatment was significantly different in those patients who did not have POPF and those who had grade B and grade C fistula. And they suggested that this updated classification does have reliability in terms of clinical and economic outcomes. However, in certain subset of patients, like in this paper that was published in 2009, where they have quoted that around in 5% of patients, initially the drain amylase is normal, but in day 3 and day 5, but the patient's clinical course is not as expected, and the drain amylase is measured high only after postoperative day 10. And it has been seen that these patients have significantly worse outcome. And similar finding was shown by the Japanese group in 2020, where around 10% of the patients did not have drain amylase elevated on day 3 and day 5, but was elevated in the later in 7th day or 10th day. And these patients are termed as latent pancreatic fistula, and they also showed that these patients had significantly worse outcome, higher incidence of PPH, intra-abdominal access, and the higher number of patients required re-intervention. So if you go through the literature, in 2007, there was a definition published by Steven Strasberg group, which is also known as PathBox system. And POF is pancreatic occlusion failure. That's for distal pancreatectomy. And pancreatic anastomotic failure. If you see here, in their definition, what they say is that when the drain amylase is more than 50 ml and the serum and the value amylase value is more than 3, the normal serum value on or after day 10 only, either in the intraoperatively placed drain or postoperatively placed drain. And they have graded they call it pancreatic anastomotic failure and not postoperative pancreatic fistula, according to the Clavin-Lindo grading system in 5 grades. So actually my first question is to Dr. Vikram Chaudhary, that what is the relevance of PAC system that is described in 2007, and what is your experience regarding latent fistula? So can you check whether he's online or not? Or anyone? Okay.
Sir isn't joined in.
So in our practice, is he coming? So do you have any experience regarding this?
We have occasional patients who have been discharged from our department, and they came back with some discharge from new home, which is causing some respiration. And these are patients who come with this PA or fluid fever. So they are occasional patients, but if we are still having very small numbers, we cannot make out whether they do worse or better or same as normal temperature.
So are we
It's online, but the camera is off.
So we can speak.
Yeah, it can speak on, but I think it's now in front of the computer.
Oh.
Yeah.
Yes,
So, easier.
Vikram Chaudhary is there.
Good afternoon. Sorry, I got free slightly late from my theater. There was some delay and I had to change and I have joined finally. I'm very sorry to join late.
So the first question is for you. What is the relevance of PAC-POF system that was described in 2007, and what is your experience regarding latent fistulas?
So I would say the previous system is now very much updated. So the post-operative pancreatic fistula is now the hyperamylasemia is no more classified POPF-A, and mostly the clinically relevant pancreatic fistula is POPF-B and C. Is that what you mean to ask me, Dr. Am I missing something?
So what I wanted to ask you is that in certain subset of patients, the drain amylase is normal initially, but the clinical course is not as expected.
Yes.
And later on,
I think that is what was realized by ISGPS, and that's why they revisited their classification. Initially, all patients who on day 3 hyperamylasemia were universally classified as pancreatic fistulas as POPF-A. It was unnecessarily documenting the hyperamylasemia as a fistula, which was actually not clinically relevant. So now I think we only document what is clinically relevant, and even I think any infected pancreatic fluid which is coming out is now becoming getting classified as a pancreatic fistula. So now the current classification is more relevant, and I think nobody now follows the old classification of a POPF-A. The classification is only CRPOPF, B, and C now.
Okay, thank you. So I think we need to keep in mind that certain patients will have normal drain amylase initially, and later on only it may manifest. And we need to keep in mind these patients while managing post-op.
Can I make a statement? Yes, I did not address the second question. What about the latent fistulas? You probably meant that the day 3 amylase is normal and these patients still develop clinically relevant pancreatic fistulas later. So that is the limitation of a day 3 amylase. So infected peripancreatic leak, which is either drained later in the drain or by your percutaneous intervention, that is more relevant. And a lot of patients do develop clinically latent or biochemically latent fistulas, which I would say. Yes.
Thank you.
And the clinical presentation is what is important.
Okay, thank you. So there are various risk factors for postoperative pancreatic fistula, which was a little bit touched upon in the previous session, and they can be categorized into preoperative, perioperative, and postoperative, and also as those factors which can be modified and those which cannot be modified. And there are various scoring systems which has taken into these factors, risk factors into consideration. And one is this original fistula risk score, where gland texture, pathology, pancreatic duct diameter, and intraoperative blood loss is taken into consideration. And it has got four risk categories. And in 2019, the Dutch Pancreatic Cancer Group came up with the alternative fistula risk score, which incorporates pancreatic texture, duct size, and the body mass index. And this can be calculated online. And this also tells us the mitigation strategy, not only the risk of development of fistula, but mitigation strategy as well. However, a same group updated the alternative fistula risk score by adding sex, and this was validated in the minimally invasive group, and later on in open pancreatic as well. But the most highly cited is the original fistula risk score. And this was discussed previously. And as you can see here, that as the grade increases, the risk of clinically relevant postoperative pancreatic fistula also increases. And this is the ISGPS consensus classification. So I would like to ask Dr. Pradeep Ravela if he is available online, that which scoring systems are you using in your clinical practice? And if yes, which one and why? So I think there are amongst the various scoring system, I think the ISGPS risk classification, which has been proposed in 2023, is more practical, on table, which takes into consideration the texture and the duct diameter. So does the panelist have any thing to make anything to comment on that?
Actually, our group does not do not adopt any of these predictive preoperative predictive scores because not the preoperative prediction, but the outcome itself would be important. So after POPF was confirmed, we need to take mitigation management.
So these scoring systems has been compared, and then this study where Dr. Bikram Chaudhary is one of the author showed this study showed that updated alternative fistula risk score was better than other scores. However, this another study from Japan showed that all the three scoring systems are equally has equal ability to predict the clinically relevant postoperative pancreatic fistula. And the ISGPS risk stratification was validated by the Dutch Pancreatic Cancer Group in around 4,000 patients. And as you can see here, that the number of patients in Group B, which is non-soft pancreas, and the duct diameter less than 3 is less in number. And the clinically relevant postoperative pancreatic fistula in Group B and Group C are almost same, and the hospital mortality are almost same. So they suggested that probably less is more, that instead of having 4 categories, 3 categories are better based on the number of risk factors. If there are no risk factors, then it's category A. If there is only one risk factor, either soft pancreas or main pancreatic duct less than or equal to 3 millimeters, it's category B. And if both the risk factors are present, then it's risk category C. And they showed that the predictive ability of both the four-tier classification and three-tier classification are equally fine. So maybe the more less is more, maybe three-tier classification is better. So we will very briefly discuss about the various mitigation strategies. So I would like to ask Dr. Ram Daga regarding his mitigation strategy in terms of pancreatic anastomosis.
There have been a lot of studies comparing various ultrasonic techniques. There have been RCTs, meta-analysis, but none of techniques have been proven to be superior to other techniques in most of the hands. So there are centers which come up with some techniques like bending technique. They have shown excellent results, but these results cannot be replicated in other centers. Similarly, other techniques like lump guard is not universally accepted still. So I think there is no specific technique which you can say that is better than other technique. Again, I think it's your technique which you have adapted, which you have learned from your mentor. You have to follow that technique in a precise way. You have to master that art, and then you have to follow that technique. This is what I believe. In our center, what we do, we used to do only user techniques for all of the patients. Still, we are doing the same technique. We are not at Gangat. Well, we have not found any better results with that Gangat technique. What we do, we have to take some specific precautions while performing your anastomosis and your dissection. While dissecting pancreatic neck, what we do, we divide the interior part of pancreas from with the help of either diaphragm, populating diaphragm, or with the harmonic scalpel. But when we are close to site of ED, proximal site of ED, we shift to cutting cautery or cutting diaphragm. So we try to avoid any thermal damage at that close to pancreatic section site. This is one thing which we again when we are doing this anastomosis, we have to be very careful regarding our anastomosis, that to be good anastomosis. We have to take precise suture with no crisscross of any suture. We have to be very thorough. We can use either this surgical loops or we can use headlights to get a better vision in this field. So this is one thing which I would like to quote.
Thank you. So it's the attention to detail and doing the same thing again and again. As you said, there is no difference in the incidence of CRPOPF between pancreatogastrostomy and pancreatojejunostomy as shown by this RICOPANC trial. And also this systematic review has shown that there is no difference in clinically relevant postoperative pancreatic fistula. Either you go for ductal mucosa or other types of pancreaticojejunostomy. And the PANASTRA trial, that is the latest trial, showed that there was no difference in clinically relevant in postoperative pancreatic fistula, whether modified Blumgard was done or Cattle-Warner was done. However, this paper from Japan that was published in 2018, which compared invagination with ductal mucosa, showed that in a subgroup of patients who had soft pancreas, the clinically relevant postoperative pancreatic fistula was significantly less when invagination was done. So in surgery, I think we cannot be dogmatic. We need to sometimes individualize the technique as well. So to Dr. Sudeep Jain, like what is have you been using stents while doing pancreaticojejunostomy as a mitigation strategy?
So, the stent is
Okay. So, as you said, it was initially shown that there wasn't much difference whether you use internal stent or external stent. And even the systematic review showed that there wasn't difference in incidence of clinically relevant postoperative pancreatic fistula, whether external stent or internal stent. However, in grade C fistula, the external stent was associated with significantly less incidence of clinically relevant postoperative pancreatic fistula. And in this randomized controlled trial from Verona group in high-risk pancreas, which was identified according to fistularis score 7 or more, and the patients were randomized into pancreatogastrostomy and pancreatojejunostomy with externalized stent. Although the procedure-specific complications were similar, but the average complication burden was less in those patients who had pancreaticojejunostomy with external stent, and the major complication was also less in patients who had pancreaticojejunostomy with external stent. So in high-risk anastomosis, external stent is said to reduce clinically relevant postoperative pancreatic fistula. So the third mitigation strategy is the use. There is so much of controversy regarding the use of drain in pancreaticoduodenectomy. So Dr. Bikram Chaudhary, would you like to give us your opinion regarding use of drains in as a mitigation strategy for postoperative pancreatic fistula?
Yes. So in pancreaticoduodenectomy, at least in our center, irrespective of the fistula risk score or the risk of fistula, we prefer to put drains. And our preference is a Jackson-Pratt drain because it acts on a microcapillary action and doesn't get blocked easily. And we try to place two drains in two different quadrants. One is near the pancreaticojejunostomy anteriorly, which goes towards the caudate, and another is in the Morrison's pouch, which also is pointed towards the caudate behind the HJ. So we try to drain both the areas. These are the two regions which we feel need to be drained. It's not only about the leak which may develop, but it's also sometimes the chyle and the post-operative fluid which needs to be drained for a few days. That's what we believe. But I'm aware of the studies where centers do not put drains at all, and they feel that the clinically relevant fistula, if it is going to become a POPFB, ultimately these are the patients who are going to require a percutaneous intervention, and they will anyways need it irrespective whether you put the drains or not. But we have not dared to follow this strategy. There are very occasional patients where an absolute low risk pancreas, in a very straightforward patient, we might not have put a drain. But I think more than 95% of patients who undergo Whipple at our center, drain placement is a standard of care for us.
So we are also using drains routinely, two drains as you just mentioned, and there are various studies. So this particular study was done to show that drain is not necessary. But in this study there was increased incidence of complications when drain was not used, and the Data Safety Monitoring Board terminated the study because the mortality increased from 3% to 12%. And what they showed was that if in patients having negligible or low fistularis score, if drain is placed, then CRPOPF is high. And in those patients who have moderate to high fistularis score, if drain is not placed, then CRPOPF rate is high. And this trial showed that omitting drain was not inferior to putting a drain. And this study from multi-center study from US came up with the selective drain management. Drain was placed only when the fistularis score was moderate or high, and depending upon the day one drain fluid amylase, the drain was either continued or removed. And when this selective drain management was applied, they found that the clinically relevant postoperative pancreatic fistula rate decreased from 20% to 11%. So now there is this risk-based drain management drain is placed based on fistularis score and is removed based on the day one drain fluid amylase and also how the drain looks like. So it's not just the drain fluid amylase. We need to be careful about how what is the nature of the drain as well. So
can I make a small comment, madam, here?
Yes.
Yes, I think now the data is in favor of drains, against drains. Both sides we have data, so it's confusing. But one thing is for sure, keeping the drains for a long period of time doesn't help. So even if you're putting drains, our aim should be to get rid of the drains as early as possible. The moment you see that the patient is not developing a clinically relevant fistula or the drains are serious, and the moment you see that the patient has no reason to have a drain inside, like there is no chyle leak or there is no suspected bile leak or no postoperative complication, I think the drains need to come out as early as possible. If we follow that, I think drain associated issues can be minimized. That's what I would say. Yes, thank you.
So another controversial topic regarding mitigation strategy for POPF is use of somatostatin analogs. So I would like to have the opinion of the Professor Yuji Kishi.
Thank you. Regarding this question, actually, we never use something routinely because there is no clear evidence that this is effective to prevent the fistula. So we usually do not use somatostatin analog nor protein kinase inhibitors.
So even I used to use octreotide routinely, but after this, I went through this study, which was done in US, and so in this study, they wanted to see the optimum mitigation strategy for high-risk anastomosis. High-risk anastomosis was those patients who had fistula risk score 7 or more. And in this study, they showed that those patients who received octreotide had increased incidence of clinically relevant postoperative pancreatic fistula, 42% versus 19.9% in those patients who octreotide was not used. And the optimum mitigation strategy, as you can see here, is that the F is that the creation of pancreaticojejunostomy, not using octreotide, and external stent in high-risk fistula pancreas was associated with least incidence of clinically relevant postoperative pancreatic fistula. So after this study, I haven't used octreotide. So just wanted to know what is there are various other mitigation strategies as well, but I just want to know what is the mitigation strategy from like just be brief from each.
Actually, I think Dr. Vibha is there and Professor Sitaram is in the panel. So you can address all the questions meant for Dr. Pradeep to Professor Sitaram.
So, Professor Sitaram, what is your optimum mitigation strategy for POPF? What you can say?
I don't know whether you can hear me.
Yes, sir, we can hear you.
We can hear you, sir.
We don't use, when I was doing pancreatic duodenectomies, I didn't use octreotide. I always placed a drain, single drain, right upper quadrant behind the pancreatico-jejunal anastomosis. I didn't divide the pancreas with diathermy or with an energy source. I divided it with a knife and got control of bleeding with 5-0 polypropylene sutures. I know there's no evidence base to this, but I felt that cutting the pancreas cleanly with a knife and getting good hemostasis with sutures probably gets good vascularity, the cut edge. What else did you discuss? Drain.
Anastomosis.
Anastomosis always a ductomucosa pancreatico-jejunal anastomosis.
Thank you, sir.
My view, duct diameter, pancreas texture, and surgeon experience. These were the three main features which mattered. Thank you.
So I totally agree with you, and I think in the interest of time, we will not take the opinion of other panelists. We can discuss that later in the tea time. So this study which was done on behalf of Pancreatic Fistula Study Group showed that in high-risk patients, the optimal mitigation strategy was the making a pancreaticojejunostomy, omitting the prophylactic octreotide, and minimizing the blood loss. So my question to Dr. Yuji Kishi is, when do you suspect development of postoperative pancreatic fistula, and what is your line of management besides the draineritis?
Okay, so let me show you some slide I have made. A couple of slides. So that on the screen.
So Professor Yogi has made some slides, so he wants to show slides.
I have a copy. Slide. It's other pretty so far. The management of POP, not PCS, should be considered in both in terms of intraoperatively and postoperatively. And intraoperatively, the techniques of osmosis to be a major concern, and postoperatively, the drainage method. And as other mentioned, drugs also are not routinely used will be a concern. Excellent. And we think the drainage itself will be the most important issue. And then the timing of drain removal will be a problem. I got introduced by paper from the Japanese institution. We emphasize that not only the urine amylase level, but also serum CRP values, especially on postoperative day 3, because high CRP level, prolonged CRP level, postoperatively will be associated with a high risk of clinical relevant PFS. So we use this criteria for the removal of drain. And if this criteria was not satisfied, we need to replace the drain tubes. And usually, as you also experienced, if we put placement, if we place the drain tubes for a long time, initially, fistulography does not reveal any fistulization between the public duct and small duct but after that, this last slide, yes. You can see the appearance of power after this. So I think this will be a sign that we can remove the drain tubes. So that's only this way we manage the drain placement to treat PLPF. Thanks.
So thank you. Right. Okay. So actually there will be change in the course of the patient. Post-operative course will not be as expected. The symptoms will be non-specific, and besides the sinister-looking drain or elevated drain fluid amylase, there will be features of systematic inflammatory response syndrome with concomitant infection. And as Professor Yuji said, that the CRP will be elevated, the WBC count will be elevated, and it is very important to have the imaging to see whether there are any undrained collections or not. And it has been shown that the three important things in managing these patients is the drainage of the collection by image-guided drainage, either ultrasound or CT, or endoscopic ultrasound-guided drainage if it is in the lesser sac, and use of appropriate antimicrobial antibiotics, as well as the nutrition. And enteral nutrition is said to be superior to parenteral nutrition. And there are various suggestions that somatostatin analog also helps in the management of postoperative pancreatic fistula. So majority of the time, it's conservative management, almost 90% of the time, but sometimes these patients will require surgery. So I would like to ask Dr. Bikram Chaudhary, like, when would you consider surgery for postoperative pancreatic fistula, and like what would you be doing during surgery?
So I think this is always a difficult decision to take in the postoperative period. when you are dealing with the patient who has a likely to have a leak or a potential leak. The first thing which we need to do is avoid the denial. I think the biggest problem which happens after you do pancreatic duodenectomy is a lot of people tend to be in a denial about the fistula being present. Every problem which happens after pancreatic duodenectomy, unless proven otherwise, happens because of a pancreatic anastomotic leak, is what I would like to say. More often than not, as we know that the POP of B is a more common occurrence and a POP of C is a less common occurrence. Out of around 25% patients who are likely to develop fistula, around 17% of these 17 of these patients would be treated with a percutaneous drainage. Those 8% or 5% patients who are likely to develop POP of C, an early and a smart intervention is what you should look at. Do not delay the intervention when you see that the patient is not getting better after your percutaneous intervention, or if the patient is very sick to begin with. So if these two things are there, I think not being in the denial and an early swift exploration is what is likely to improve your salvage of that POPFC rather than a delayed intervention is what I would like to say. And your I think the center should be recognized by its rate, not of a rate of POPFC, because that generally should be at a high volume center around 5 to 8%. But your failure to rescue rate is highly important. And if you are rescuing more than 50% of your POPFC, I think you are managing your POPFCs better. So avoidance of denial, early intervention, and good rescue of POPFC patients is what I would suggest. I think technical things we'll discuss later if they come.
Okay. So yes, absolutely, as you said, and so these are the various management that can be done to the pancreatic stump at re-laparotomy, doing minimum just debriding and draining the peripancreatic region to completion pancreatectomy has been described. And the technique, a bridge stent technique, which has been described, is putting an internalized stent or externalized stent as shown in this picture, and draining the area of anastomotic dehiscence has been described. And versungostomy, making a controlled pancreaticoenteric fistula, cutaneous fistula, has also been described. So this was a survey that was done in 2013. It's a quite old one by EAHPBA, and they showed that there was major disagreements worldwide regarding the management of POPF, and they suggested need for standardization. However, the Dutch Pancreatic Cancer Group came up with this study of management of severe, means grade C, pancreatic fistula after pancreatic duodenectomy, and they showed that the primary catheter drainage was associated with success of 77%. And in propensity score, propensity matched cohorts, they showed that the patients who had a primary catheter drainage had better outcome as compared to those patients who underwent primary re-laparotomy, emphasizing that conservative management with adequate drainage is the important thing in managing these patients. So there is much talk about going for completion pancreatectomy, and the same group came up with this study of multicenter cohort study and meta-analysis. And in this study, they showed that those patients who underwent completion pancreatectomy had a worse outcome as compared to those patients who underwent pancreas preserving procedure like putting a drain, doing a versungostomy, or going for bridge stent technique. So the first thing in management of these patients with postoperative pancreatic fistula is adequate drainage, appropriate antibiotic, and the nutrition. Surgery is the last resort. And when you go for surgery, it's the pancreas preserving procedures, not completion pancreatectomy. So this is one of our patients who underwent, who had ampullary carcinoma, and this is before 2021. And at that time, I used to do truncating pancreaticojejunostomy. So as I said before, like this patient had normal drain amylase in day 3 and day 5. So we removed the drain early. But after that, she started to have her course deteriorated. And then on day 7, we did ultrasound, transabdominal ultrasonography, and a drain was placed, and the drain amylase was high. And then on day 10, she had a mild extraluminal PPH. CT angio was negative. And since her hemodynamic stability she was unstable, and then we took her for surgery, and where we did versongostomy and feeding jejunostomy. After that, although she had a prolonged post-operative course, she improved, and her pancreatic stent was draining around 200 ml daily, but suddenly it stopped. And then we did a pancreatogram through that stent, and what we found was that the pancreatic the dye was going not only into the pancreatic duct but also into the intestine. So it was like fistula was formed by nature. So I'm sorry, I did not find that picture of that pancreatogram, so I could not put here. And after that, we removed the stent and she was discharged. So there is a lot to discuss in postoperative pancreatic fistula. But as a take-home message, I would like to just share what high-volume pancreatic surgeons has to say. Professor Marcus Buchler has mentioned that we need to keep cool and not to overreact. 90% of the fistula will heal. Main problem with fistula is late bleeding, and which is the cause of mortality. Therefore, we need to be prepared for dealing with this bleeding, and interventional radiology should be available 24 hours a day and 365 days per year. And Professor Matthew Katz from MD Anderson also mentions that I almost never operate for fistula in my experience, and all fistulas can be managed non-operatively. And the surgeon from Argentina has he mentions that when reoperation is necessary for fistula, just drain the fistula by placing multiple drains and make sure that you put a feeding jejunostomy and then wait and see. So the next complication is post-pancreatectomy hemorrhage, and this was also defined by International Study Group of Pancreatic Surgery, and it was in 2007, and it is defined on the basis of 3 parameters: onset, location, and severity, and this has been widely cited paper. And so if the bleeding occurs within 24 hours, it's early. If it occurs after 24 hours, it's late, and it can be intraluminal or extraluminal, and it is mild or severe. So what is important to understand is the early is always grade A and grade B. Whether it's even the early is severe, it's grade A only, and the late is always grade B and grade C. Even the mild late is grade B, and severe is grade C. So, and various depending upon the various therapeutic consequences and clinical condition, also it is graded. And the severity is based on the fall in hemoglobin less than 3 grams, and also number of transfusions required. If more than 3 transfusions are required, it is severe. And based on the need for invasive intervention, also it is considered mild or severe. And this was the reappraisal of post-pancreatectomy hemorrhage definition. And what they showed was that the patients who had no PPH and grade A PPH had same outcome, and those patients who had grade B PPH, which will include early severe and late mild, have same outcome. But what they showed was that the outcome of patients with severe PPH alone, mild PPH with POPF, and severe PPH with POPF had significantly different outcome in terms of hospital stay and mortality. And they suggested that probably instead of time of onset, concomitant POPF should be included in the classification system or grading system. However, the definition has not been revised since 2007. So this is one of the case scenario. This is also a case which was performed before 2021, and he is a 30-year-old male with ampullary carcinoma and underwent Dunkin pancreaticojejunostomy. So he had early severe intraluminal PPH, and we did CT angio. There was blush in the pancreatic stump. Angioembolization was attempted, but bleeding was not seen. And since there was ongoing bleeding, we took him for surgery, and enterotomy was done proximal to the pancreaticojejunostomy, and we could see the bleeder at the transected margin of the pancreatic stump, which was ligated. feeding jejunostomy was done, and this patient developed postoperative pancreatic fistula, but was managed with adequate drainage, antibiotics, and enteral nutrition. So he had, after that, he had uneventful recovery and was discharged on 35th postoperative day. So I would like to ask Dr. Sudeep Jain, would you have managed this patient differently? The case of early intraluminal severe PPH, and when would you opt for upper GI endoscopy?
So this particular case, which you everything but cases. So side, side answer of the issues stable, but that so
How early would you do in a post-operative patient where
majority of the cases it is not required in
So this is the second case scenario of delayed PPH. So this is a 30-year-old lady who underwent pancreatic duodenectomy and truncated pancreatic jejunostomy. On postoperative day 3, her drain amylase was normal. And on day 5, she passed a little bit of melena, which was ignored. And on day 7, she had massive lower GI bleed and hemodynamic instability. And CT angio was done, which showed hemophilia with intraluminal blood. And angio in DSA showed there was bleeding from arc of Buehler. That's what our intervention radiologist said. And arc of Buehler is a communicating artery between the celiac axis and the superior mesenteric artery. And successful embolization with the gel foam particles was done. And she did not bleed after that, but she had pain, abdomen, and fever. So the first picture is the pre-embolization CT, where you can see clot inside the jejunum as well as the biliary tree. And the second one is the CT after embolization, when she had fever and pain abdomen. And there are two collections you can see. So one is this one, and the another collection is down there. And both these collections were drained percutaneously. And however, the drain amylase was not high, and she was discharged on 24th postoperative day. So this is another case of delayed PPH. This is a young female, 21 years old, who had an uncinate mass, and this was solid pseudopapillary tumor of uncinate process, and she underwent pancreatic duodenectomy. She had eventful recovery till post-op day 5, and but on post-op day 5, she had melena, and she had hemodynamic instability, which improved with resuscitation. And CT angio revealed clots in jejunum, and DSA was done. So this is her angiography, and the bleeding was actually from the dorsal pancreatic artery, which was arising from the superior mesenteric artery. And our intervention radiologist embolized it, and after that, she had uneventful recovery. So since Dr. Pradeep is not there, I would like to ask Dr. Sitaram, would you have managed these two patients of delayed intraluminal bleed differently? And both of these patients did not have concomitant POPF.
The only thing I would add is we probably would have done an upper GI endoscopy. But otherwise, management of bleeds would follow what you have done. CT angio followed by angioembolization.
So in both these two cases, Duncan pancreatic jejunostomy was done. So we were pretty sure that it was bleeding probably from the pancreatic stump. And we were a little bit reluctant to go for upper GI endoscopy so early on day 5. So that was the only reason we did not go for upper GI endoscopies in these two patients.
A significant proportion of patients bleed from the gastrojejunostomy as well. which have been managed endoscopically.
So here, I think both the cases, it was bleeding from the um, uh, uh, one, it was from the pancreatic stump, and the other one was also, I think, from the pancreatic stump. It was the arc of Buehler. So the third case, the third patient is he is a 65-year-old male who had ampullary carcinoma. So 40 minutes left. 40.
Chalo, take 10 minutes maybe.
Okay, so I will just discuss the PPH and then finish. So this gentleman had ampullary carcinoma and underwent pancreatic duodenectomy. So on D1, there was blood in the drain.
Sorry.
Blood in the drain, and the patient
I
was
think you have more time.
patient was tachycardic, although the mean arterial pressure was maintained. And Dr. Vikram Chaudhary, what would be your approach in this patient? Actually, he had only extraluminal severe PPH. And what are the preventive strategies for
I'm
PPH?
very sorry, Dr. Lakhe. I couldn't hear you because there was some communication going on. So POD, one of PD, tachycardia, and fresh blood in the drain. Okay,
In
blood in the
day
drain.
one. In day
Okay,
one.
okay.
And this patient had modified Bloomberg pancreatic duodenostomy.
I think this patient probably needs to be taken back to theater. If the patient is still stable, I sometimes would like to do a CT just to get an idea what is happening. But if the patient is unstable, on day one, extraluminal bleed is usually a vascular mishap, a clip slippage, or a GDA, or a branch of SMA, or generally a technical problem which can be sorted immediately, and it is clearly an extraluminal. So I think I would take this patient for surgery. Sometimes if the patient is relatively stable, I might do a scan or occasionally an angio, but this is probably a surgical intervention is what I feel. First impression.
We did take him for a CT, and there was clots in the peripancreatic area, and we took him for surgery, and there was bleeding from the pancreatic duodenostomy site. And we did control the bleeding initially in the first surgery, but again he bled, probably because of coagulopathy, and he developed ARDS, and we could not salvage that patient. So what I thought was that we took him for surgery a bit late. We should have gone a bit earlier. So and what would be the preventive strategies for PPH?
Small point about the upper J endoscopy, which Professor Sitaraman mentioned, is that probably the endoscopy is something which is done is when you do not get anything on other investigations, probably because it's will be very uncommon that the endoscopy will be a therapeutic endoscopy will be required after a Whipple. It happens, and a GJ, if you have done a staple GJ, sometimes that bleeds. But sometimes the CT first guides you what is the source. If it doesn't guide you, then probably invasive angio and the location of the clots and the extent of the presence of the clots, probably that guides us. And then we probably resort to endoscopy. So that was the only thing which I wanted to add. If Professor Sitaraman can add something else, I would be happy to hear what he says. But I think it's usually a CT depending upon the stability of the patient. Even if sometimes we more often than not, even if we plan an invasive angio, we still try to get a CT because CT is more sensitive and specific, and it gives a roadmap to the intervention radiologist also for their interventions. So sometimes more often than not, even if we plan an invasive angio or a DSA, we would like to do a CT angio in those patients before we proceed.
So do you have any suggestions for preventing PPH?
Okay.
Yes,
So yeah, you're probably trying to point towards the falciform the patches and the omental flaps, and but I think the best is the most common scenario when the PPH happens is POPF. So try to keep your POPF rate as low as possible. Be proactive in managing your leaks. I do wrap the falciform around the GDS stump in most cases. If I can't wrap that, if I have not dissected the hepatic artery for a long distance, sometimes I will just put it anterior to the GDA, just separate it from the pancreatic anastomosis. I don't prefer omentum A lot of people I know prepare the omental flaps and put them anterior and posterior. But I think in the context of leak, if the leak happens, then that omentum itself sometimes gets necrosed and infarcted and infected, and that probably acts as a double-edged sword. So I'm not a great fan of omental flaps, but some people do that. Apart from that, a meticulous dissection and a meticulous surgery and a good hemostasis at the end of resection is what you can do.
Okay, thank you. As you mentioned, there are studies of falciparum ligament flap and even arterial reinforcement with the polyglycolic acid sheets have been described in the literature, which has shown to decrease the development of pseudoaneurysms and bleeding. So, however, we are not practicing these strategies. So this is an interesting algorithm where it mentions that whenever there is post-pancreatectomy hemorrhage, so if it is early, whether it is intraluminal or extraluminal, operative hemostasis is recommended. When it is extraluminal late, then interventional radiology. And if it is intraluminal and associated with even with POPF, then interventional radiology. If it is not associated with POPF, then interventional endoscopy is recommended. And when these strategies fails, then operative hemostasis. So this is our experience of managing around 336 pancreatic duodenectomies, out of which the incidence of PPH was around 25%. And we categorize these patients into two groups according to the time zone. Before 2014, the angioembolization was not routine in our institute. So after 2015, you can see that PPH incidence is similar, 13.2 and 12.5. But what is significant is that after angioembolization, mortality has decreased from 58% to 23%. And this is the one of the systematic review which gives us the management according to ISGPS. So accordingly, grade A, conservative management, grade B, initially conservative management, then step-up approach to surgery early. And grade B is endoscopic or endovascular, and grade C, which will always be late, either endovascular or endoscopic, depending upon whether it is intraluminal or extraluminal, and surgery only when as a last resort. So as a take-home message, like we need to have a multidisciplinary approach in the management of PPH. There is no specific guidelines, but one need to go for individualized step-up approach. So I think that I have time. So the third complication is delayed gastric emptying, which was defined by ISGPS in 2007. And the definition is based on the need for NG2 for more than 3 days, the need for reinsertion of nasogastric tube due to persistent vomiting after postoperative day 3, or inability to tolerate solid diet after postoperative day 7. And it has been graded into grade A, B, and C based on these 8 various parameters. In grade A, actually can be treated with just prokinetic agents. And grade B, sometimes reinsertion of NG tube, and sometimes other investigation needs to be done, like GI endoscopy or contrast study or even CT. And grade C, like intervention, like putting a nasojejunal tube, draining the draining collections, doing surgery for delayed gastric emptying has also is considered as grade C. So, Dr. Mohan, how often do you encounter delayed gastric emptying in your clinical practice after pancreatic duodenectomy, and do you have any specific preventive strategies?
Our data, it's around 11%. 11% of the patient had this delayed gastric emptying, and less than 1% patient had this type C disease among those. So this is our data so far. Regarding prevention, in our setting, foremost cause of disease again POPF. So we try to prevent POPF as far as possible. And after POPF, other is our GJ technique. What we do GJ in intracolic compartment. We do a classical Whipples and do GJ in intracolic compartment. It's an anti-peristaltic GJ. So what happens when we keep it in intracolic compartment? in a retrocolic fashion, not anticolic as against other data. We keep it in retrocolic fashion. So stomach lies straight forward. So somehow gravity helps in pulling of food into the jejunum. Further, we separate infracolic and supracolic compartment. So if any leak happens, it is limited, inflammation is limited to upper part, and this GJ muscle is not affected by this inflammation. Further, with anticolic anastomosis or GJ antral, this apparent limb of GJ is on the left side, is far away from the probable leak site and probable inflammation. So probably this may help in GJ over setting.
So, various preventive strategies like variation in pancreatico-enteric anastomosis, going for pancreaticojejunostomy or pancreatogastrostomy has been evaluated, and various studies have shown that whether you do pancreaticojejunostomy or pancreatogastrostomy, the incidence of DGA, there isn't much difference. But it is said that pylorus preserving pancreaticoduodenectomy is associated with increased incidence of delayed gastric emptying as compared to pylorus resecting or stomach sparing pancreaticoduodenectomy. That's what we've been doing. And regarding the technique of reconstruction, as you mentioned, literature suggests that anticolic is preferred over retrocolic. And it has also been shown that doing a bronze jejunostomy also decreases the incidence of delayed gastric emptying. And this is the PODA trial done by the Spanish group, where they compared Billroth 2 gastrojejunostomy with Roux-en-Y gastrojejunostomy to see whether delayed gastric emptying is decreased or not. But they found that the incidence of delayed gastric emptying was similar in both the groups, and they said that probably Billroth 2 is favored because it does not require an additional anastomosis. So the next question is, how would you approach a patient who developed delayed gastric emptying? Professor Sitaram.
We used to do feeding jejunostomy for all our patients. So if there is delayed gastric emptying, it really is not stressful because we have a way of feeding the patient. So we just sit it out.
Okay. So these are various ways. The first and foremost thing is that we need to rule out mechanical cause. Endoscopy and sometimes even barium meal or gastrogastric meal is required. And definitely intra-abdominal collection needs to be ruled out because most of the time it is associated with postoperative pancreatic fistula. So, so this is one of our case. He's a 69-year-old male who had duodenal carcinoma of the and if you see in the imaging, he had portal cavernoma as well. And this cavernoma was not associated with portal hypertension. So after extensive discussion, we took him for surgery, and we could save one of the collaterals and do pancreaticojejunostomy. As discussed in the morning, in this case, we transected the bile duct in the end because it had got few collaterals, and we used a vascular stapler to transect the bile duct. And in the he had only eventful recovery, and he did not develop postoperative pancreatic fistula. But we were unable to progress with feed, and he had hiccups with bile reflux. And we did upper GI endoscopy, and we could see patent anastomosis, and CT did not reveal any collection. And barium meal showed, this is actually gastrographin meal, which showed that we could see in 30 minutes the dye was going into the jejunum. There wasn't any mechanical cause of obstruction. So this, we do not routinely make a feeding jejunostomy. So this patient, it was really difficult managing this delayed gastric emptying. However, the radiologist, interventional radiologist, kept a nasojejunal tube, which were and we could feed the patient. So, what would be your approach in patients who have delayed gastric emptying but do not have postoperative pancreatic fistula?
Yes, actually, recently we have very rare cases with grade C disease or the patient who cannot eat for more than a couple of weeks. So in usual manner, it would be sufficient to manage the patient only with intravenous nutrition or direct nutrition. But I think we have nothing to but to wait until the bowel movement recovers, and especially previously we put enterostomy tube routinely in all cases we could procedure, but recently not because as I mentioned, we have very rare cases with breast ECD. But in patients with especially in the elderly patients in which the cause of malnutrition will be a major concern, I recommend to put the enterostomy tube into the.
So this patient did not have bronze jejunostomy, although my colleague is here, he routinely does. And after a few very distressing delayed gastric emptying, I've also started doing bronze anastomosis, and I think the incidence of delayed gastric emptying in complicated cases has pancreatic duodenectomy has decreased. So it is not a very common complication. And technical improvements like pylorus resecting or stomach sparing with anticolic gastrojejunostomy is recommended. And bronze anastomosis has definitely shown to decrease delayed gastric emptying. We are not using feeding jejunostomy routinely, and I think it needs to be individualized. So the fourth complication is post-pancreatectomy acute pancreatitis. This is the new entity, and it was defined by ISGPS in 2022, and it is said to be associated with increased complications, especially it is post-operative pancreatic fistula. Although ISGPS defined it in 2022, it was first described by Saxon Corner in 2016, where he defined post-operative pancreatitis as elevated serum amylase more than the normal institutional value, just more than the normal institutional value. And he recommended using, based on CRP, it was predicted to be grade A or CRPOPF based on CRP. And according to the change in management or requirement of intervention, it was further graded into grade B. And when surgery was required, reoperation was required, or when there was mortality, it was graded as grade C. The ISGPS defined post-pancreatectomy acute pancreatitis as those patients who have sustained hypoamylasemia, that is, serum amylase is elevated more than the institutional value for at least 48 hours. And these patients are said to have post-operative hypoamylasemia. And if these patients have radiological evidence of acute pancreatitis, clinically relevant change in management, then it is graded as grade B. And if the patient has organ failure, persistent organ failure, either single or multiple, or a patient needs surgery, or a patient dies, then it is graded as grade C. So if you look into the Saxon Corner's definition as well, like requirement of intervention, surgery, and as well as according to ISGPS, the treatment of post pancreatectomy acute pancreatitis will be same as that of post-operative pancreatic fistula. So management will not be different. We will not be doing different management in post-pancreatectomy acute pancreatitis. It will be same as that of post-operative pancreatitis. So as you can see here, same thing, biochemical features. If it is serum amylase is elevated for more than 48 hours. And if radiological features are there, it will be either grade B or C, depending upon what is the clinical impact. So this clinical impact will be same as that of POPF. So I would like to ask Dr. Bikram Chaudhary, what is the how practical and relevant is post-pancreatectomy acute pancreatitis in our clinical practice? And being a resource-limited country like ours, can we omit radiological features to define acute pancreatitis in these patients?
Yes, so I think I would just say what we do at our institution. So day one serum amylase is what we are doing currently. Usually it is done on the next day, the second day. So it means it is around 24 to 36 hours since the surgery. And that's the time where we try to do that. And if it is significantly raised, I would not say exact value which we follow. But if it is more than a drain amylase or if it is significantly raised, we would think that this patient has developed a pancreatitis. But I think one of the important indicators of development of postoperative acute pancreatitis is also on table sometimes when the pancreas develops white patches and there is a stranding around the pancreas in the pancreatic capsule. If you see the white patches developing, these are the patients, and the patients who have high fistulary score. These are the patients who probably in postoperative period likely to also have postoperative acute pancreatitis as a component which results in their postoperative complications. Radiologically, if you ask me, we also do not do CT scan as a standard of care to diagnose a clinically suspected postoperative acute pancreatitis. But more often than not, these patients have issues in postoperative period and they end up getting a CT scan on day 4 to day 8. And that also tells us radiologically that these patients have coexistent pancreatitis, which has resulted in a fistula or some other problem. And that's how most of the times we get both the biochemical evidence and the radiological evidence. But just to suspected postoperative acute pancreatitis, if the patient is otherwise doing well, we would not do a CT scan.
Well, less than 5 minutes.
Sure. So I think then we will take questions from the delegates. So this study showed that even though definition of hypomylesemia is still evolving, because this study showed that out of 247 patients, 165 had hypomylesemia at day 1, and only 24 patients had persistent postoperative hypomylesemia as defined by ISGPS. And if you look into this diagram, like those patients who had postoperative hypomylesemia, that means elevated till 48 hours, only 9 patients had CT evidence of acute pancreatitis, whereas those patients who had hypomylesemia in day 1 had almost all patients had CT evidence of acute pancreatitis. So this is our study. Like in 135 patients, we looked into the postoperative hypomylesemia, and what we found was that the 52% of our patient had postoperative hypomylesemia, and clinically relevant postoperative pancreatic fistula was significantly high in these patients, and mortality was also high. So what I think is that although post-pancreatectomy acute pancreatitis is a significant entity, does it really have any clinical implication besides the postoperative pancreatic fistula is a big question, and the whole entity is still evolving. So we need more studies to establish this entity. So I have so I'll not
finally, but CT scan is the only thing probably which will be conclusively diagnosing the pancreatitis in the postoperative period. Everything else will have a biased interpretation. That's the problem. So this definition will evolve.
So that's what I wanted to ask, because you discussed that whether CT is required or not. But in most situations, clinical picture.
In most situations, the clinical picture will be as if something is happening. And as Vikram rightly said, after PD, if something is happening, you have to rule out a leak. The only way that you can rule out a leak and collection is by doing a CT scan. So I think for all practical purposes, a patient who is not settled after PD, cost is a constraint, but I would say that a CT should be done.
Completely agree, sir. I think the biggest problem in the management of post-pancreatectomy complications is surgeon's denial, is what I feel.
So any questions from the audience?
Another question I would like to ask everyone on the panel as well as in the audience. Has anyone ever operated on a patient with DGE, and what is the maximum duration after which you have seen a DGE settling?
Never.
Yeah, never.
The maximum, maybe Ashok could remember, we have seen is more than 5 weeks or 6 weeks. this patient, and then it settled. Another thing, which is an observation by the residents, that whenever we wanted to exclude a mechanical cause and got an endoscopy done, somehow after endoscopy the DG resolved. So probably it was not DG, it was some kind of a kink at the gastrojejunal anastomosis or the duodenojejunal anastomosis, which got corrected by the scope passing through the stoma. So that is an observation made by many residents and in many cases.
So we also have the similar experience.
So it's not an Indian phenomenon only.
Yes, sir. Almost it's a protocol now at our center that if the patient's DG is not settling for 2 weeks, third week we are doing an endoscopy in electively. But we try to wait for 2 weeks usually before we do endoscopy.
I remember there was a discussion actually in between. I am doing some administrative work also related to JSF, but there was a discussion that delayed intraluminal bleed. Now, early intraluminal bleed agreed that endoscopy should be done, but if you have a delayed intraluminal bleed, say after 7 days, 10 days, then what should be done?
Endoscopy. You can just wait. It's wait to rule out the anastomosis ulcer.
Sir, endoscopy has a limited rules, and as was mentioned earlier also, it is usually the investigations when all the other investigations were done and nothing was found, then we end up doing endoscopy to find out if there is something inside like anastomotic ulcer or something which is causing problem.
But yeah. The counter question is that could a delayed intraluminal bleed be a manifestation, say, of a small collection eroding into vessel, which instead of rupturing in the abdominal cavity has ruptured into the loop also?
Definitely. The pseudoaneurysm usually, whenever there is a pseudoaneurysm, they have a tendency to, sometimes go intraluminally through the anastomotic line and present as a intraluminal bleed, though actually they are the extraluminal streams.
So but there will be evidence of extraluminal bleed also in those subset of patients.
Yeah, I just wanted to say that in our practice, we put in a nasojejunal triple lumen tube in all patients during surgery. So it's a triple lumen Freca tube. One lumen will be in the stomach. The other jejunal limb will be in the efferent limb of the GJ. And we keep it for about a week. And if there is DG, the gastric port will decompress it. If there is none, we remove it by 5 to 7 days. We found that quite useful. And we don't do a feeding jejunostomy like you.
So I'm Dr. Dheeraj from Raipur. So anyone has experience of erythromycin in DG, because we had a patient of grade 3 DG which was up to 3 weeks and was not responding to all the prokinetics. But adding erythromycin, he responded well to that and proved well. Yeah.
Kapoor sir, can I make a statement?
Yes, please.
I really don't believe any of these drugs which are used as prokinetics in the post-op period, if they really help the relief from DG. I really have no confidence in any of these drugs. I don't know what the other panelists feel. I think the DG takes its own time to resolve. If the fistula is treated, it resolves. And sometimes if it is a primary DG, it resolves on itself after some time. I have no confidence or any drug.
I would like to make a comment actually. In our practice in Rajasthan, we are mostly a vegetarian patient with somewhat long colon. So we are using this Nesodite since 2018 in all our patients on day 3 or day 4, starting from day 3 4. And what happens, DG is often contributed with the colonic or small ileus. So I think that part being taken care of with this Nesodite, and this somehow reduces the DG. This is what we feel in our practice.
I don't think that's available in Nepal, but we have been using erythromycin with sometimes it helps and sometimes it doesn't. So this is our experience of 181 pancreatic duodenectomy at our department in last 5 years, and our POPF rate, CR POPF rate is 22.6%, and this DG is 5.5% with mortality of 8.8%. So before I conclude, I just want to mention the Porsche trial from Dutch Pancreatic Cancer Group, and they have come up with the mobile app where you can feed all your data in that app. We can download it and we can and where all the data can be entered, and that will give us the whether CT is recommended or not, whether so for us, we routinely give antibiotic. They also mention that whether antibiotic needs to be given or not, and even it tells us when to remove the drain. And it also helps in evaluating the CT scan that is done in the post-operative period. And implementing this algorithm or this sort of AI, they showed that the primary composite outcome was significantly decreased in the intervention group, as well as the bleeding and the new onset organ failure also decreased. And the postoperative procedure specific complication, there wasn't much difference, but the failure to rescue decreased from 15% to 8%. So those patients who developed complications were identified early and was managed appropriately. So, and that smart app has been validated by the surgeons in UK, and they also showed that it helps in improving the post-pancreatectomy outcomes. So as a take-home message that complications are part and parcel of any surgery, and reporting of these complications are important. And it is important to anticipate the complication, identify it, and act promptly. And there has been shift in management of complications as we go for step-up approach, and the importance of multidisciplinary management for good outcome cannot be undermined. Thank you very much.
Our next panel discussion is on biliary complications. I invite Dr. Kulbhushan Haldenia as a moderator. Dr. Kulbhushan is a consultant in GI and HPB surgery, Department of Surgical Gastroenterology and Liver Transplantation, NIMS Hospital, Jaipur. I also invite the panelists, Dr. Anand Nagar, Professor, Department of HPB Surgery and Liver Transplantation, Mahatma Gandhi Hospital, Jaipur. Dr. Ashok Kumar, Professor in Department of Surgical Gastroenterology, SGPGI, Lucknow. Dr. B.L. Yadav, Professor of Surgery, SMS Medical College and Hospitals, Jaipur. Dr. Kishore GPS, Clinical Lead of HPB Surgery and Liver Transplantation at Fortis Hospital, Bangalore. Dr. J.B. Agarwal, a Senior Consultant, Gastrointestinal and Laparoscopic and Bariatric Surgeon, Agarwal General Hospital and Polyclinic, Mumbai. Dr. Kanchan Sachinandani, Chief Consultant, GI and HPB Surgery at Jupiter Hospital, Thane, Maharashtra. Also joining us online will be Dr. Saurabh Galoda, Associate Professor in GI Surgery from AIIMS Delhi.
Bhushan will try to finish it.
Yes.
Good afternoon, everyone. First of all, I would like to thank Kapoor sir and Jaipur Surgical Festival team for inviting me and giving me this opportunity. So I will start with this from history and make a diagnosis. So middle-aged female has recurrent biliary colic, evaluated with ultrasound abdomen and find to have polylithiasis. So it straightforward, we will plan for cholecystectomy. And nowadays, now that we will do by laparoscopic technique. So can we go for this? Have we done it slide? Yes, sir. Okay. So this is the I'm showing the video and during Talos resection, Yes. I would like to ask Ashok sir, what has happened and how do you advocate the situation?
Actually, surgeon is trying to dissect like serious. So, and he started away from the required side of the dissection. And second thing I'm saying is no traction at the infundibular. Just make the mistake and the plane looking good. There's a diagram and some kind of taking the more bites at the last stage of the dissection have created problem in the tank in the CPD also there in the liver just wasn't fine. There is no time for
So very well said, sir. Like this, the basic things that when you do the laparoscopic cholecystectomy, then the traction should be appropriate. Like your fundus should be on your right shoulder, infundibulum should be over the right towards the right leg and outwards. And another thing, he started the dissection slightly away from the callus that you can clearly see in this. So three things you can learn from this video. Suppose that this has happened intraoperatively, then how will you manage this thing?
So it's all depend on the situation. We can see there's no much adhesions or reaction around the calories. And who is doing it depends. You're young, you're in the early stage of your learning, better to convert or call some senior person. If you are able to repair, you are doing well with the advanced laparoscopic surgery, even you can repair laparoscopically also.
Okay. So, first of all, I think we should recognize that from where it clearly seen that it is from the CBD, but for student point of view, I would like to comment like for operatively there is if on surgical side, if there is a bile, then you should also see the color. Like if golden yellow bile is the watery, clearly flowing, so most likely from the CBD or liver. If is the yellowish green bile thick, viscid, then you should come the like you think about that it is coming from the gallbladder. Or if it is a dark green bile, then you should think about the duodenum. Okay, but in this case, it's not. It's clearly visualized that because he is away from the callus triangle, the section doing over the CBD, and clearly is the golden yellow bile. So, sir rightly said that uh, if the injury is small and then you can repair intraoperatively.
This also depend on the stage of the surgery. Initially, you started the surgery, you're picking the ball patterns, look tribal, angry. So most of time you have an injury in the gallbladder because it's tribal. You're trying to pick the gallbladder. When you're dissecting the callus triangle, hypocystic triangle, most of the times you may have an injury in the cystic duct, even the CBD. So you already have finished your dissecting the gallbladder from the cystic leg. You may have a bile from the gallbladder because of the injury. Even you have finished your work and you are beyond the cystic plate, you may have a bile from the liver itself on that communicating in the gallbladder.
Sir, want to say something?
First of all, I would say for the delegate that usually we start the dissection posterior, not anterior.
Yes.
I think that is a very important message we should remember. The first dissection is posterior peritoneum, and peritoneum is just one layer thin. You don't do picking up thick tissue. So layer by layer you should dissect.
Yes.
Sir.
I think I agree with sir. The area of dissection is unsafe here. It's not a safe zone of dissection. The dissection here is at the base of segment 4. So it's actually CNC rather than CBD. So homeopathic cut has been approved for it. And the energy source also we should see not all cases require ultrasonic shears to start sections. I mean, you can do it with a simple electrophoresis, which very pretty familiar.
Just to add in this, principally in the laparoscopic cholecystectomy, we always try to start from posterior dissection first. After finishing posterior dissection, we change our position to anterior dissection. We always try to do posterior dissection first. It's very important.
The three principles of taking a hook cautery, it's look, hook, and cook. You have to look, then hook the tissue, and only then cook. If it seems transparent, only then you can cook it with your energy source.
So in this case, like we identify the injury. Suppose, sir, if any this surgery is doing somewhere outside in periphery. So what message you will give, like that surgeon how he manage? He is a general laparoscopic surgeon. Yes, sir.
See, it is a little beginner with sort of a novice and beginner. I think you should immediately call for a help. A person who is more well versed and who is good at suturing. But many times it happens that in a peripheral place, the camera is not good, the vision is not good. Even if you want to suture, you may not be able to suture because your equipments are not equipped for that suturing. So it all depends on what sort of a setup. But I think the most important thing is to call for a help.
Yes.
Brain and refer would be able to see them.
Yes, sir. So message is loud and clear that if you are doing this surgery in periphery and you are not very confident, it's good to put a dream and refer the patient and talk to your colleague or senior person that he will manage this, because there are other medical legal issues can occur if you the patient is treated at your center. Suppose, sir, if there is a complete cut off, like cut the CBD and you identify intraoperatively. So, Anand, boss, then how will you advocate in that situation?
In this condition, it depends on the expertise available in the theater. First of the expertise of the surgeon, then expertise of in the form of equipments. We all need equipments in the form of good sutures and the this needle holder we need for this. So that if the surgeon is not competent enough to do a suturing, so if he divided the duct, so then if he is not able to manage, we don't know how to manage the bile injury. After division of the complete division, the patient need hepaticogynostomy. If he is not competent enough to do the surgery, he should put a drain and refer the patient immediately.
Yes.
I think in early injuries, you should also make sure there's no vascular injury. That will also determine whether you want to do a repair. There is a hepatic valve, you will probably get a repair. Otherwise, if it's early injury with no vascular injury, with expertise, probably repair.
The only concern here, sir, if there's no vascular injury and if he divided the duct, if the injury of the level of injury is below the confluence, we can apparently repair in such cases because of the preservation of the blood supply of the other part of them.
Yeah, I think that's a fair point. Doing an end-to-end repair is prescribed, but I would still think that the hepaticogynostomy must be a gold standard. We can do a very
But with the end-to-end repair, the chances
End-to-end repair will cause a lot of strictures. I would disagree for end-to-end repair. I think good FJ, if you have expertise, will be the thing, because otherwise you'll create people who will go on having problems with stricture and irritations and stenting and all that. So if the size of the duct is good, then probably end-to-end. If it is less than 3 millimeter or something, I think FJ will be the better choice.
Also, usually these cuts are made with energy sources. You wouldn't cut the CBD with the scissors. at any point of time. So the edges would have to be refreshened, and then you have a loss of segment there.
I want to add in this. If a surgeon has a talk with you regarding the injury, so you have to instruct the surgeon do not remove the gallbladder, because in the trying to remove the gallbladder, he will divide more more the duct into two places. So he just put a drain and the refer the patient.
So, message is loud and clear that if you cut the.
Can I interject in this one? Hello?
Yes, sir.
There are two things. One thing is when you're doing the cholecystectomy for an uncomplicated stone, highly unlikely that you're going to get a dilated duct. So which means that doing an HJ at that point in time is basically something which we used to see that all primary failed repairs will eventually lead to a redo hepatic ostomy. So I don't think that we advise to anyone. That is one. And second, the vascularity is usually acceptable because there are collaterals at the joint if we go through the anatomy of the duct. So end-to-end repair expertise available still than I think an HJ to an undilated duct. That is my point, but you can always debate.
Yes, I want to add, Dr. Saurabh.
See, in an aged person, say 70, 75, the CBD will definitely be dilated because with every 10 years, the CBD dilates about 1 to 2 millimeter. So if it is aged person with the dilated duct, you can do HJ.
Sir, in case of bile duct injury, which is located in the higher and near the confluence, if there is no vascular injury in a current era when we are doing fine suturing, availability of the fine sutures 5 or 6 or PDS, we can directly afferently go for anastomosis, hepatic genostosis.
Correct.
If you are evaluated surgeon, you have a competence, you can then do the laparoscopically, you can do the laparoscopically, it can open, just convert the patient in the open and try to make an anastomosis. You can done. Not done, you cannot done, just refer the patient for the expert. I think this is the best way to work.
Okay, very well, sir. Very well said, sir. So, like message is loud and clear. If you complete cut the duct and you identify it intraoperatively, if you are a biliary surgeon and there is no vascular injury, no significant loss of the tissue loss, then you can repair primarily if the duct diameter is more than 4 mm or but if duct diameter is less, then it's better to go for the hepaticogynostomy. And if you are not a biliary surgeon, then it's better to put a drain and refer the patient. And if there's a vascular injury, then also better thing to repair in the later time. Yes.
So if you are a hepatobiliary surgeon and if you have done the injury, you should not do it. So you should be calling your colleague. You may be an expert, but at that time you are stressed.
You may not. If you have a good team.
I will not agree with that.
No, may not be agree.
I will not agree with
If you have a good team.
It all depends on
you can do it.
how stressed you are. If you are stressed out too much, then call for a help.
Yeah, definitely. Keep the patient packing and the phone.
And I'm not saying of myself, there is literature to show that.
No, I agree. But on a lighter side.
Sir, the biggest problem for a surgeon is the ego of the surgeon because we feel that we have failed. That is the problem, and then we fail even more. And so calling a help is never a wrong thing to do. It is always better because you'll get another perspective, which is actually something you might be missing at that point in time. So even if you are an expert, never hesitate to call a help or call your colleague, and it will always help you. That is my point also. I also agree with Rajesh sir in this.
I think I also, if you are an experienced team, you will have other good HPV surgeons who will come and check. Invariably, if you've done a bile duct injury, you will not be in a good frame of mind to repair it. God forbid if it happens, you will not be in a good frame to repair. So it's better your colleague comes and chips it. The other thing is end-to-end repairs. I would think that it will be a very rare scenario. I mean, I don't think it's, if you have to give one message, I would say that if you have to go primary repair, let it be a hepatic ostomy and let it be done by an experienced person. End-to-end is, I think, more clear.
Only in case of more than Caesar.
More than 50% chance of the snow.
Stricture.
In the era
Hand to hand.
of transplantation, what do people do?
Any that.
Transplantation is a non-dilated and that's end to end only. There's no big deal. Secondly, if there is a better person than you, you can.
Everything is improved. But never seen in the bile duct injury. You may not have the enough data to say that. It will be affected as effective in the bile duct injury.
And secondly, this instance, I mean, you need little more dissection before you suture. Yeah. Here, this is something we should.
I've taken video from my collection.
Right.
That is done.
Just to start the discussion.
For the discussion only.
Without defining anything.
Yes,
just
yes, this is not the right. Actually, yes. Okay. I'm showing again one video, another video in which colleague GB has taken from GB bed, and after that there is a bile at GB bed. So Ashok sir, how do you advocate the situation?
You already have dissected the GB and there is bile coming from the GB bed. You could not see the opening. And we should try to see the opening, where it's coming from, and definitely it's coming from the GB bed. Maybe some the connection directly connecting with the GB and that may be connecting with the main stream of the bleeding tract should be found and be repaired or cleared.
Yes, sir. Sir, want to say something?
Yeah, it could be type of Lushka, which is a fine leak. You decide how much is the bile coming out. If it is just a minor leak and minor this thing, most of the time with the duct or Lushka, you just promise to stitch there and let it stop, and better to put a drain, I would advise. But if it is a bigger leak, then probably you'll have to define from where it is, whether it is coming from the accessory duct or something, and then act accordingly. As well, less than 2 millimeter advisable is ligate. If more, it look like it 3/4 meter, you may require some reconstruction.
So just to add here, whenever you see any leak in the GB bed also, you go back to your landmarks again, see for your R4U line, whether it is above the line or below the line, if it is a major duct leaking or a minor duct leaking. So as sir said that if it is less than 2-3 millimeters, usually these are very small aberrant ducts and do not have any major communication with the biliary system, and if you suture it off, they tend to stop, the leak tends to stop. And yes, a wide drainage after the surgery.
Below the 60 plate and we mistaken for Dr. Plushka. Because Dr. Plushka, I mean, all of certain so many lab questions. You have probably seen one or two in at least in materials. Some must have seen more. But before you call it Dr. Plushka, you would be very concerned if it's a posterior duct. So you make all efforts to make sure you're not closing out the posterior duct.
So try to see the whole scenario, the background, the environment.
How will you confirm that it was here the on table?
So we can do colangiogram. What do you say? We can do colangiogram. We can do sample leak.
This is not show.
It's not connected with your main.
It's not connected.
If not connected with the main stream, it may not show aberrant duct coming down.
Yes, we can confirm the posterior sectoral duct on the time. If we can do the interpretive colangiogram then. The posterior sectoral duct we can get to know.
You can go back and carefully look at it. If not, you can try to put in a small infant feeding tube into this and do a colangiogram.
It looks very small.
On the cholangiogram, then you know it's a posterior duct. Then you can take a call what you want to do.
Okay.
But in the intracholangiography, if it is actually an aberrant duct, so won't that give us an indirect clue as to that this duct was
Yeah, so yes, see, before calling it a duct of Lischka, we should make sure it's not a posterior level. If you find that it's a posterior duct intraoperatively, on the cholangiogram, you can see how much of parenchyma is drained. You can get an idea of how much liver parenchyma that white duct is draining. If it is draining a significant sector, then you have to go ahead with this last one. I call for help and do.
I'll show you sir another video on basis of that. Like you're taking the gallbladder from cystic plate, and during dissection, we found this tubular structure. So these are two videos. Sir, any comment on this? Kishore sir?
I think it could be it could, I mean, if it's higher than the GB pair, it could be beauty of the middle hepatic vein because it runs in the campus line. So it's right there. Sometimes it's quite superficial. It could be a tributary of the middle hepatic vein is what I'm thinking because you clipped it. I don't see. Is there some bile there?
Yes.
So if
So like.
So if there is bile, then it could be an aberrant bone.
So just one thing, like whenever you see any structure like this, after clipping, please cut it with a scissors and not with an energy source because that obliterates the, if at all there is a lumen, it will obliterate and you won't come to know what it was, whether it was a vessel or a bile duct.
Second thing you can do, just open the specimen.
Yes,
Try to find the inside the connecting the inside of the GP. Look for the mucosa in the same orientation. If it's found you have a connection, maybe the fibrous case.
It's nowhere near the height. It's higher in the so this I can agree that this could be a because this will not matter because it's very high. It's in the GP plate. So you can clip it off.
Is there anything at all? Because it is not even bleeding, not no bite.
Because
the specimen
Sir.
So one is that does the location matter because this is almost at the fundus. And second, your point that don't cut it with you have clipped whatever it was you have clipped.
Just to ensure what it was.
She's saying something should leak from the gallbladder.
Yeah.
Nothing is leaking.
That's why I've checked with the opening the specimen.
Some tissue, thick tissue, that's all.
Commoner is a middle hepatic vein tributary because that can be very superficial subcapsular and it can bleed a lot sometimes. So you have to stay closer
Most
to
of the time it looks thinner, loose, and very present.
Yeah, but I would reiterate what Kishore has said that a tributary of the middle hepatic vein can be very close to the cystic plate. And if this is obviously a thick walled gallbladder, if we have gone into the parenchyma, that means beyond the cystic plate, you can cause injury to this tributary. So you have to be very, very careful there and it can bleed like anything.
Agreed. Fully agreed.
Yes, sir. So, sir, my question is in both videos, we are above this R4 line, like from Rubius sulcus and the umbilical fissure segment 4. Even after that, doing all proper technique, the section posteriorly, then define the critical view of safety, and then you encounter this situation. Even after that, the aberrant duct can come. Like you can encounter the aberrant duct.
Of course, you can have a
Okay, so like these two ducts, as we discussed, like most probably in first picture there must be the duct of Luska, and in second that is the cholecystohepatic duct that is communicating with the gallbladder to the any hepatic duct, and this is the duct that is lying just close away, just above away from the gallbladder bed. So if you are remain close to the gallbladder, then most probably you will not encounter the duct of Liska. And cholecystohepatic duct you always encountered and you have to tackle them. But usually they are very small ducts, so you can repair at that time and not bother.
Very nice.
Okay, I will show you another video.
I hope you have declared that these are not your lab bodies.
I just collected from the.
It's very difficult to get them actually.
Actually, so the duct and artery, and we have cut the duct and so and it's also not a good idea to cut the duct by hook, but yes, we are cutting. And after further dissection, something is visualized to.
In there, and there's a bile there.
Yes.
There's already a tinge.
There's a tinge of bile there.
There's already a tinge of bile.
So Anand, what is your comment on that?
First of all, when we consider the laparoscopic course, we should follow the R principle. R principle is to do external dissection first, followed by empty dissection. Then lower one third system should be lifted out in the gallbladder. In this video, we can see the gallbladder is not lifted on the system. And the surgeon just started dividing the system by it looks some sector that maybe the anti sector comes can which is dividing.
So very rightly said that the surgeon had not done proper job. Like he before cutting these duct and artery, he not demonstrate the critical view of safety.
Definitely. It's look like his complete excision of the CBD. First, you have clipped and divided, and secondly, he just divided because there is no clip. That's why the bile is start coming. So easy looking. The gallbladder is pristine, plain, is looking fine. Everything fine. You may have a chance of the high grade injury because we have a possibility to go on the left side of the CBD, and you may have excision of the CBD. But looking frozen, the severe kind of the additions, always the nature protect the patient from the surgeon because you have to remain on the right side of the CBD. You may injure the lateral side of the CBD. You may injure the right sectoral duct of the system, but you may not cover the full CBD because it requires a lot of effort and the skill. So always try to make the triangle, hepatocystic triangle, which include the liver, right side of the CBD, cystic duct, and try to find two structure only in between the cystic duct and the artery.
Kishore sir wants to say something.
Yeah.
See, I would like to reiterate the critical view of safety because that is very important. The critical view of safety has got 3 points. One, that you should see from anterior and posterior only two structures going to the gallbladder. Two, all the fibrofatty tissue between the cystic plate and these two structures should be removed before you divide those things. And third is that you should show to a surgeon, another surgeon there, present there, and show him that this is what critical view of safety is, and this is what I'm going to do. So all three principles have to be followed before you go in.
So can I interject on this one again? Sorry to interrupt. Actually, if you go to the literature, we find that visual misinterpretation is the biggest cause of injury. And critical view of safety of late, I'm not too sure whether if a person has taken the CBD along up, and still he will find those two structures only. So as we have discussed sometimes in our group that it is always better to stay closer to the gallbladder rather than, be too conscious about this, finding this critical view of safety. Because if you have misinterpreted, then whether it is you, whether it is your friend, colleague, whosoever is, one thing I agree that someone else might have a better perspective than you, but still to always profess that critical view of safety is something which will save from bile duct injury is probably not correct at this point in time. I would rather say that it would be better that we stay close to the gallbladder and dissect closer to the gallbladder. and find those two structures. People might differ from my viewpoint, but that is how I see these things.
Can I clarify that? So if there's a vertical structure entering the duodenum before your dissection, like in this case, it's likely to be CBD. And I agree with everyone that it's probably a segmental excision of the CBD here. CVS can be established in easy gallbladders, and it is a must to do. And I think visual confirmation and everything will actually add an element of safety. In certain cases, like difficult cases like acute cholecystitis, where there's a frozen calot, you may not be able to always establish a CVS. In those cases, you have to have alternate bailout strategies. That's an entirely different discussion. So I'll leave that. But I think in this, it is probably misidentification of the CBD as the CHD and wrong traction and vertical traction. I think a segment of the CBD is excised here. And I also suspect there will be an arterial injury in this.
Yes. Actually, you see the video again further. See the segmental aberrant duct. So CBD visualize properly. Yeah. Sir, you encountered intraoperatively. So how will you manage it? Okay, sir.
So you're saying this is a sectoral duct that has been clipped? Is that what you're saying? Okay, in that case, then first, I think basics, you have to call your colleagues who are more experienced to come and see. And we have to try and see what exactly has been injured. So if it is a sectoral duct that has been clipped, we can see if you can safely do a cholangiogram. So in doing a cholangiogram, you should not create more injury, trying to cannulate something and creating a new injury. If you can define the extent of injury and see what the sectoral duct and what has been clipped, then you can plan your further strategy.
There, yes, we have ICD facility. Probably you can make use of that, and that will give you the anatomy what it is, and it will help you out. Because sometimes the cholangiogram may not be possible because you already given by how will you do a cholangiogram? Injecting into the gallbladder is not delineate because you already clipped it divide. So ICG is another rescue thing which we can learn. Yeah, definitely, I agree also. So cholangiogram may not help, but some kind of more dissection, meticulous dissection, try to identify the duct, whether it's right or main duct. Then you take the somebody has advised this is smaller that may not be a good option for the hepatic also consider.
So what are the criteria, like when you will repair and will you not repair in this situation? Like,
always remain the same, whether you can repair, you have a experience, you have gone through these cases, you have a good result, you have a confidence, you have a support, all this all depends. And if you cannot, just better to place the brain, call some your video and report the patient.
See,
Yeah, yeah. If you want to.
see, here there's no life-threatening problem. A major duct has been clipped, that's all. So, you can see what you want to do. If it's in a peripheral center, just refer the patient. And then you can always deal with it later. If a sectoral duct is clipped, what will happen? It's a sterile system, it'll dilate and, later on you can send that person later for a hepaticojejunostomy later at some stage. So the important message here is, I think, don't do more damage here. By trying to dissect the bile duct or trying to identify doing a cholangiogram, as long as there's no bile leak, it's a clipped system, you reconsider. If it's the entire right hepatic duct clipped also, it's not an emergency life-threatening situation. You'll have time to discuss with an experienced person. First of all, we have to identify what is the extent of damage that is caused. And then you can plan your strategy.
I anticipate one problem we discuss very often, the intracolangiogram. So my question to all the panelists, do you have facility of doing intracolangiogram OT setup and infrastructure in your own setup? At least I don't have where I operate most of the time. So it's more often a academic discuss we should do intracolangiogram. So we don't have the facility to do that. So we should give a message to that what happens, what should next to be done. At least I strongly agree the person who makes the injury, whosoever is the mindset of person on that particular day, particular moment, even the HPV surgeon would have been a good mindset, he would have not done the same damage. If I had done, then better to call refer to that. The crux of that is that do not do more damage. Referring is not an issue because this case looks like a very uncomplicated without any sepsis. You make a call to a senior colleague with expert facility, he can do the same job very next day because early bile duct repair by whatever way he feels like, if it is aneurysm or primary, whatever we decide, he can do better way rather than we try to do by ourselves. So my request that in panel discussion like that, role of intracolangiogram should only be talked about if we have personal experience of doing it, otherwise should not.
I would like to make some comment on this. See, nowadays, many centers have started doing ERCP. And once they have ERCP, I'm talking of my days when we used to take pictures, you know, static pictures, and then we didn't have, but I was doing that, but that is a different era altogether. But now the era is of ERCP. So many theaters would have a CM available to them. And if you are doing gallbladder, I would request all of them to occasionally practice operative cholangiogram so that when the situation like this arises, you are little more comfortable doing a cholangiogram rather than just referring.
Regarding regarding ICG, many of the time what I have seen in ICG, whenever we require need of ICG, it won't work. It happens always. In the patient in whom we require the need of ICG, it won't work. The diet is not reached in the gallbladder. And when the such type of the incident happens, on the time we give ICG, it take around 2 hours to reach the ductal system because it needs about approximately two around 3 hours to reach the ductal system. Number one. And intraoperative cholangiogram, yes, sir, we can perform intraoperative cholangiogram safely, but we need a CM only. In the multi-specialty hospitals, they orthopedic centers, they all have a CM, so we can perform CM. I have image. I have just shared the intraoperative cholangiogram also. We'll share with the image of intraoperative. Okay. But we can safely perform cholangiogram.
I point it we go to Gurmukh and then we go to Siam. People comfortable with this.
Yes, sir.
That's my point.
Yes, sir.
That's why referral is important. If you do not have a support, do not have a person, do not have a expertise, just refer. Please detain.
To be honest, cholangiogram
Doing a cholangiogram during lap chole is a rarity, actually. In the sense, it is extremely rare that we have to do cholangiograms during lap chole. If you anticipate a difficult gallbladder, you can do a preoperative imaging. It can be an MR or it can be a CT sometimes. And if you cholangiogram to prevent bile duct injuries is a totally different thing. I think it should not be done because if you try to do in the context of a bile duct injury, you may cause more damage. It's better with experience that if it's a difficult gallbladder, you use bailout strategy, stay away from the CBD, do a partial cholecystectomy, all those things can be done. So it's a very rare situation where you have a doubt that you injured a bile duct. Only then you should very judiciously consider doing a cholangiogram.
An article in the American Journal of Surgery saying selective cholangiography is the way forward. If you have abnormal LFT in the beginning, we are suspecting a duct stone. Under those circumstances, only when you are able to define this defect, do a cholangiogram. In bile duct injury, it has always been shown to cause more damage rather than rescue the patient.
I agree with you. In the first instance, I think we should have preoperative imaging.
So, message in this this discussion is if there is aberrant ductal injury is there, first reassess that, look the size of that duct. If size is also mentioned, literature is less than 3 mm, or if draining the some part of the liver, then you can clip it. Size more than 3 mm, then it also said that it should be repaired if it is a good biliary surgeon, or either put a drain and refer the patient.
The concern is also there, the interoperability, how can we identify the size of this data?
No, just,
Like that's a when the injury
I
happened,
got it.
and when we look at that size, it's very difficult to the size to measure the size.
yes. So for minor bile duct injuries, I showed some literature. Stars was A, B, and back repair with or without the placement of a Q-tube and the placement of adult drain in the areas concerned, if and appropriate. This is the survey from the France in which they've taken the 47 centers and 640 bile duct injury was there, and they've seen if they repair immediate, the failure rate was 64%, but that was actually survey most of the general surgeons. So, but there are few other literature that is recently published in 2020 in which early referred to HPB center and done by the biliary surgeon, that is routinely do the hepaticogenoscomy, in which results are better.
The difference I think that the HPB surgeon makes is he does a HEPCO repair.
Yes.
And this should not be attempted by a young surgeon in a bad situation, should not be done, because he'll convert a type 1 or a type 2 stricture into a type 4 stricture. So it is HEPCO should be done in a center with expertise by a senior surgeon. In an undilated duct, it's difficult. Risk of portal vein injury is more because of the orientation of the duct it's above the portal venous segment, and to approach the bile duct is difficult. So it's much more difficult to do a HEPCO in an undilated duct.
Yes. Okay. Yes, I am showing you a video in which we are dissecting the callouts, and you have seen this. So, Agarwal sir, how will you advocate the situation? How will you?
See, this is definitely a arterial bleed. We can see it pulsatile bleed, which is fairly good amount of blood gushing out. I can see the upper border of liver there. So we are not very sure what has been injured. So first thing I would do is to put in a pack and wait for 5 to 7 minutes and get things organized. Get things organized in the theater. Probably tell the anesthetist that we might require blood, we might require to resuscitate, maintain the blood pressure, get everything else organized, your diathermy system, your clipping system and everything, your suction properly. And then probably after putting in a gauze piece and waiting for enough time, you gradually remove the gauze piece with the suction and maybe a clipping mechanism ready with you, and then gradually withdraw and see now what is bleeding. If you can identify that it is the cystic artery which is bleeding, probably you'll be able to clip it and manage this thing. The most important part is not to panic. If you panic and try to blindly apply clips, I think that is the most dangerous thing which you would have done. But if it is a hepatic artery bleed, then probably you have to be careful about it, because if it is a then you will have to artery, because clipping the hepatic artery will lead to the increase of the maybe it may be right hepatic artery, which so that is able to clip that. So you have to repair it. If you can repair it, well and good.
Yes, okay. So, sir, wants to add something.
I think I would also first put in a gauze piece, keep pressure for some time. You use one of your left hand or right hand to push the gauze piece against this artery. You wait for some time, like sir said. Then I would use a bipolar in my left hand, suction in my right hand. Just irrigate it nicely, see where it is coming. Because it looks like an inflamed gallbladder and the bleed is quite high up. It's quite high up on the gallbladder side. So I think it is cystic artery, but we should confirm, make sure it's cystic. If it is cystic, I'll just flush it with the suction on my right hand and just bipolar it with my left hand. It will stop, because applying a clip in a friable gallbladder may not hold. We can just bipolar it if we are sure it's a cystic artery. It will stop.
In this sort of situation, we have observed an arterial anomaly where the artery supplies segment 5. There's a very small branch that goes parallel to the gallbladder, and it empties into the bed of the liver.
Yes, mid bed.
In mid bed of the liver. So if you're careful, we can preserve it, but otherwise you will end up in a situation like this when you're separating it. It can be clipped with impunity because it's going to supply a very small portion of the liver. But ideally, you shouldn't take it.
Yes, sir. So, yes,
Sir, Professor Kapoor wants to say.
I would like to enter into a debate with what Dr. Agarwal said, that ligation or clipping of the right hepatic artery.
If the liver is normal, if the patient has no jaundice, I do advocate, especially to young general surgeons who are working in small centers, that if you have a situation where you have injured the cystic artery at its origin from the right hepatic artery, it's like a hole in the right hepatic artery. Rather than losing the patient on the table, I would advocate just clip the right hepatic artery, because it has been shown that clipping of right hepatic artery, if the portal vein is intact, in a normal liver with no jaundice, it may cause some enzyme elevation, but it would probably not cause any fatal or dangerous consequences.
I've done that on 2 occasions, sir, but I didn't want to give it a general message to everybody that this is the one.
No, that is what I said, that I would like to enter into debate. Because I say this, I tell when I'm addressing general surgical audience who are working in a periphery where there is no other support, he is the only one. Rather than losing a liter or 2 liters of blood converting and all that, I say that it is safer that you clip and then do whatever.
Yeah, because most operatively little elevated enzymes and that part will necrose and probably nothing. Only thing later on it might form in an abscess or something, but the patient is saved at least. Yeah, definitely. And this situation looks more dangerous, more typical because you have a lot of inflammation. You do not have an idea of the anatomy. Your spurt of the bleed is better to have a DBK or vascular forceps on the left hand. And as sir has said, it should be used as a bipolar energy source, or initially just pack. If it's stopped, just wait for a few minutes. If it's not stopped, just use your bipolar. No way to clip in this situation.
okay. So, message is clear. Like if it is this kind of bleeding, then first of all, press it. Press it 1 minute, 2 minutes, for 5 minutes. Usually, if this one from cystic artery, it stops. Yeah, the severity of that is showing like that, it's not looking like. Okay, don't be panic. Don't be panic. Ask your colleague, resident, the staff to arrange the blood, and don't clip like eyes are not like that. Because if you clip, then it might be even more like portal vein or duct and other things. So just be calm, and most probably some cystic artery, it will stop by just pushing and pressing it. Yeah.
Arrange everything for the conversion also.
Yeah.
Ready
If it not
for the
stop,
conversion. Keep it ready.
The way it's spurting, I would rather hold that with one of the blind Maryland like that, and then use the right hand to dissect and suck, and quite often you can define the entire structure. Because if this is the artery spurt, put a gauze, and a minute the gauze will be affected. It'll keep on sucking on it, So it's possible just to have a Maryland to just hold it. I mean, any arterial spurter, better to hold it. Sometimes you just bust the Maryland and
Yeah, definitely. It can be option.
Depends on the location of the bleed. This image, in this video, we can see the bleed very high up. So maybe there is a small branch. When it's near hilum, then we should be very careful before doing cautery or ligating this bleeding.
It's near the gallbladder, you can buzz it against the gallbladder.
Not for this case, but once in a while we should just turn our heads to the monitors for the anesthetist also and look at the vital parameters. Look at the BP, whether the BP is short or like more than 200 or something, and control those parameters also simultaneously.
Yes, if there's a bleeding and vitals are not like deteriorating, it's better to open and come like ask for help to some senior person. Yes.
There is no point of doing open without controlling the bleeding. And to take adequately, even the time for conversion open, then do by the time lot of bleeding out there.
Yes.
So first control, compress, will it adequately
After
compress? Then
com-
open.
yes,
But in sometimes we encounter the variation in the cystic artery anomaly also. Two branches, anterior, posterior, accessory artery also. Here also we want to know whether he has divided the cystic artery or not. Even though we have divided the one cystic artery, anything going into the GP like the tubular structure, we can presume that secondary artery, accessory artery. Even there will be variation in the anterior, posterior also. So dividing one cystic artery does not mean it will not bleed again also, especially the government inflamed acute inflamed.
okay. I show you the another video in which during the posterior dissection, there is a lot of bleed. Say, filling and filling, we are compressing again and again. It's not stopping. So, Agrawal sir, what is your comment on that?
See, this is, I think, below the Ruvier sulcus or in the Ruvier sulcus, as I can see the anatomy there, and the bleeding is really torrential. So, in my opinion, it is some major vessel which is injured. Either it is the right hepatic artery, but I don't see any persistency, but the bleeding is really severe. So, either it is the right hepatic duct or portal branch or the right this thing which is bleeding. So, this is a very critical situation. In this case, probably packing may not help, but packing is the first thing we would do. And get organized everything as we have said. Probably arrange for a blood, arrange for opening this thing, ask for a help. A hepatic surgeon or a transplant surgeon will be of great help here. And then go ahead and see what it is injured. And depending on what is injured, you'll have to take care.
Yes. One of the situations where if you are doing a retrograde dissection of the gallbladder, it's very easy to injure the right branch of the portal vein, especially posteriorly. In that condition, and also if you are dissecting from above the callous triangle, you can go into the portal vein and it will bleed from there. So, two situations where we wouldn't think of keeping it laparoscopic anymore, we would convert immediately.
It look like a portal.
Yes, sir. So it's
Quite
not
often, when you're trying to convert, the surgeon should have the experience to control it on table. The one who's done this may not be in a position.
Correct.
But
Very-
it's-
Actually, you can pack,
you can pack.
you have more packing, you have more pressure. You cannot apply with the laparoscopy. It's better to get.
So yes. So like as Kapoor sir told, like right hepatic artery, you identify intraoperatively, you are not in position that you can repair it, then you can ligate it. But it's from the right portal vein. In that scenario, you can not ligate it because it lead to the catastrophic. So you have to repair it. So either call to the transplant surgeon or any biliary surgeon that can repair the.
And often when this is not possible, you should advise them to pack and send.
Yes, sir.
Pack and send.
Yes, sir.
Pack and send.
That is the last.
Very true.
Okay, so like we are talking about the bipolar as sir told. I am showing you a video that during bleeding we have used the bipolar cautery and what happened.
No, this is one.
No, sir, just it's a different case like that is doing the callus dissections, difficult gallbladder.
Expecting instrument coming.
Bleeding there.
So during the blunt dissection, from suction there is a bleeding in the callus. Okay.
The concern is the bleeding or the bile
No, sir, just wait. Sir. We use the bipolar cautery just so to control the bleeding.
Is that also damaged?
He's cauterizing blindly without seeing what.
So,
He's also cauterizing.
so what mistake the surgeon is doing in this case? Yes.
See, first of all, he's cauterizing without identifying what is he cauterizing, which is the first mistake. because he does not know what it, and it is the porta hepatis where he's cauterizing, which is absolutely wrong. You cannot cauterize. There may be hepatic artery there which is cauterizing. So these are the, and plus I can see the bile duct injury already. So there is a bile duct which is divided. So it is a vascular and drainage system injury, double injury.
I think one way to avoid this situation is you do the dissection in the subserosal plane of the gallbladder. Because if it's an acutely inflamed thick wall gallbladder, you will find the plane in the subserosal area. So you can dissect there. So that way you will stay away from the hilar structures. And cystic duct you can define close to the gallbladder in this situation. Most of the time in acute cholecystitis, in this situation where there's a stone impacted in the cystic or the infundibulum. So we should not try excessively to define the cystic duct bile duct junction. So if you stay cold in the subserosal plane, eventually the gallbladder will lift off, cystic plate will be there, and you will never enter the hilar structures. So it's better to prevent these situations.
So it's actually looking frozen, even very narrow kind of callots and fourth segment of the liver. It's better to enter in the GP.
Yes.
Jump in
So
the swimming pool. That this is the best way.
So this
not
patient,
walking on the round.
in post-op period, he had hemophilia, and we did the CT angio, and we found this. So basically, it was a thermal injury to the right hepatic artery, so lead to the pseudoaneurysm of the right hepatic artery. So it's embolization done, and patient was dead. So, like messages when the things are not clear, you are not identifying the structure properly, not coagulate either by monoclonal or bipolar. No analysis source should be used if structure is not clear.
Complete embolization of the
Here I can see the, just go back to the thing. I can, no, the arteriogram. See, you can see the right and left, and there's a good collateral between right and left.
Yes.
And you can see the aneurysm. So probably the whole right hepatic artery has been embolized.
Yes.
In that situation, radiologist can utilize the stent instead of placing foam or spiral. You just use the stent.
I come into another scenario. You are entered and you see the spindle contracted gallbladder and collapse is frozen. So, what is your comment?
Madam को पूछो, madam should be important.
There are multiple approaches here. The carrots looks frozen, and then I think the deodorant is also stuck there. So, to gradual dissection in this case, you can approach with the blunt dissection, blunt dissection and irrigation, hydro dissection that we call. Attempt once to go to the carrots and then try to dissect there. But if that is not possible, then you can probably take an antidote approach.
Yeah, I will try to open the gallbladder first. Subtotal cholecystectomy, enter in the very small looking contracted gallbladder, try to enter inside the gallbladder and try to see the rest of thing from inside. Do not, should not operate or try to make a dissection at that point. This looks very bad.
Yes, sir. That is the bile duct.
That's a dilated bile.
Yeah.
Something wrong.
So I was about to say that even if you have a pre-op MRCP, I would expect that the stone is bulging into the bile duct there. There's probably a big stone which is partially into the bile duct in the middle. So in this, you can, you just have to open the bile duct, evacuate the stone and close the bile duct or close it like a choledocoplastic. But I would have some pre-op imaging for that. See, it's a hugely dilated bile duct that is quite striking. So it's not a problem to open this bile duct, evacuate the stone and repair the bile duct.
Yes. So,
See here in that picture, I think one should be careful here that that structure is vertically behind the duodenum. It means it is a common bile duct. If you see this picture very carefully, it is entering vertically behind the gallbladder, behind the duodenum. So that is very important observation to make.
Yes. It depends on.
Go back to the.
Go back.
So if you are saying this is Miridzi, Why the CBD is dilated below?
Below.
The Mirizzi will cause dilatation above. To me, this looks like as if it's a choledochal cyst, and the point which Kishore was asking whether we have a pre-op cholangiogram, was there a suspicion? Second thing is that, and because many young surgeons must be watching and they will watch these videos, if the calyx is not there, or if you can't find it after an adequate time dissection, you are finding it difficult. This is something which we have been saying and we want to document also. It is not mandatory to demonstrate critical view of safety in every gallbladder. If you try to do that, you will cause an injury to the duct and to the artery also. So only if it is possible, easily possible, you do it. Otherwise, you shift gears. Now, what Anand was saying, and I think what Ashok also mentioned, get into the gallbladder. Far from the neck of the gallbladder, in the mid body, open the gallbladder, divide it into two parts. Look from inside. What you can't see from inside, outside, where the gallbladder and cystic duct junction or cystic and CBD junction is, you can easily see from inside because the lumen of the gallbladder will be seen to be narrowing or getting obliterated. That is the point where you have to stay to the right. So this is what I call a divide and rule cholecystectomy.
So, yes, actually, I also want to give this message. Just forget the CBD. Yes, this is dilated, but see the callots that is frozen. In that scenario, don't go on the critical wave safety technique. Just forget that and do the subtotal cholecystectomy. So
even fundus first is also very dangerous in that case.
Yes, yes. Either fundus first or from low as you are comfortable. But just leave the CBD or critical wave safety because our main aim to avoid the CBD injury.
This looks like a single gallbladder. Yeah. The stone has gone into the bile duct, it should be lower down.
There could be two. One in the
He said you avoid the
CBD
CBD dilatation.
This
You
could be
just
meningeal and
consider
CBD stone, both. Maybe. Double pathology.
Okay. So, sir, another scenario, if you find that there is a thick wall gallbladder encountered intraoperatively, so then how will you manage that in that scenario? Or confirm.
So this looks so thickened means how much thickening is there, and you need to see the preoperative images also. So preoperatively whether
Then more than 3 mm, 4 mm.
3 mm. This looks edematous actually, thickening with edema. So in that case, it's probably the cholecystitis component here. But yeah, if the thickening is more, then we need to evaluate that thickening with good imaging preoperatively and then decide on the approach.
Regarding thickening, I want to comment. We need to see the focal thickening or the diffuse thickening in the ultrasound or the CT scan. Then we have a more suspicion regarding the tertiary malignancy or not. Or we have to image further or with the help of our diagnostic modality like we in our center. In case of thick wall gallbladder, after doing CT scan, we routinely do PET scan in every patient. Just to recommend is there any PET uptake or not, and we correlate this PET finding with the post-operative biopsy. See, whatever the process we plan. As per the thick wall gallbladder, our plan is to do as per the couple surgery. Of course, we remove the part of liver around 1 or 2 centimeter thing of the gallbladder with the liver and send for the frozen. But this thing we follow when we have a low suspicion of malignancy. So Kapoor said out of 9, if we have a possibility of benign disease, then we follow this approach. Otherwise, we apparently do the as per the CGP protocol, like surgical laparoscopy followed by intraabdominal biopsy and radical.
Definitely, you should have an idea of whether this circumferential thickening or focal thickening, whether there is something in inner lining of the GB. If inner lining is looking fine, it may not be the CAGB because CAGB is a disease of the mucosa. If something seen in the wall, you can see the fat density on the CT. You can see some yellow, some density in the GB wall. It's more towards the xantho. If these are the things, you may have should have an idea of the history, whether patient have a significant weight loss, have a family history, supportive kind of investigation also we require, like marker CA-19-9, CA diffusion weighted MRI also can add. These kind of supportive investigation make your confidence build up so that you can take a decision, proper decision during the surgery. Because even the, as I has described the Lucknow approach, it's very useful when you're doing the surgery in that kind of scenario. You just take out the GB without breaching the GB calots, and you have like a midway. But sometimes you also have a thickening in the neck. In that situation, we fail to demonstrate this benefit of the Lucknow approach. If it's limited in the fundus, mid body, you can approach. जैसे वो neck की तरफ जाता है, you may have a different kind of extreme option.
Yes. If a patient presents with a typical biliary colic, you put in a laparoscope. You didn't anticipate acute cholecystitis, but you see this. This is acute calculus cholecystitis. So you see whether it's difficult or easy for you to do it. I mean, I'm saying as an individual surgeon, if you think you can do it safely, go ahead and do it. This looks pretty okay. There are various gradings for acute cholecystitis. This looks okay to do. Differentiating a thick wall gallbladder, whether it's acute cholecystitis or malignancy, that's a totally different topic. But if you think there is any suspicion of malignancy and you put in a scope and you're not sure what to do, it's better to close, bail out, do a proper imaging, counsel the patient and come back with a plan rather than try to do everything on table at the same sitting. That would be my take on this.
Okay. So, like, see, this is the chart diagram that I made. If there is a.
Can I? Hi.
Yes, sir.
Again.
Yes, please, sir.
So, what about the Korean approach where you can just take the cystic wall, actually, cystic plate? It's a diffuse thickening. It's not. So, Koreans actually are not taking 2 centimeter wedge, but rather advocating less and less of wedge. So, basically, what you're doing is you're not breaching the GB wall, and then you can send it for frozen and see the frozen what it comes out, and then do completion lymphadenectomy after that. It's just a debate. I mean, what does the panel say on that approach?
There are two options. One is if you have intraoperative ultrasound. If you can do intraoperative ultrasound, laparoscopic or open, then you can take a decision on the table. If there is infiltration of the liver. If there is no infiltration of the liver, then you can follow the Korean approach and remove the cystic plate. And remove the gallbladder in torso and send the cystic duct margin for histopathology. And send the specimen for histopathology. Do a frozen section and then take a decision whether you need to take a measure. In any thick walled gallbladder in the north, I wouldn't hesitate to consider carcinoma.
So that's why multiple information is very important. Korean approach is also called total cholecystectomy. They remove the whole of the cystic plate and just the midway remain between the malignancy and the benign. So you consider everything. You consider the from clinical presentation, investigation, biochemical investigation, radiological investigation, and overall your reasoning is required.
So right.
I just want to make a quick point on that. If we see intraoperatively that we didn't suspect preoperatively, but on table on laparoscopy, you find that there is some suspicion of carcinoma gallbladder. I wouldn't go ahead and do the completion surgery. I mean, I wouldn't do the radical surgery in the same setting for two reasons. One, CAGB is quite aggressive biologically. Even seemingly with small infiltration of liver, there can be aortic cable nodes and distant mets. So I would rather bail out. They talk to the patient's relatives. The second reason is that because they have to take time to absorb this information, because you've gone to do a lap chole for a stone disease and suddenly there's malignancy and the implications are so different. So I think it's sensible to just come out and, investigate, do a proper staging and then take a call. I think.
There is the possibility that
Yes.
Yes. The carcinoma of the gallbladder, then I will continue with what I said. Otherwise, I defer to you. We would do that. We would do this.
Agreed, sir.
There are instances where we have abandoned cholecystectomy because it was too frozen and it was a mass of momentum stuck there. We have abandoned it and come back and counseled, re-imaged and gone back.
I think we should also keep in mind the xanthogranulomatosis cholecystitis, because we see quite often these days, we feel it is a carcinoma gallbladder, will be very scary, but it turns out to be xanthogranuloma.
Anand can tell about the recent case.
Recently we have operated 2 patients this now around 10 this way. Our protocol, we follow the protocol, the focal thickening in the fundus of the gallbladder. We did PET scan, the uptake is there. We did our the same thing, radical coli was done with intraorbital biopsy in the lymph section, and the final biopsy results comes out to be
And PET was also positive.
PET was also positive. PET was taking showing the uptake in the fundus.
I don't think you should consider.
Inflamed tissue, your PET may be positive. The inflamed tissue will show it as a PET positive.
We always think the CAGB, treat all the CAGB, what was the pathology comes out after that.
Xanthogranuloma, 30% it is known that it can be a CAGB masquerade.
Yeah. It can happen. The patient pathology have given the xanthogranuloma with some evidence of the malignancy.
Usually comes with diffuse thickening, not focal thickening. Yeah.
Okay, so comes to the next step that we put a scope and find this.
I think you were showing something. You were showing some hand like this.
5 minutes.
Quickly run through the thing. Enough for the day.
ये अभी और चल सकता है
ये तो 1 घंटा और चल सकता है. Show the R4.
ये तो एक दिन पूरा चल सकता है.
एक दिन पूरा चल सकता है. Only show subtotal, I think that will be better problem. We'll discuss.
Yeah, many times it will not be a difficult question. I mean, we should have harmonic scalpel ready, but otherwise, many times the porta will be normal. We will be very scared that this will be. No, I'm talking this liver. I'm sure this you'll have a pre-op diagnosis. You're saying about accidental finding.
Yes, sir.
Yeah, I mean, I think you shouldn't back out.
Usually, but the ultrasound done somewhere outside.
Right.
And that was liver was normal, and we took the scope and find.
Now it is very common.
We didn't repeat ultrasound at your center. Then the situation.
Cholecystectomy in cirrhosis is known to be safe. If the patient was not suspected to be cirrhotic, he is probably a child's age. So it's safe to do a cholecystectomy in such patients. Lab coli.
We actually
present on that lab coli is dangerous in cirrhotic.
Only one point here is that is there a portal hypertension?
Yeah.
If there is a portal hypertension in the cardiology, you will find a lot of veins which are dilated. Then you should have proper energy source. You cannot use monopolar. You will have to have either bipolar or maybe the ligashore or something, which will be better to seal off those thin vessels dilated, because that is very, very important. Otherwise, you might land in trouble.
We have found that problem with extrahepatic portal venous obstruction as opposed to cirrhosis. What we have found is they don't detect that the portal vein is obliterated.
Correct.
They say that everything is normal, perfectly fine. And then you go inside and you can't see in that area, you see multiple blood vessels.
Yeah, in
So you
ESPD
have to
it's
come
very
out.
dangerous.
So the perioperative management would differ, even if it is a child's age cirrhosis. Sometimes after the surgery,
They will go
any
into
surgical
decompensate
stress
it.
will decompensate the patient. So your perioperative management should differ. Maybe the patient may have some coagulopathy in the perioperative period, so you should be ready with your agents. Give perioperative albumin, give some higher antibiotics, because these patients are prone to develop postoperative infections, ascites. So we have to be careful with that.
I think with child A, it's not a big issue, but with the child B, then the risk of decompression.
Even yesterday, I have done some cholecystectomy, have empyema, very angry looking gallbladder, aspirated whole of the pus, done subtotal cholecystectomy, and there was the finding like a small nodule over the liver, and patient have not come out from the anesthesia, taken 1 or 2 days to. Yeah, this can happen. Yeah, yes. Yeah, still you have a problem.
The stress of surgery
It matters.
The stress of surgery matters.
So actually, technically, you can't fold the liver. We have some difficulty in that. It's a hard liver, we cannot fold. And I mean, there are times when we leave a part of the gallbladder wall behind. We don't go, whatever the one is stuck to the liver, we don't dissect. Yeah.
Basically, this leaving behind the wall of the gallbladder behind its cirrhotics. Actually, that was the procedure that was told when we were students. But that has changed. They are now advocating completion cholecystectomy, and they say there is no problem. Only thing is, if you have coagulopathic problems, you have to correct it with FFP and thromboelastography. Because cirrhotics don't necessarily always bleed. The coagulation profile in cirrhotics can be high, but they don't clinically bleed. They tend to be thrombotic, they tend to develop DVT. So that's an important thing to remember about cirrhotics is you can't predict them. They have to be investigated and you have to take decision based on thromboelastography.
So these are few tips. So young colleagues, if you're operating with cirrhotic liver, minimum blood dissection should be done. Use bipolar, harmonic, or ligosure. Protectors should be applied on the body of the gallbladder so it will not injure the fundus because if the bleeding from the GB bed and it's very difficult to manage because there are a lot of collaterals there. And the high risk gallbladder the bed, then do the laparoscopic cholecystectomy type 1 in which the GB bed gallbladder will left. And the hilum is difficult, then you do the type 2. Both are difficult than type 3. These are types of cholecystectomies. So the surgery has done, then the patient of laparoscopy after few days he had bile in the drain.
This for the next JAIPUR surgery. We need to
We need to wind up now.
One last question. When to append?
Sorry?
When to abandon?
I would say that if you are a good surgeon and if in half an hour you have not made any progress, then I think it is time to think and abandon or convert. Half an hour I would give maximum time for trying to dissect and trying to find out your moorings and trying to find out the anatomy. But if there is no progress, probably abandon.
Conversion actually helps.
Generation is better in open.
Sometimes
That's why it's better to convert. Your generation is better in lap poly. Persist is the answer.
In bleeding, open conversion definitely will help.
Yeah.
But yeah, in violent injury, definitely bail out.
Bail out.
Two other situations where I would say,
relatively abandon, I mean, do not, I didn't proceed at all.
Yeah. So two other situations I would add, a relatively young, inexperienced surgeon working alone in a peripheral hospital. One is when it is acute cholecystitis, which you did not suspect pre-op. Then it is better that you come out. You yourself can go in after 6 weeks or 8 weeks. The gallbladder would be much better. Second is suspicion of malignancy. If you now suspect that there is something wrong, it doesn't look like a simple inflamed acute or chronic cholecystitis gallbladder, and you are not competent to do a extended or a radical cholecystectomy, don't do anything. Just bring the omentum, put it there, refer the patient to a place where the patient can be investigated and managed.
One more bailout thing is that in case it is acutely inflamed gallbladder and you're not confident, I think you can do just a cholecystostomy and bail yourself out and then later on go ahead and do the something.
Kanchan, if I can ask a delicate question, you are the new age GA surgeon, born in a laparoscopic era, have been exposed to enough open cholecystectomy.
That is a real question. You have to call somebody.
Unfortunately, I was exposed to many or rather only open
Why that? Okay. And means how many cholecystectomies you do or you assist or you participate?
Just show that R4 line.
The R4 line.
R4.
That is the
U line.
R4U line. That's R4 Govia surface, 4 is segment 4, and this U for umbilical fissure. So you, if the section pain is above that line, then you will be safe. And below that, you will unsafe and injure the vessels.
It's good for the good looking patient and the dissection plane.
Important. Rather than only Rubial sulcus, rather than only looking at Rubial sulcus, I think this R4U line is much more important. You look at Rubial sulcus, you look at segment 4 and then umbilical fissure. So unsafe dissection is below that line and safe dissection is above that line.
I think you can say right. CBD also.
Right,
A vertical line.
Because sometimes the Rubius sulcus is obliterated also. So
Many times, yeah.
stay in the right of the.
Correct. Enough? Yes, that was good. Bus.
Thank you, Danielson. Thank you.
Thank you. Thank you.
We have a tea outside this, and we have a bus for Sun City and Intercontinental, standing in front of the facility. And car from the Sun City to Intercontinental at 7:45 p.m. Please be wait. Thank you.
That's good. Very good. You are in Sun City. 7:45, there will be a vehicle which will bring you to the Intercontinental, the place where we were yesterday. But again, and also. You met him? Yes, 7:45, both of you from Sun City to Intercontinental for the dinner.
Sure. So now that
Yes, now you can go and relax.
पिक्चर तो ले ले नहीं नहीं अरे सुनो
ये लोग ले लेते
हाँ दिनों मिले कि याद कर
is from Tanzania. He's our online student. Surgeon, practice surgeon, and
Doctor, I would like to have your number.
Yes, sir. Sir, I had already messaged you earlier. If I take the time, I will message you.